all for the AIOS YOSI Forum 2023 here today. We'll be starting our sessions with, it's a competitive session, and the first session is called Young Ophthalmologist Retina Case Competition Session. Here we have, before starting in, we'll call up our panelist here. We'll call Dr. Sharath Hegde. Dr. Sharath Hegde is working in ODP and is a dear friend of mine. He's an alumni of LBPI. And Dr. Sharath, if you can come, please. Thank you. Then we have Dr. Shishir Varghese, another friend of mine. He works with me with flash notes, and he's presently working. He's working in Kerala, and he is a past alumni of Coimbatore Arvind Eye Hospitals. Dr. Shishir, if you can please join this dais. And we have Dr. Kaushif Tripathi here. He doesn't actually need any introduction. He has n number of case articles and presentations to his name, and he's a alumni of AIMS Delhi, and he's now working with ESG Kolkata. Dr. Kaushik, if you can please join the dais. Thank you. So we have for the present session we have 6 cases, and the thing is we'll have it's a 85 minutes long session. So we have divided it into, like, per case 6 minutes of presentations. We'll have 6 minutes of presentation and 6 minutes of discussion. It's a competitive session, so please keep it in time so that we can have more discussions, and accordingly we can give you marks accordingly to it. If you can write. So we'll call upon our first presenter. We have Dr. Monisha Apte. She'll be presenting today. The topic for her presentation is double trouble. Dr. Monisha.
Good morning, everyone. I'm Dr. Monisha. Thank you, Yosi, for giving me this amazing opportunity to present this case, which was a double trouble on its own. So to begin with the case history, a 60-year-old lady, she presented with sudden onset painless diminution of vision in her right eye since 20 days. The patient also complained of fullness around her lids, more so in the left eye since 1.5 months. She was a diabetic under treatment with poor control. The patient does not give any other complaints such as cough, weight loss, fever, diarrhea, fatigue, or malaise. The patient also does not give any history of trauma or any other systemic illness. Examination of the eyes showed best corrected visual acuity of hand movements with a near vision of less than N36 in the right eye, whereas the left eye vision was 612 with a near vision of N8. Ocular motility was full, free, and painless in all directions. Examination of the adnexa showed mild fullness of right eye upper lid on inspection. However, it was normal on palpation. Whereas in the left eye, inspection showed fullness of the upper lids, and palpation showed superior and superonasal multiple non-tender firm nodular swellings. Pupillary reaction was ill-sustained in the right eye, whereas it was normal size reacting to light in the left eye. Anterior segment examination was normal in both eyes with a normal IOP, and the anterior vitreous phase was clear in both eyes. This is how the right eye appeared. Some amount of fullness was seen, but palpation was normal, whereas the left eye showed significant fullness of the right eye upper lid with a firm non-tender nodular swelling on palpation. Fundus examination of the right eye showed presence of a clear media with significant disc edema, with blurring of disc margins, with splinter hemorrhages superiorly and inferotemporally, and tortuosity of blood vessels with dull foveal reflex and an attached retina. Examination of the left eye was normal, just some RPE changes was noted temporal to the macula. OCT showed presence of disc edema with peripapillary subretinal fluid extending up to the macula. B-scan also showed elevation of the optic nerve head with some amount of fluid around the peripapillary region. Owing to these clinical findings, we thoroughly investigated the patient from top to toe. Just to highlight some of the important investigations, MAN2 test was negative, serum ACE levels were high, around 65 units per liter, HbA1c was 12.9, suggestive of poor control of diabetes. We also did a tissue biopsy from the nodular lesion and sent for histopathological evaluation. All other radiological investigations were normal. We also did a whole body CT for this patient, which was normal. The histopathology of the lid lesion did show fibrofatty tissue with epithelioid non-caseating granulomas. Langhans giant cells were seen with dense lymphocytic infiltrate around the granulomas, sparing the nerve fiber bundles suggestive of chronic inflammation. Also, it was negative for AFB, pass, and permeating pattern was seen on reticulin stain. So just to briefly summarize, 60-year-old female, sudden painless diminution of vision in right eye since 20 days, involvement of both eyes, where the right eye presented with disc edema and the left eye had a left upper eyelid lesion. Serum ACE levels were raised with all other blood investigations being normal. Histopathology suggestive of chronic inflammation, radioimaging being normal, and a poorly controlled diabetes. We came to a diagnosis of ocular sarcoid in both eyes. So we started her on systemic steroids, 1 milligram per kg body weight, and oral methotrexate was started at a dose of 20 milligram per week, along with folic acid supplementation. So at presentation, the patient had hand movements in right eye and 612 in the left eye. Post 1 month of oral steroids and oral methotrexate, the disc edema did reduce subsequently, but then it, however, landed in optic atrophy, leading to disc pallor and attenuation of blood vessels. The OCT also showed reduction in the disc swelling. The left eye upper lid was also showed reduction in the lid edema, and the lesions also resolved on treatment. So even after 3 months, the patient was maintained on oral methotrexate and oral steroids. The patient had a stable vision in the right eye and left eye since 1 month, and there was no recurrence or new inflammation anywhere in the eye. Even after a year, the patient was on immunomodulatory therapy and she had no signs of recurrence. So what was interesting in this case? First of all, there was a bilateral involvement and with a different presentation, where the optic nerve head was involved in the right eye and the lid involvement was seen in the left eye. This is a case of definite ocular sarcoid as per the diagnostic criteria of International Workshop of Ocular Sarcoid, and it's a purely ocular sarcoid not involving the lungs. And it is a rare presentation. We all know that optic nerve head does get involved in ocular sarcoidosis, but the incidence is 1 to 7% of ocular sarcoid cases. Also, there was no recurrence and it completely resolved on immunosuppressive therapy. So just to conclude, my aim was to present this rare case of bilateral ocular sarcoid presenting differently in each eye without pulmonary involvement, and a point to highlight is that extensive systemic workup is needed to rule out secondary metastasis and CNS involvement. Thank you.
Excellent case, Dr. Monisha, and we'll come to our panelist here. We'll start with Dr. Shishir, if we can ask some questions and we can have a discussion after that. Yeah, Dr. Shishir, over to you.
Yeah, very nice case, extensively, very nicely worked up. If you look at only the ophthalmic features, probably won't hint at, it doesn't look like a proper sarcoid, but only after the workup.
Yes.
And the other thing I wanted to know is how did you give steroids and get the systemic sugars under control? How
Yes,
did you
sir.
manage to?
Basically, she was also, we started her on insulin as well because the patient was maintained only on oral hypoglycemic drugs, but then the HbA1c was 12.9 and she was not at all regular on treatment. So that is when we sent her to a diabetologist and he started her on insulin, and we kept a strict blood sugar control while the oral steroids were on.
Over to you, Dr. Kaushik.
My question would be, what was the projection of rays in the right eye?
Sorry, sir.
Right eye, PR, yeah.
Projection of rays was accurate, sir.
And RAPD?
RAPD, it was an ill-sustained reaction, sir.
How do you explain the other eye's findings? Other eye had some changes in the macula.
Sir, it had some RP changes. We had done an OCT for that patient. So OCT only showed some RP undulations, but no other significant findings were seen.
What are the differences for the other left eye? If there was no lead involvement, just fundus features in both eyes, there was no lead involvement. So what would be your differential diagnosis in such a case?
There was no lid involved. I mean,
If
yeah.
it is a hypothetical case, one eye has this disc edema like thing and other eye is having some RP changes in the fovea, there is no lead involvement. So what would be the differentials?
Yeah. The first thing is that I would think about some optic nerve lesions such as meningioma, and I would evaluate the patient based on optic nerve head lesions specifically. So I would go
other
ahead
things
with.
like there is optic granuloma, no, in the right eye. This
Right.
is not a truly papilledema like swelling. This is like a mass
It's a
which
mass
is there inside the
granule.
disc.
Yes.
So my question is, what are the differences when you see like disc is very much elevated and there is exudation around it, and it is not papilledema like kind of swelling. That is, disc is like there is some granuloma or mass. What could be the differences?
Basically differential for infiltrative disc.
Infiltrative disc. Yeah. Yes.
Like you investigated, no? Well, I want to know what are the specific differential diagnoses you thought of that you wanted to exclude by doing tests.
First, we did an MRI of the optic nerve head, and so that is how the tumors were ruled out in this case. So
And you did CBC also, no?
yeah, peripheral blood smear and everything
What
was
does that
normal.
rule out?
So basically leukemia and
Though rare, but this leukemia can also be cause of.
yeah.
Dr. Sharad, please.
How will you differentiate this with the ischemic optic neuropathy? So what are investigations you will prefer, and you can say this is say granuloma is not a ischemic optic neuropathy, because the patient is diabetic, she's more than 50 years. So she may have ischemic optic neuropathy because you don't know the other eye also had a some amount of ischemia which developed later. So usually how can you differentiate with investigations? What are the findings which will go to an ischemic optic neuropathy and which will go for granuloma?
Because if it's a systemic optic neuropathy, the patient will specifically have a pallid disc edema. So yeah.
When the acute thing is there, what investigations will help you to differentiate? So you do multiple investigations, like OCT, FA,
Yeah.
what investigations will help you to differentiate?
Field testing would have helped us in this regard, but the vision was hand movement. Yeah, the hand movement
This
was
is
it.
important for the other features also very much. So what are the features you see in OCT and FA when you do, which help you to differentiate can you value the body in the issue of it? Just carry on.
Presentation, please.
Yeah.
Presentation, first presentation.
Yes. Just when you see this first picture, the first photograph, there is a definitely like the infiltrative, when you see there is a slight elevation which is there, which is not commonly seen in ischemic optic neuropathy. And the other important feature is you can able to see there is a branch and an artery occlusion also. Inferiorly, you can see
Yes.
the whitish lesion which is there. So there is something which is complexing in that area. Even in ischemic optic neuropathy also we can see. But that is one of the important features. That's the reason the patient, there is artery occlusion also. So which multiple inclusion we should rule out other conditions. That's the reason the patient has much less decrease of the vision, which can be the, even in the late phase when you see there is attenuation of the artery which is there in that area. That one point I wanted to highlight.
Thank you, Dr. Monisha. So to sum it up, we had this patient. So if you have a disc edema, one should know whether it is an infiltrative cause due to local infection or it is due to any systemic. And there we can actually do FA at times, and or doing an autofluorescence also to rule out brucins would help. Once that is out, doing an FA and what Dr. Sharad told us about the infiltrative part, that can have differentials for that. We'll have the next case now, and if we have time which permits later on, we can ask our panels to give an overall idea of what we discussed. The next presentation would be by Dr. Yashi Gupta. She'll be speaking about systemic sympathetic ophthalmitis after ocular burns. All the best, Dr. Yashi.
Thank you, sir.
In
Good
the
morning, respected seniors and my fellow colleagues. I am Dr. Yashi Gupta, and I'll be presenting a rare case of sympathetic ophthalmia following chemical ocular burns. Sir, it's not moving forward.
Hello, slides are not moving, please.
A 47-year-old Indian male presented to our retina clinic with complaints of diminution of vision in the right eye for the past 1 week, which was sudden in onset, painless, and associated with metamorphopsia. There was no history of photophobia, floaters, flashes, use of high-powered glasses, any similar episodes in the past, or any history of diabetes or hypertension in the patient. On retrospective history taking, the patient revealed to have had severe ocular chemical burns to the left eye with toilet cleaners 6 months ago, which was treated with tenoplasty, amniotic membrane grafting with temporary tarsorrhaphy at our center. However, to our dismay, the left eye developed corneal opacification and conjunctivalization. On examining the patient, the general physical examination and the systemic evaluation of the patient was found to be within normal limits. On examining the patient, the best corrected visual acuity of 6/18 was present in the right eye, and a perception of light rays positive PR accurate visual acuity in the left eye at presentation. The eyebrows and eyelids of the right eye were within normal limits, while the left eye revealed a few trichytic lashes with a thickened tarsus. The extraocular movements of the right eye were full and free, while the left eye were restricted. The anterior segment examination of the right eye was within normal limits, while the left eye revealed a symblepharon both in the upper and the lower fornix, with a completely opaque conjunctivalized cornea. On evaluating the fundus of the right eye, choroidal folds with multiple hypopigmented lesions were seen. This is the fundus photograph of the right eye of the patient, showing multiple pockets of serous retinal detachments and choroidal folds at the posterior pole. This is the fundus fluorescein angiogram, showing multifocal pinpoint areas of hypo and hypofluorescence over the posterior pole with late dye pooling in the areas of exudative detachment. The OCT macula of the patient revealed a diffuse choroidal thickening with subretinal fluid and retinal pigment epithelium undulations. The OCT angiogram revealed a distorted vasculature both at the superficial and the deep capillary plexus level and choriocapillaris flow voids suggestive of ischemia. The ultrasound B scan of the right eye was anechoic, while the left eye showed a thickened choroid with vitritis. The following systemic investigations were done for the patient and were found to be within normal limits. The following differentials were arrived at: sympathetic ophthalmia and Vogt-Koyanagi-Harada disease being the top two. A provisional diagnosis of right eye sympathetic ophthalmia was made based on history, clinical examination, and ocular findings. The patient was thus started on IV methylprednisolone pulse therapy for 5 days, followed by high-dose oral steroids after complete systemic evaluation. However, on tapering the steroids to 50 mg, there was a relapse of posterior segment inflammation. A multidisciplinary approach was thus adopted in view of uncontrolled blood sugars and visual deterioration. Azathioprine, a steroid-sparing immunomodulator, was thus started with tapering steroid doses. After 2 months of treatment, the vision of the patient stabilized to 6/12 with no signs of ocular inflammation. Treatment course and follow-up: the patient gradually responded to the treatment with resolution of exudative detachments, as can be seen on the OCT image. The best corrected visual acuity being 6/9 on azathioprine 100 mg once a day at 1 year of follow-up. Thus, sympathetic ophthalmia presents as a bilateral diffuse granulomatous uveitis, though the presentation can be quite variable, most commonly occurring after penetrating ocular traumas or intraocular surgery. So far, there's been only one case report of sympathetic ophthalmia reported after chemical ocular burns, but the exciting eye was found to have a corneal perforation. And recently, in a study conducted by Zhang et al., only 1 out of 22 cases of sympathetic ophthalmia was caused by alkali burns from among 9,000 patients with globe injury, thus pointing towards its rarity. Thus, diagnosis and management of sympathetic ophthalmia is often challenging, and we need to keep the important risk factors in mind. Development of sympathetic ophthalmia in non-penetrating trauma is though very uncommon, but the review of literature shows sympathetic ophthalmia after hyphema due to a non-penetrating trauma, after injury to an intact globe following mechanical fall, or a blunt injury to a tricycle eye. Thus, to conclude, in our case, there was no ocular perforation, so we hypothesized that the severe chemical burn had led to the ischemia, which led to a release of pro-inflammatory mediators, hence the sensitization. Thus, this is an uncommon case of sympathetic ophthalmia in an intact globe following chemical burns. Hence, sympathetic ophthalmia may also occur after non-penetrating trauma, and thus we need to keep a high index of suspicion and regular monitoring of such patients to facilitate early recognition and treatment, hence reducing the visual morbidity. Thank you.
Very good presentation, Dr. Yashi, and very nicely managed case here. So over to the panelist here. We'll start with Dr. Sharat. Can you ask if you have any?
Nice case. Very
Thank
rare
you, sir.
condition which we see in the ophthalmia. What are things I think perforation is the most important, especially after the chemical injury. There may be small perforations linked to the iris, this thing, but as I told, there are certain case reports which they say without any perforation we can see through the ophthalmia. So my just one small question is, why did you decide AIOS YOSI?
Sir, after the blood sugar of the patients got deranged on high-dose oral steroids, we sought a medicine referral, and in consultation with the rheumatologist, azathioprine was started from our LNJP department.
Why not Peter Fixate or
Sir, because that was available in our hospital supply and patient was non-affording.
Excellent case, Dr. Yashi. My question would be, like, what is the dose of IVM?
So 1.5 milligram per kg a day for 5 days.
So if a person has 60 kg weight, then you will give 90 milligram.
Sir, can you please?
A person has, you are saying the dose is 1.5 milligram per kg of IV methylprednisolone. Then a person has a weight of 60 kilogram.
Yes, sir.
Then the dose would be 90 milligram of IVM.
Sir, to combat the first inflammatory ride, we need to give a high dose of.
No, that is not my question. My question is, what is the standard dose of methylprednisolone, IV methylprednisolone pulse therapy?
Sir, it's 1 milligram per kg of body weight.
what sir is asking is what you are saying is about oral steroids, 1 milligram per kg body weight, what we give. What he is asking is pulse therapy, what we give when the patient comes.
So 1 gram per kg body weight of the patient.
1 ग्राम में 60 ग्राम, तो IBMP जो वायल है वो 500 मिलीग्राम या 100 ग्राम में आता है, तो 60 ग्राम कहाँ से लाओगे आप? बेसिकली जो डोज लिखा है वो गलत लिखा हुआ है. इट
Okay,
इज
sir.
1 gram per dose. And my question would be, how would you differentiate CSR versus sympathetic ophthalmia on OCT?
Sir, in sympathetic ophthalmia, bacillary layer detachment can be seen, and RP undulations will also be present.
Versus CSCR?
Central serous chorioretinopathy, sir.
एक बार पढ़ लेना CSCR versus sympathetic ophthalmia लीकेज और ये ठीक है, that's all.
Can you, Dr. Kaushik, you can tell rather
Yes,
than
actually in CSCR the RP will be straight, it will not be undulating or curved, and there will be serous PED. So if you are finding serous PED in a case of bilateral exudative RT, or there are multiple points of exudative RT and there is fibrin but there are PEDs. If there is PED, then most likely this is due to CSCR. Do not give steroid, oral steroid or systemic steroid in that case. It will most likely lead to exudative retinal detachment in that case. And also the leaks in CSCR are either pinpoint leaks. Pinpoint means in the early phase and late phase you compare, the point is increasing in brightness and size. And also there may be smokestack leak. Sometimes in chronic cases there will be diffuse leak also. But pinpoint leaks, typical pinpoint leaks and staining of the detachment is usually not seen in CSCR. Also look at the disc. Here if you look at the disc is staining. That also gives a clue that this is some inflammatory pathology. In this case there was no AC cells. Yes, no AC cells can be there in cases with sympathetic ophthalmia. Some cases may present with posterior segment manifestations only. PGI group has a nice article on that.
Multimodal imaging.
Nice case, very well managed. Just one point to add. Any scleral thinning in the eye with the injury? Because that's how usually the uveal tissue gets access to the conjunctival space and that causes the inflammatory
Sir, there was no obvious perforation, but we cannot rule out any micro perforations that might have been present after the chemical burn.
Okay, fine.
Thank you, sir.
Thank you, Dr. Yashi, and it was a beautiful presentation. So the take home would be basically to do an FA in these sort of patients, and it's definitely to see the other eye, because at times we don't actually look the other eye and we are treating the eye which is actually having the problem. So observing the other eye, looking for KPs and looking for the fundus and ruling out all a condition of sympathetic ophthalmia is a must. And FFA would actually be a clincher. OCT subtle changes what Dr. Kaushik has described. So we'll come to the next presentation by Dr. Kshitij here. He'll be discussing about CNV in a VKH patient. By the time he starts, before that, I would want to call Dr. Chen, if he can please join us on the dais. He's our international faculty here, and he'll be speaking in the international session of AIOS. So Dr. Po Chen, if you can please join us on the dais. Yeah, please. Thank you. Thank you so much. Over to Dr. Kshitij, if you can please.
Good morning, everybody. I am Dr. Kshitij. I am practicing as a VR surgeon in Bareilly. Today I shall be discussing about a case of CNVM and Vogt-Koyanagi-Harada disease. In the interest of time, I will just quickly run through the general features of VKH. It's a bilateral granulomatous panuveitis, which may or may not have extraocular manifestations, generally manifesting in females in the 2nd to 5th decade and more common in Asians and Hispanics. And it's a T-cell mediated autoimmune reaction against melanocytes, melanin, and RPE. Presents in 4 stages. The first one is the prodromal stage, where the patient presents with headaches, fever, orbital pain, nausea, dizziness, and light sensitivity. There could be neurological and auditory manifestations, and they generally last for 3 to 5 days. This is followed by uveitic stage, where there's a blurred visual acuity in both the eyes, which may be asymmetric. There can be presence of anterior chamber inflammation with hyperemia and edema of the optic disc with multiple serous retinal detachments. Followed by the chronic stage, where there is the characteristic sunset glow fundus because of depigmentation of choroid, perilimbal vitiligo called as Segura's sign, vitiligo, poliosis, and alopecia. This is followed by the recurrent stage, where could be acute exacerbations of anterior uveitis, and this is where the late complications happen. These could be cataract, glaucoma, choroidal neovascularization, which has been reported in 2 to 15% cases in literature, subretinal fibrosis, choroidal atrophy, posterior synechiae, optic atrophy. Now, without any ado, I would like to walk you through the case by means of an animated explainer video.
Hello, hope you all are doing well. This is Dr. Sharma. He is gonna share an intriguing case with you. So let's get going. A 36-year-old female presented to us with complaints of diminution of vision in both the eyes for past 1 day. Visual loss was preceded by headache for 2 to 3 days. Her best corrected vision in both the eyes was finger counting at 1 meter. Anterior segment in both the eyes had granulomatous inflammation. Her fundus picture looked like this. Bilateral optic disc hyperemia with blurry margins. Multiple pockets of subretinal fluid. And ILM folds over the posterior pole. OCT of the right eye showed undulating choroid. Thickened RPE. Serous retinal fluid. And ILM folds. OCT of the left eye had similar features along with subretinal septae and hyperreflective dots within the SRF because of fibrin. Our provisional diagnosis was Vogt-Koyanagi-Harada disease, and patient was started on intravenous methylprednisolone 1 gram for 3 days, followed by oral steroids along with topical steroids. The patient responded very well, and 1 week later her vision was 6/9 in both the eyes. The disc margins were now sharp. SRF pockets had resolved and the ILM folds had disappeared. OCT showed restoration of normal retinal architecture in the right eye, while subtle irregularities in the ellipsoid zone were noted in the left eye. The patient was advised gradual tapering of oral prednisolone, and she was started on azathioprine 50 mg TDS. She continued doing well and was 6 by 6 in both the eyes 2 months later. The patient was lost to follow up for the next 6 months. She reported 6 months later with diminution of vision in the left eye for past 15 days. She had discontinued azathioprine after taking it for some time, without the doctor's recommendation. Both eyes had developed sunset glow fundus, while the left eye showed subretinal hemorrhage and fluid at fovea and papillomacular bundle. While the right eye OCT was normal, the left eye OCT showed subretinal hyperreflective material, and subretinal and intraretinal fluid. She had developed CNVM as a late complication of VKH and was given intravitreal ranibizumab for the same. She was followed up 1 month after the injection and showed resolving CNVM. Her vision had improved to 660 and OCT showed regressing SRAM along with resolved SRF and intraretinal fluid. Considering the good response after the first dose, patient was given a second dose of ranibizumab. Patient returned 2 months later with a BCVA of 624 parts. OCT showed regressing SRAM but re-emergence of SRF and IRF pockets. A third dose of ranibizumab was given. A month later after the third dose, patient is maintaining 6.6 in the right eye and 624 parts in the left eye. Left eye OCT showed resolved SRF and IRF. Patient did not want to get injected further for the time being. We are maintaining her on tapering dose of azathioprine, and we have advised her to not to miss the follow-up visits. CNVM in VKH disease has rare incidence. We would love to know how you would have liked to manage this case. Thank you for your kind attention. Goodbye.
The pathogenesis of CNVM in VKH is there is an underlying chronic inflammation which destroys the Brooks membrane, which liberates angiogenic factors, thereby increasing the VEGF levels, which leads to the formation of CNVM. The literature reports very few instances of peripapillary CNVM, which occurs very rarely and is least reported. We confirmed the presence of CNVM by means of FFA, which showed early hyperfluorescence followed by late leakage. The management protocol is you give anti-VEGF along with corticosteroids, because corticosteroids, they maintain the vascular permeability and decrease the chances of bleeding. iSpy is a platform where we develop animated explainer videos for PGs and fellows. So those who are willing could check out the other videos on our platform. Thank you so much.
Thank you, Dr. Sitich, and it was a very nice presentation and nicely managed case. We'll ask our panelists to ask questions if there are any. Over to you, Dr. Shashir, if you can.
A very nice, nicely managed case also.
Thank you, sir.
Little scary to start azathioprine and then you have the patient lost to follow up. Why not methotrexate or?
Sir, in our experience, we feel that the response of azathioprine is better in cases where there is posterior uveitis. So in our line of management, we use methotrexate for those cases which have anterior recurrent uveitis, and for posterior uveitis, our choice of drug is azathioprine.
The other thing is CNVM recurrence means increase in the inflammation which is happening. So why not give also Tricot or an Ozodex? Control the inflammation. You started the steroids, that's correct. But
yeah, that is definitely a choice. Anti-VEGF injections along with intravitreal triamcinolone, that is definitely a choice.
Even a PSD.
Yeah, it works well and it has been reported in literature.
Very nicely managed case.
Thank you, sir.
My question would be how do you follow up a patient with choroidal OCT? Is a case with sympathetic ophthalmia, or the role of enhanced depth imaging in sympathetic ophthalmia or VKH?
I didn't quite get you. Could you please?
Role of EDI, just OCT. How can you monitor the disease with OCT?
The choroidal thickness on serial follow-ups and along with the undulating RP and presence of SRF and IRF would let us know the progression of the disease and would help us tailor the further management.
What happens? Like in activity, what do you see, and in active disease, what is seen?
The active disease would show the presence of subretinal fluid along with intraretinal fluid, and the choroidal thickness would also decrease once the disease is under the process of remission.
Very nice case.
Thank you, sir.
The last FI what I saw, I just saw there are still that is inflammation is still present. I feel like as she asked me adding a corticosteroid maybe the resilience or she did there I think it requires more immunosuppression. And the subrectal bleed was still present. I feel that we stopped the injection.
Yeah, so far the patient has had 5 injections, but somehow this seems to be recalcitrant. This amount of the minimal shrum which is present, it's perhaps not going away, and due to financial constraints, the patient doesn't really follow up with the injections every time she's advised.
The more commonly see any uveitis, especially multifocal choroiditis, we see pericardial fibrosis. In the case of multifocal choroiditis, we see more commonly peripapillary fibrosis and CMA commonly in uveitis. Leakage is rare, but because there is because patients stop the medication, the recurrent inflammation has caused the peripapillary CMA.
It is.
So, how would you actually, if you had not had a CNVM or for per se, how would you actually go about treating the patient or counseling the patient for a year? Because patients of VKH, if they are not treated or but partially treated, this is what actually
Yes,
helps.
so my line of management for all VKH patients is intravenous methylprednisolone for 3 days, followed by oral prednisolone, 1 milligram per kg body weight in tapering doses. And at the same time, I start azathioprine, 50 milligram TDS. And I tend to counsel them that the medication would go along for at least 6 months or so, because in my experience, that lessens the chances of late onset complications.
The beginning itself, you can add PST immediately after the IV methylprednisolone. Give both eyes injection PST. Along with that, you start the oral steroids.
All right.
That is the other option.
Fine, I would definitely try it in some other patient.
Dr. Chen, I have to ask anything.
Did you do any fluorescent angiography in the baseline?
Angiography was not done at the initial presentation because the diagnosis was spot on and we made the diagnosis on clinical basis of the fundus picture. But once she had developed CNVM, we do have angiography pictures and I have included them in my presentation.
Thank you. Yeah, because we had a painful experience before. On the OCT is a very typical BKH patient, but in the end it's a lymphoma patient. That's our experience. So
Quite right.
it won't be so typical on fluorescent angiography.
Thank you, Dr. Po, and thank you, Dr. Sitish. We'll have our next presenter here, Dr. Sindhuja. She'll be speaking about macular pucker following cryotherapy. Dr. Sindhuja, if you can please join us.
Good morning, everyone. I'm going to present a case of endogenous endophthalmitis where cryotherapy was done for the infective focus. The case was 27 years old male patient, complaints of diminution of vision in both eyes for the past 15 days. Diminution of vision was gradual, progressive and painless in nature. Patient also had history of fever 2 weeks back before presentation, and past history, the patient had a history of CA colon for which he underwent hemicolectomy 2 months ago. Anterior segment examination, vision in right eye was 1/60 and left eye hand movements close to face with PR accurate in all quadrants. IOP was 10 mmHg in both eyes. Cornea was clear and few pigments was present on endothelium, and AC cells was 4+. Lens was clear and there was RL cells. Posterior segment examination, right eye the media haze was grade 3. And also we could see cotton ball exudates in vitreous cavity, and there was a focus of infection in right eye supratemporal arcade, and left eye also the media was haze was grade 3. So we did a ultrasound and we could see mild to moderate amplitude spikes. There was no RD and PVD posterior vitreal detachment was present in both eyes. A diagnosis was made as endogenous endophthalmitis and likely fungal. Systemic workup was done. Blood culture was negative. Urine culture was positive for E. coli. Chest X-ray, USG abdomen was normal, and hemogram, KFT, LFT was normal. So management. First, in the left eye vision was hand movements close to face, so we did vitreous biopsy and pars plana vitrectomy along with injection of antibiotics and antifungals in left eye. And after that, the patient also received intravitreal antibiotics and antifungals, 48 hours interval twice, and after 1 week once more. So 3 times the patient was given injection. And right eye, initially vitreous biopsy and intravitreal antibiotics and antifungals were given, and after 48 hours we didn't see any resolution. So the right eye also was posted surgery. We planned surgery, and PPV was done along with intravitreal injection, and intravitreal antibiotic was given after 1 week. The vitreous biopsy and staining report was negative in both eyes. Along with that, the patient was also given IV antifungal amphotericin B. So this is the surgical video of the right eye. So vitrectomy was done, and vitreous shaving was done around the infective focus. Then cryotherapy was done. It was in the supratemporal arcade. So here cryotherapy was done. And FAX was done. This is the left eye. We could see the infective focus was there at the macula, and this is the post-op 5 weeks left eye image. This is the right eye where we did cryo of infective foci at superior arcade, and at 5 weeks we could initially the patient was responding and vision was good. At 5 weeks, we could see a macula pucker developing at the cryo site. So this is the vision. Right eye, initially the vision was 1/60. At 3 weeks, the patient gained vision of 3/60, but after formation of pucker, it dropped to 1/60. And left eye, the initial vision, hand movements close to face, and final vision was 6/60. So the patient was planned for macula pucker release, but patient was not systemically stable for surgery. So in one literature, we saw in a recalcitrant endophthalmitis, cryo was done at the infective focus. So conclusion, cryotherapy leads to resolution of endophthalmitis, but it should be avoided near the posterior pole. Thank you.
Thank you, Dr. Sindhuja. It was a very interesting case and a lot of discussions we can have it here. We'll start with Dr. Sharath here. I think the last slide which you showed, he was one of the, one of the authors of the case. So what to do, Dr. Sharath, and what was your experience, and can you put some more light on it?
Very nice case. The thing is, retinitis lesion which was there looks very much posterior to doing cryo. So what the cases what you have published in these cases are usually which are there very close to the aura. Because the main technique of why we do a cryo is mainly something called double freeze-thaw technique, like how you do for any tumors, how we do and kill the cells. Similarly, here we want to kill the fungal cells, which are very resistant to this thing, because most of the drugs what we have is fungi, static, not fungicide, other than amphotericin B what we are using. So this double freeze-thaw technique when we do, it kills the fungal cells. And usually we do it in the periphery. What we have published the cases which are done in the peripheral retina, which is there, and they very nicely resolve. Your case also nicely resolved, well treated. But I feel to do a cryo, it was more posterior. And any cryo was inflammation and ER formation, it has to be happen. Pathogenesis is like that to happen in ER formation. So my question is, when will you repeat the interventional antibiotics?
Sir, we'll do surgery, and after 48 hours we'll see the result. In this case, like generally, after 48 hours we'll see the resolution whether it's resolving or not, and we can repeat. Usually we can repeat twice after.
It depends on the pharmacokinetics of the antibiotics actually. So amphotericin B and all are like very usually we repeat it after a week, or we have to give a half dose of amphotericin B because it is lot of toxicity. Voriconazole and all can be repeated after 24 hours. vancomycin, ceftazidime can be repeated by 48 days.
Dr. Kaushik, if you want to ask.
My question is, how did you reach so posterior with cryo? It is very difficult without peritoneum.
Yes, sir. Usual peritomy to be done, but without peritomy also, we have in this case, so we didn't do peritomy, and I could reach it till there.
And was oil used, silicone oil?
So silicone oil was not used in this. So there was not much. We could clear almost all. Vitrectomy could be done. There was not much exudate, so we didn't inject oil in this.
Dr. Shishir?
Yeah, very nice case. My only thing is your last slide, you have written cryotherapy helps in resolving end of. I think the take home message should be not cryo, but timely pars plana vitrectomy along with intravitreal antibiotics helps in resolution. Cryo is like an added adjuvant.
Dr. Chen, if you want to ask anything.
Do you routinely use triamcinolone to stem the because sometimes there's some vitreous cortex remnant on the retina surface. It's very thin layer. If you sometimes even after PVD, you can have the remnants on the retina. So if you don't remove it, sometimes you get severe pucker after vitrectomy.
Yes, sir. But usually in endophthalmitis case, we should not try to induce PVD that much. But in this case, already it was there, and it's a case of fungal endophthalmitis. So tricot we didn't use tricot.
Another thing is that cryo is not usually cryo is very unusual in such case, and this was the case reported if there was recurrent
Recalcitrant.
This is I think something unusual. You can try to publish it also because this is unusual, but reviewers will have many comments on this because this is very posterior, and even cryo can itself, if you freeze it very really, it can reach macula also, and there will be macular scar. It was very near to the posterior.
In the same lines, I wanted to ask the panelists also, like, how do you actually go about cryoing this sort of a lesion? Whether you go all around it or just over since this is more posterior, so we can say that we are just touching it on the lesion. But if it is more anterior, how would you actually go about? Whether you go doing the way we do it in a RD case where we go all around it, or you just go over the lesion and do a cryo, Dr. Sharan?
Yeah, I guess this is more posterior to go for a cryo actually. Ideally, as I told you before, it's just like you have to do a cryo over the lesion, which is completely you have to cover, as you do for any tumor. You have to keep it over the lesion, over the fungus infection or the retinitis lesion, whatever is there, and you have to do double freeze thaw technique. Yes, you have to keep it for 60 seconds, leave it for 15 seconds, let it defreeze, then again you have to freeze it for 60 seconds. So that you should ice thawing what is should cover fully the lesion. Usually what we need is like that in the anterior side.
Thank you, Dr. Sindhuja. It was very nice to have you here. And we'll have the next presentation here by Dr. Dipanshu. He'll be talking about circumscribed choroidal hemangioma treated with anti-VEGF and focal laser. Over to you, Dr. Dipanshu.
Thank you. At the outset, I would like to thank YOSI for giving me this platform to speak upon. I'll be presenting two cases. My first case is of a 37-year-old gentleman who had complaints of diminution of vision since 10 days in his left eye. His best corrected visual acuity in the left eye was 6/18, and we could note some fluid pocket temporal to the disc, and which was confirmed upon doing OCT. As you can see, the fluid was starting from the disc margin and approaching fovea. At this juncture, actually, I tried looking for any disc anomaly, but I could not find any for the fluid. And there was no other complaint than patient being a type A personality. At this point, I diagnosed this patient as CSCR and asked him to review after 6 weeks. But to my surprise, he followed up within 2 weeks only with further deterioration of vision, and fluid had almost increased 3 times. So I tried looking more carefully, thinking that I had made an incorrect diagnosis, and in fact I was incorrect. And there was a hypopigmented patch which was almost 2 disc diameter in size in the superior nasal quadrant, and there was OCT through the lesion showed choroidal elevation with subretinal fluid. When we did a B scan, the B scan showed a low lesion height on superior to the disc. When we did an FFA, we could see that there was hyperfluorescence which was seen in all the phases of angiogram. So a middle-aged man with choroidal elevation with subretinal fluid showing tumor height on B scan with hyperfluorescence presented throughout all the phases of angiogram. We diagnosed this case as extramacular choroidal hemangioma with secondary subretinal fluid. With available treatment modalities, we advise the patient to undergo intravitreal anti-VEGF or bevacizumab followed by laser photocoagulation. This is follow-up 3 weeks post laser, post combined management of injection and laser. As you can see, the laser marks on and around the lesion, and the fluid over the lesion had also resolved, and you can see there is slight decrease in the choroidal elevation as well. If we compare the macula, there was complete near resolution of subretinal fluid at the posterior pole. So this patient has been following up with in past for 6 months now, and there has been no episode of recurrence. My second case is of a 47-year-old male who had complaints of diminution of vision in the left eye since 1 month. If you look at the best corrected visual acuity, it was 6/6 with myopic correction, and in the left eye it was 6/9 with hyperopic correction. We looked at the fundus. There was a orangish red subretinal lesion seen, which was within the arcade of 2 disc diameter size and approaching fovea. When we did an OCT through the lesion, we could see a similar choroidal elevation with RP undulations, and there was also subretinal fluid in this case. B scan through the lesion showed medium to high echo-reflectivity, and further when we did angiography, we could see similar pattern of hyperfluorescence and late staining of the lesion. So similar pattern was seen. There was a orangish lesion with choroidal elevation on OCT and hyperfluorescence with medium to high reflectivity on B scan. So we diagnosed this patient again as circumscribed choroidal hemangioma, and with the treatment options available at our center, we planned for intravitreal bevacizumab followed by laser. This is post 2 anti-VEGF. You can see visual acuity has not increased. The size of the lesion compared to the first visit has also remained the same, as well as the subretinal fluid has not very well responded to anti-VEGF. At this point, we asked the patient we advise the patient that he should go further for further intravitreal injections, thinking that there might be reduction of fluid, but the patient was not very keen for it. We also advise the patient if he wants to go to other higher centers, but due to financial constraint, he was not very keen for it, and since he did not get very good results out of the 2 injections, he did not come for further follow-up. So I would like to conclude by saying that PDT remains the gold standard in these in this scenario in cases of choroidal hemangioma, but due to unavailability of the PDT cannot be, it's out of question right now. Next important is transpupillary thermotherapy, but that was not available in our region. Then there are then the literature also suggests a use of anti-VEGF, where people have shown cases where the fluid has resolved with use of monotherapy as well as in combination with laser photocoagulation. Intravitreal anti-VEGF has shown moderate amount of efficacy in these cases, and when the lesion is at the macula in times of unavailability of PDT, the treatment remains a dilemma. Thank you.
Thank you, Dr. Dipanshu. Very interesting cases, since we don't have PDT now as a treatment modality in India for treating these sort of lesions. So, I would like to start with Dr. Shishir, your take on this, and if you want to ask anything.
Yeah, 2 cases, very nice case. One presenting extrafoveally and one athrophobia. So you said you did laser around the lesion, is it?
Sir, yeah, on the lesion and on the margin of the lesion, actually.
So you're supposed to give intermittent spots about 1 or half burn width apart on the lesion.
Yes, sir.
And the problem with green laser is there should always expect a 50% chance of
recurrence. Yes, sir. Penetration of the laser is, because it's 532 nanometer.
Yeah.
Other TTT is 810 and VDT is 689. So that has deeper penetration. So with 532, you might have to give more number of sessions.
And that's actually an ideal case for TTT. It's extrafoveal. It's away from the disc also.
Yes, sir.
It's an ideal case for TTT actually. The second case, well managed with anti-VEGF, but that's also an ideal case for PDT.
Yes, sir. That's there, sir.
This thing.
Dr. Dipanshu, how do you differentiate this from metastasis in angio?
Sir, this will be hyperfluorescent throughout. In that, there will be hypo followed by hyper. And leak, no. So that will be hypo followed by
Multiple
hyper.
pinpoint leaks can
Pinpoint
appear
leaks will be
in the
there.
late
Yes,
phase.
yes, sir. That's-
And what is the usual setting for PDT in choroidal hemangioma?
Sir, it is the dye is used in the dose of 6
Standard
milligram
dose
per
or
meter square.
Standard dose or something else?
Half dose can be given, so 3 milligram per meter square. Actually, I have not done it, sir. I am not very sure of the half dose.
एक्चुअली यूजुअल डबल स्टैंडर्ड डोज के डबल डोज यूजुअली यूज करते हैं ए के लिए मास के लिए स्टैंडर्ड डोज मे नॉट सफिस
Okay.
फॉर CNBM CSCR we are using half dose but for masses including this angioma usually double dose is used.
Okay, sir. Double fluence. Half fluence and double fluence. Yes, sir.
Nice cases.
Thank you, sir.
So only thing, one of the differential diagnosis you should keep in mind of posterior scleritis also. So definitely apparent all in the straightforward.
Yes, sir.
But whenever the unilateral becomes like axial to RDs,
Yes, sir.
keep in mind of posterior scleritis.
Yes, sir.
And if you leave for some models, they will go for bullous RD.
Yes, sir. But sir, there was no RCS thickening on B scan, no T sign, no pain. So an FA was conclusive of hemangioma, so we thought of hemangioma as well.
See, the one thing which I wanted to emphasize was what other investigations you would have tried to do apart from whatever has been listed.
Autofluorescence.
Autofluorescence would not help you in treating it. I think ICG would have helped us. As
Yes.
one thing which was discussed first was whether to rule out with tumors.
Yes, sir.
So if you do an ICG, it will show all hypo in all
Hypo,
the
yes, sir.
sequences. One, and secondly, when you're treating these sort of lesions on an FA, you may not see the extent of the lesion. That would be most likely picked up on an ICG better. So in an FFA, I would say that you would be more you'll be more concise in, or maybe partially treating the margins. The extent would be not as
Lesser than what I
demarcated, or
did.
the demarcation would be better, or the leaks would be better on an ICG, and that would actually help you with giving the lasers. So doing an ICG would have helped us better. And since the PDT is not there, that is one flaw. Actually, even I have a couple of cases like this.
So how do you
And,
treat?
we have done an ICG and we are treating it, and we are actually, the problem with this is like we have to give focal lasers, and I have one patient which is having a very papillary sort of a lesion. So that patient, it's very close to the disc, and we can't go aggressively treating it with lasers, because now it is slowly there is an SRF coming in. So I am giving lasers, waiting for 2 to 3 weeks for the time to actually the scar to actually start happening there, and less and less an amount of SRF. As far as anti-VEGFs are concerned, do you actually? I would want to ask the panels, how do you actually go about having and treating this with anti-VEGFs? But because it is very ambiguous, actually we are not actually treating the lesion; it is just the fluid. So actually, I was referred this case with someone had actually given anti-VEGF to this patient who had they were suspecting CNV, but this was lesion. So better to do an ICG one, and secondly, treating with anti-VEGFs would actually not help that much. Treating the lesion.
What they say, sir, probably using anti-VEGF might reduce the SRF a little, and then the approximation of neurosensory layer and RP will be more. So probably the effect of, if we are doing with green laser, probably the effect might come better. That's what they say. But it shows moderate efficacy only. Like 50% of the cases only respond to anti-VEGF.
There is no endpoint.
Yes, sir.
Just have to keep injecting like.
Yes, sir. Yes, sir.
They say it will see the vascularity of the hemangioma.
Yes, sir.
As he said, there is no endpoint with the anti.
Yes, sir.
Thank you, Dr.
Thank you.
Dipanshu.
Thank
We'll call upon our last presenter, Dr. Aditi, if she's here. Yeah. Dr. Aditi, if you can please join us, and she'll be discussing a very interesting case of Cardi syndrome.
Good morning, everyone. I'm Aditi, junior resident from RP Center. I'm presenting a case report on Aicardi syndrome. A 19-day-old female child was brought to RP Center by her parents, who reported left eye being smaller compared to the right eye, which was noticed at 10 days of birth. Patient was taken to a local hospital and diagnosed as right eye posterior staphyloma and left eye query retinal detachment with microphthalmos. Baby was born full-term normal vaginal delivery. Birth weight was 2.9 kg, and there was history of NICU stay for 10 days and also history of neonatal seizures. The family in the family history, there was a history of spontaneous abortion at 2 months. It was a non-consanguineous marriage, and the parents were healthy. On torchlight examination, the left eye appears relatively smaller than the right eye. Anterior segment, both eyes were within normal limits, and the pupil in the right eye was reactive and left eye was sluggishly reactive. On fundus examination in the right eye, there were multiple distinctive peripapillary chorioretinal lacunae around the disc and posterior pole, size varying from 1 to 3 disc diameter, and the optic disc appeared colobomatous. In left eye, there was total retinal detachment. Based on the fundus findings and history of neonatal seizures, Aicardi syndrome was suspected and MRI was ordered, and patient was referred to peds neurology. On MRI, there was corpus callosum agenesis, severe dilatation of the right lateral ventricle, interhemispheric cyst, colpocephaly, and malformation of cortical development, all suggestive of Aicardi syndrome. And on EEG, there was asynchrony between the two hemispheres. So patient was started on antiepileptics and sent for physiotherapy and further genetics evaluation. So the differential diagnosis at this point were Aicardi syndrome, and the classic triad of chorioretinal lacunae, infantile seizures, and corpus callosum agenesis was present in this patient. Other differential diagnoses were high myopia, ocular toxoplasmosis, and MLMCR. Coming to the discussion, Aicardi syndrome is a rare developmental disorder characterized by the triad of chorioretinal lacunae, infantile seizures, and corpus callosum agenesis. Its prevalence is about 1 in 1 lakh population and predominantly occurs in females. It occurs due to a de novo pathogenic mutation in the X chromosome. The gene has not yet been identified. The diagnosis is exclusively based on clinical findings, either the presence of triad or presence of 2 of the classic triad plus 2 of the major features. The major features being cortical malformations, periventricular and subcortical heterotopia, cysts around third cerebral ventricle or choroid plexus, optic disc coloboma or hypoplasia. Other supporting features which can be found are vertebral and rib abnormalities, microphthalmia, split brain EEG, gross cerebral hemispheric asymmetry, and vascular malformations. The most characteristic ocular finding is the chorioretinal lacunae, which are multiple yellow-white flat lesions concentrated around the optic disc and posterior pole. Other ocular findings include optic disc colobomas, microphthalmos, morning glory disc, retinal detachment, and altered foveal development. The size of the lacunae have found to have a correlation with clinical outcome, wherein patients with larger lacunae are more likely to have poor language and psychomotor skills. So this helps in prognosticating the patients. Identification of the characteristic ocular findings in Aicardi syndrome helps in diagnosis and referral to an early intervention program and provides access to physical, mental, speech, feeding therapy, as well as appropriate management of neonatal seizures. Thank you.
Thank you, Dr. Aditi. It was a very interesting case here, and I would start with Dr. Sashir if you want to have some pointers to discuss about.
Nice case, never seen one before. What other differentials you considered?
Sir, the patient was referred as posterior staphyloma. Probably they thought it was high myopia, but high myopia will not present so severely in an infant. It usually progresses with age as the globe develops, as the sclera stretches, there are chorioretinal changes. So we would not suspect high myopia. Another differential is ocular toxoplasmosis, in which we'll find chorioretinal scars, but there is also pigmentary changes. There can be cataract, and in MRI brain there would be cerebral calcifications in toxoplasmosis.
Other differences other than this 4 other congenital like maternal infections should be ruled out. Zika virus infection, there is microcephaly, but there might be certain pigmented areas around the disc also. What was the imaging used in this case?
Sir, what was
imaging?
This was RETCAM 3, sir.
What is the field of view in this?
130-degree field of view, sir. 19-year-old females, 19-day-old females, sir.
So the thing is, the most of this condition what you see is a very severe genetic disorder. Right?
Yes.
the male fetus usually they won't survive, they say, in this condition. Very nice case, but only thing another, for a differential diagnosis, you can say another orofacial distal syndrome, which
Yes,
also
sir, yes,
can
sir.
have a similar picture like this, but it's a more classical of
Yes, sir.
Dr. Aditi, how would you actually go about with your protocol of doing other systemic evaluations when you have some fundus picture like this, or maybe because you have done an MRI for this patient? What was the like after seeing the fundus photo, you went in that this requires an MRI, or it is like a protocol for you how to go about?
So, in this case, the main two differentials being ocular toxoplasmosis and iCardi, we can do an MRI. If it was toxo, it would show calcification also. And because of the characteristic lacunae, we suspected more iCardi, so we got the MRI done.
Dr. Pope?
Very interesting case, and I haven't seen
Thank
any
you.
one of these. Is it family hereditary?
No, sir, there was no family history. The parents were healthy, but there was history of spontaneous abortion at 2 months. It could be because of some chromosomal abnormality, which usually happens in the first trimester.
Do gene sequencing from
No,
this?
genetics evaluation is pending, sir. It has not yet been done.
What are the other optic disc abnormalities associated with brain abnormalities?
Morning glory syndrome or optic disc coloboma is usually associated with brain abnormalities.
What is the abnormality seen in optic nervate or hypoplasia? Bilateral optic nervate hypoplasia.
Thank you, sir.
Thank you, Dr. Aditi. And this sums up with our presentations. And let's go back with if we have a general discussion on the topics, or if any other questions are need to be asked. Dr. Sharad, if you want to ask about, I think there was something.
Yeah, Dr. Kshitij regarding that FA finding. The only thing is like in the case of leakage, better we do the FA because sometimes we need to differentiate APMP versus leakage. So how can we differentiate leakage versus APMP than leakage?
In APMPB, generally the visual loss is not so significant. This patient had bilateral counting fingers at 1 meter, and there was bilateral granulomatous inflammation present in the anterior chamber, along with fundus findings which were quite characteristic of VKH. There were multiple pockets of subretinal fluid, there was hyperemic disc with blurred disc margins. So yes, definitely APMPB is a differential which is to be considered. But in our case, we felt the provisional is VKH and we adhered to the VKH.
As I said, in most of the time they may present in similar features, but APNPP they also present with a severe visual loss sometimes. The placard lesions are most classical what we see, but every time in a case
But the pockets of SRF are not as
present in APNPP also in the pocket of SRF. So that FA will help you very much distinguish because you say that early and late phase. In the case of APNPP, there will be early hypo followed by late staining, but in the case of leakage, you see early hypo followed by late cooling. The classical one helps us to differentiate, especially for PGs.
So thank you everyone, and this concludes our session on young ophthalmologist retina case competition. The results would be announced a bit later. I would want to call upon our presenters, Dr. Monisha, if you can come and collect your certificate, followed by Dr. Yashi. Dr. Monisha, if you can get your certificate. Yeah, please. Dr. Po, if you can give the certificate. Dr. Po, if you can please give the presentation. Yeah. Thank you, Dr. Monisha. It was a very good presentation. Thank you so much. We can call upon Dr. Yashi Gupta if she can come and please collect her certificate. Dr. Yashi, Dr. Po, if you can, or Dr. Sishir, if you can, please. Dr. Sitesh, if you can come on the dais and please collect your certificate. Dr. Kaushik, if you can do the honors. फैकल्टी को मैं इससे अक्षय से करवा दूँ, अक्षय करवा दूँगा, अक्षय को बुला लें. If Dr. Sindhuja, if you can please come on the dais. अक्षय मैं ऐसे दिलवा दूँगा, फैकल्टी को बुला. हाँ वो दिलवा दूँ, कोई बात नहीं. That's fine. Dr. Dipanshu, if you can please join. नहीं एक को ही बुला. Dr. Aditi, if you can please come. We would like to felicitate our panelists as well. We would like to call Dr. Akshay Nair if you can come on stage and give our panelist the mementos, please. Please. Dr. Sishir, please, if you can please collect your memento. Dr. Kaushik Tripathi, if you can collect your memento, please. We have Dr. Po, if you can have that. Thank you. Dr. Kaushik, if you can collect your memento, please. We have Dr. Sharath here, he can collect his memento.
And our moderator, Dr. Avnish Upadhyay, our treasurer also.
Concludes our session. It will be followed by the next session. We can ask Rohit Modi and Dr. Devakant if you can come in and join on the dais. Thank you so much.
Most of us are either into private practice or we are planning to put up our own setup. And many a times we get overwhelmed looking at the magnitude of things to be done, and sometimes there is a lot of negative talk around putting up your own practice and the challenges we are facing. So hence YOSI decided to keep this practice development session. I would like to invite Zain Khatib, Aman Khanna, Pooja and Ankit Agrawal as the esteemed panelist for this session.
In the meantime, the panelist joins us. I'll invite Dr. Rohit Modi, who is a practicing VR surgeon in Mumbai, and he'll be talking about if you want to learn how to swim, jump into the water, which is basically about starting a practice. So this session is relevant for not just the people who are planning to start a practice, but residents or people who are in other kinds of practices. I'm sure it will give you some very useful tips for that as well.
So we keep on hearing about the boom in our economy, the boom in every industry, and the boom in the India's healthcare firms isn't showing signs of slowing down. So here is what I believe. If you want to learn how to swim, jump into the water, and that's what private practice is all about. And we always question, either boom ho raha hai, this is happening, that is happening, but really, can we see that boom in our own private practice? Here's is my take. We know recently India surpassed China to become the world's most populous country. And we all know numbers do matter. Also, when we look at this, we know that the health insurance provided by the government is growing. But mind you, the health insurance coverage by the private sector is also growing by huge leaps and bounds. And the best part is, since we are a country of more than 130 crore people, even in a 2 or 3% growth every year would mean more than 4-5 crore more people joining in the private health insurance coverage. And that number makes a huge difference for us. It may be 2 to 3% of the whole population, but it's actually 10 to 15% growth when we look at the population we are targeting. That is only 10 to 20% of the population we are targeting in our private practice. And one of the interesting stat which I came across is at birth, life expectancy in India is 69. But when somebody actually reaches 55-60, it shoots up to 77. Now that translates in more of age-related disorders. And as the aging increases, the incidence of AMD, diabetic retinopathy and glaucoma increases subsequently. And that is, because also we are the diabetic capital of the world. And we all know everybody is talking about the India growth story. We are growing at 6.3% when major economies like the US, UK are going for an economic downturn. And our estimated per capita income has increased. Now, why these statistics are important, I will talk in my subsequent slides. It has actually doubled in last 7 to 8 years of the Modi government coming in. And if you see the number of people coming into the 5 to 10 lakh bracket. Now, why I am saying this, somebody who's earning 2 to 3 lakh rupees a year may not think of going to a private practitioner. But as soon as somebody's monthly salary increases from 20-25K to 50-60K, he can actually afford a solo practitioner's fees. And we can see a significant jump in the number of taxpayers. The interesting part is the direct tax collection overshot government's expectation by 16% in this financial year. So the number of taxpayers have increased. So the number of people who are actually earning more than 7 lakh rupees a year is increased significantly. And the best part is ophthalmology packages are not a big ticket item like, CABG or a liver transplant or a kidney transplant. These are pretty cost efficient surgeries. And most of the surgical packages, if you agree with me, would be something like, cataract packages would be from 50K to 60K. Yeah, there are some packages for 1.5 lakh, 2 lakh rupees, but most of the packages are between this. Intravitreal injections, the next boom is going to be intravitreal injections. 8K to 25K, Avastin or Azumab, whatever we like. And refractive surgeries, LASIK, PRK, whatever we are doing, roughly 30K to 50K for both eyes. And that's where the insurance coverage, for intravital injections is going to create a big boom. The numbers, the follow-up is going to increase tremendously. And that's why with rising age, rising income and increased coverage and more treatment options, the number of patients are going to increase exponentially. So, we are thinking that, earlier there were 10 ophthalmologists in my area, now there are 30. But mind you, the demand is for 50 or 60. So the exponential rise, the growth phase is now. And that's why it's the best time to start private practice in ophthalmology now. And I'm sure most of us are going to at least afford a Mercedes or a Audi, if not a private jet. And there are private practitioners in US, ophthalmologists who have their own private jet. And most of them are retina specialists. Thank you.
Thank you so much, Dr. Rohit. I'm not sure how many in India have a private jet, but let's invite a comment from the panelists. Dr. Pooja.
I think it was a wonderful presentation, a good overview where we are heading. So another question that I have is with the multi-speciality chains coming into the field of ophthalmology. I don't know whether there is a second session for that right now. How is the challenge? What is the challenge for a new age ophthalmologist coming into practice? So what should you pick up? Should you go for a multi-chain? Stay away, physically stay away from that. How do you practice? Plan your practice. Firstly, what is there in your area?
We have Dr. Abhishek in the meantime to set up this.
So my take on this, everybody will have their own take. One thing is, it's a good thing there is, equity-backed, private equity-backed chains are coming in. Now we have come to know the value of our practice. And, some practices, even as young as 5-7 years old, are selling for 15 crores. And in tier 2, tier 3 cities. So my take would be, develop your practice to that level, probably a 45-50, and then you take a call whether you want to sell it off or still continue as a private practitioner.
Buy a private jet.
Huh?
And then buy a private jet.
You can get something like 30-40 crores also at that point of time. And for 30-40 crores, you can learn how to invest in the finance session. So that can additionally, make something like even a 10% return would be 3 to 4 crores a year. That would be like earning something like 25-30 lakhs a month. So you can very well imagine the kind of lifestyle you can lead with that kind of money at the age of 45-50.
So I was working for a chain initially, and then recently I started my own practice. So I have bits of experience from both worlds. A corporate setup is a great learning ground to how to start a practice in a professional manner. So we have what literally done is copy pasted what we learned, what you're working in. I was working in the hospital, so try to copy paste the model that they have, and you get to learn what mistakes they are making and how difficult it is to run as 40-50 samples from the top, and then you can overcome those mistakes and take advantage of the good things that they're doing.
But I think I agree with you. You learn a lot from the corporate practices and before moving out to your practice. But I also feel like when you move to your private practice from a corporate practice, the cost of investment is also a lot because you are used to using all the best quality equipment, best microscopes, best surgical equipment, and to buy that in your private practice at the same time becomes a big challenge, I guess.
But you also learn that it's really important to do that. So you find an investor, you get some loans, and you have to go that way, because if you start really small, you will take that much time to reach to a certain level. And in the present time, in a good city, in a tier 2 city or a city like Delhi, if you don't have that level of practice, you won't be able to pick up anywhere. That investment we really need. You have to figure it out how to do it.
Now we would like to invite Dr. Abhishek Hiranjan. He is a practicing vitreoretinal surgeon in Vapi. And in a few years' time, he has become a leader in his field in that region. And the most important part when you start a practice is you need to know how to crack a good deal with the dealers. So, Abhishek.
Thank you for those kind words, Dr. Rohit. In today's fast-paced healthcare industry, medical equipment plays a crucial role in the diagnosis, treatment, and management of various medical conditions. However, acquiring medical equipments can be a significant investment for healthcare providers. Today, I am going to tell you all you need to know about cracking a deal. Good morning. I am Dr. Abhishek Herenjal, Medical Director of Advanced Retina Care Center, and I am running 4 eye care centers in South Gujarat. And these are a few equipments that I own which help me run a successful practice. Ours is the only few NABH accredited ophthalmological centers between Mumbai and Surat. Though this is a topic where we can have at-length discussion, in order to keep it precise, these are the top recommendations that I would like to discuss with you. Firstly, it is essential to start with a thorough research. Conducting comprehensive market research will help you understand the price range of the equipment you intend to buy. This information will help you negotiate for the best possible deal. It is also essential to gather information about the manufacturer's service policies, including warranties, additional fees, and after-sales support. So building a good rapport with the supplier will always work to your advantage. It can help you develop a long-term relationship with the supplier and eventually lead to a reduction in the cost of equipments and products. It can also lead to better quality of instruments and services later on. So it is essential to negotiate the best possible deal to ensure that you get high quality equipment at competitive prices and a reliable after-sales service. As doctors, we always hesitate to ask for discounts. Many of us may shy away and just go ahead with an impulsive buy. For example, the full system of Heidelberg Spectralis costs you around 2.5 crores. And upon asking for a discount without any negotiation, the company gives you the system at 1.85 crores. That is a straight 75 lakhs discount. So keep in mind, many suppliers have discounts for bulk purchases, they have discounts for repeat purchases, and also some special deals for some select ophthalmologists. So though negotiating is all about getting the best deal, be willing to compromise on some things like delivery, the payment terms, warranties, or the quantity of consumables that you can get. A flexible approach could help you build a better relationship with your supplier. Now, sometimes walking away from a deal that is not good is also necessary. Sometimes when negotiations fail, it is best to get out before getting into a bad business deal. Example, I required a laser console for my medical retina setup and I had two options. A new one worth 25 lakhs or a refurb one worth 8 lakhs, which was in good working condition. Now, since we all know that the laser cavity is the heart of the machine and it has a lifespan of around 7 years and it would soon require replacement, I realized that the refurb was living on borrowed time. So in spite of a great deal in the beginning of my private practice, I decided to go ahead with a new one. Bonus, I could negotiate an extended warranty with a fixed AMC at a lower rate, and also I could negotiate to get all the new lenses free of cost. So we all know the power of cash. And any dealer will be very happy to get an upfront amount for his machine. So here you can take the negotiation to your buying point. Lastly, at trade shows and conferences, you get all responsible and credible companies. And also in a couple of hours, you can get all the information regarding various price points, the first-hand demo, and the differences between every machine. This is also an opportunity for buyers to negotiate and get a better deal, since suppliers will have a lot of competition. So in conclusion, it is important not to compromise on the quality of equipment. Always ask the vendor about the equipment features, the components, the certifications. As additional add-ons, you can also negotiate on various terms and conditions such as the delivery time, the installation cost, the training cost. You can also avail zero interest finance buying options with a staggered payment promises. And also you can go ahead with IL bundling options and a luring promise of upgrading, buybacks and exchanges in the future. Thank you. I had done a lot of research just a couple of years back while buying all the above machines, so feel free to talk to me one-to-one in case you too are looking to open your new setup. I will be more than happy to help and get you good connections. Thank you. This is Dr. Abhishek Herenjal.
Thank you so much, Dr. Abhishek. And in the meantime, I'll invite Dr. Akshay Nayak. He is a practicing oculoplasty surgeon in Mumbai, and has a very famous YouTube channel that he runs. One tip from my side would be that what Dr. Abhishek also touched upon is in the terms of the warranties and AMCs and these kind of things. We bought a Constellation recently, around 7 months back, and we did not know, and it was not clearly chalked out, that the Phaco handpiece had a warranty of just 6 months. We were under the impression it was 1 year, and it broke on 6 months and 7 days. So, but we pressurized them and they gave us a new one. But be very clear about these AMCs and all these things, because that will land you in the soup later on. Dr. Zen, I would have your views on one thing that he hasn't touched upon is the bundling of the term bundling that often comes. Can you tell us more about it? I think you recently bought a machine.
So basically, negotiation is definitely important. But as Dr. Devakant mentioned, the bundling aspect, sometimes in the process of negotiation, you realize that the company people are trying to tell you about your practice better than what you know. And they suddenly make you realize that you have certain volumes of practice which you know you don't have, but they make you believe that you have it. And they end up, giving you all those lenses. Sometimes the lenses come at the same cost, sometimes it's a premium. You don't realize. So you have to be smart in that sense that, I've bought quite a few machines with lens bundling, but you have to be smart. So some of them have not ended up so well where, towards the end you realize that you've got a stock of unnecessary lenses which have expired, and you don't have that. You can't implant those many lenses of that company, You can't just push if you don't have those volumes. So you have to be smart in that sense. The company people will tell you that you have those volumes. So in that sense, you have to be really smart about it. I would say, going to a lot of conferences, interacting with people gives you a lot of exposure and understanding about, how people talk, when they want to sell you something. So that is important. Machines, to buy machines when they are new, when no one else knows about it, is important. There are a lot of machines which are good copies of machines which and after you buy it at a low cost, after a few years you realize the cost has really gone high. I had bought the Tommy OA 2000 when not many people knew about it, the optical biometer. Similarly, I bought Optopol Revo at that time when not many people were buying. And I remember when I had bought Optopol Revo, I spoke to Dr. Rohit. I asked so many people, do you know about this machine? And most people were like, no, we don't know. And they got it at a good cost at that time. Now both costs have increased, skyrocket. So important to do good research, as you said, and see which machines are good for their quality.
Okay. So I'll be talking on do-it-yourself online marketing and how you need to make your presence online, and it's important to be there. The slide is not being put up. Slide लगावेंगे?
Can we have the slides, please?
Yeah. So why have an online presence? I think that is the point is moot. Here, everybody here knows why we need to have an online presence. Whether it's a restaurant, whether it's a hotel or a vacation, airline, everything. All of us look up reviews, look up how they are being, what features they offer, what benefits they have, and then we pick one. So much like that, the old school way of doctors referring patients to you is going to get slowly phased out, and most patients are going to come to you self-referred, and you're seeing that a lot of patients look you online and directly come. So it's important, and also it's important to go and get patients to write testimonials about you or reviews, especially ones you think are going to be favorable. So the first thing is to register yourself and put up your practice as a Google business there. It's also important because what you do, what your practice is about, what specialty it is, it's important for peers also to know so that they can also refer. Because oftentimes in WhatsApp groups, we know, is there a retina colleague in, say, Surat, or is there a cornea colleague in Bhopal? if you're there online and frequently post things online, people know about what you're doing. If you've got a new equipment, if you've got an unusual case, if you've got some achievement or an award at a conference, it's good to put it, but we need to be a little cognizant and not to overdo it, because at the end of the day, I'm talking about this from a practice building perspective, and posting things of how many conferences you've attended and how many awards you've won is great on Facebook, but from a practice perspective, it's not going to get you patients. So the first and most important thing is to build your own website. This is absolutely key, because your own website is your information the way you want it, in your words, with no restriction, with as many photographs as you want. It's important because patients, you have to think from a patient's perspective. What is it about this doctor that I want to know? What is it about this center? Do they have insurance coverage? Do they do these kinds of surgeries? What are their timings? What is the working days? Everything that you want to know as a patient should be there. And also how they can get in touch with you. Unless you're responsive, unless there's someone picking up the phone whenever it rings, or having a mobile number there that they can reach out either through text or WhatsApp, is extremely important. Also on your website, it's important to have a column or say a blog that you update every week, every 10 days, every 15 days, one small column, maybe 300, 400 words, because adding new information on your website with new keywords, a new post, brings your website up on the algorithm of searches. And of course, now you have got ChatGPT, so you just need to give a prompt of give me a 300-word blog on eye care for children, and you have your blog to put up. So thankfully for me, oculoplastics is a very visual branch, so before and after works well. I won't go into the details of how to go and make your own website, but the biggest stumbling block that I have realized from people talking is their inertia to get their own website. Everybody tells me, I've thought of my website since 5 years. I bought the domain, but I haven't gotten to making the website and putting up online. If you can't do it, pay money and get it done. It doesn't have to be done by you. None of us are, or all of us are not coders and computer engineers or designers. So pay money, get a designer to do it, and visit other websites that you like, get those features, show them what you want, and get that on your website as well. Now I'll come to each of the social networking platforms. Facebook is the necessary evil of our lives, but it's important to know the average age of the Facebook user is 40 years. So if you're if you're a refractive surgeon, you're not going to get many patients from here. And a lot of us do not have a professional page on Facebook. So if you have your only personal page where you're putting your vacation photos, funny jokes, etc., remember that's an echo chamber. Only those whom you're already connected with will be seeing your post. So there is no new market that you're reaching. There are no new people whom you're reaching. On the other hand, from your professional page, say your clinic or your hospital page, if you keep posting things, that comes in the search reviews, in the search results when people look for something specific. And remember, nobody looks for a cataract surgeon or eye care help on Facebook. So Facebook is not a particularly great place or a marketplace for practice. Also, Facebook is over the years degenerated, so we have to be, oftentimes we end up seeing people getting into arguments, talking about whether it's politics or whatever. So then, and also there are guidelines. You can't keep posting any photos of patients online. They get put down saying that it's not in line with what they say. So I am not particularly bullish on Facebook. What I am extremely intrigued by and amazed is Instagram. Instagram basically is the new marketplace, whether it is for patients, whether it's for information. All of us before sleeping have our ritual of going through random reels and sharing it with people. A lot of patients actually look out for keywords, for hashtags on Instagram, and actually do doctor shopping on Instagram. So if you put up, say, LASIK, in the past 1 week, past 24 hours, there have been 2 lakh posts, 200,000 posts on LASIK, and you can see not all of them are actually about LASIK. So a lot of people or ophthalmologists on Instagram have made it a lifestyle page. They talk about fitness. They talk about they've made it, talk about motivational talks. So you need to strike the right balance of whether you want to post your personal life, your professional life, and other things on Instagram. But the more you make it about your profession, about surgeries that you do, give them a peek of how your day is. There are different strategies of how you can keep going. Have ask me anything sessions, going live, a day in your OT. There are multiple things that you can plan on Instagram. Look at cataract surgery, 34,000 posts in the past 24 hours. So, and not all of it is about cataract. So if you look up, like I said, you can always have a personal connect with people. And compared to Facebook, the average age of the Instagram user is 23. So you see the demographic shift that has happened in this. Now, say for example, Dr. Danny Zhu, she's got 45,000 followers, and she posts, a lot about cataract, a lot not about cataract. Similarly, Andrew, he is a 3-time Ironman champion. So he's an ophthalmologist, but his posts are rarely about ophthalmology. So, there are two ways you can straddle this and make it work for you. Whether you want to focus on, and a lot of us here have interests apart from ophthalmology, and patients or people on Instagram actually like to see a personal side of the doctors as well. So for me personally, Instagram is now a source of almost 20 to 30% of all my practice people who walk in. It helps to be verified, but the other source that I look for that helps me in generating patients is YouTube. It is surprisingly useful, and whether it's teaching videos, whether it's informational talks or short talk about, say, dry eye, computer vision, tips for children eye care, or your surgical videos, or how to, whether it's a presentation that you're presenting somewhere and have someone record a clip and put it up, the reach is the widest. Now remember, on YouTube, people are looking for something very specific. So the reach is very wide, and people who click on your video will not incidentally click on your video. They're looking for something, and that is how they found you. So you need to make sure that the video or whatever you put up on YouTube is high quality. How do you go up on the YouTube search algorithm? Consistent, persistent posting. Every month, one video, every week, a short or a small story. You need to be persistent. You need to take time out from your weekly schedule to create content, and it has to be relevant. You'd be surprised how patients are not afraid of surgical videos. They're not afraid of blood. Surgical videos are great for peers, residents, fellows, and we all know how Dr. Pradeep Mohanta has taught so many patients of us. But at the end of the day, this is your greatest audit. It's an external audit. You've done your surgery, put it up on YouTube for everybody to see. It is a validation, and patients know then they see it as a confident surgeon, someone who's putting up his surgeries, his before and afters, and his patient testimonials are great. And when patients are actually happy and they write comments on that, other people who read comments actually make note of that and come back to you. And I have, on my YouTube channel, I see patients and prospective patients having conversations with each other in the comment box. And sometimes you wonder how, it's funny, but it does happen, and how someone who's written a comment on your YouTube page actually ends up being a person who refers patients to you. So it's great. Again, you can, by making the patients know about how you practice, what you do, it's almost as if the patient knows the doctor before coming in, and they come and tell you, oh, I've seen all your videos, I've seen all your photos, I've been following you for a year or two. So, patients actually stalk pages that they want to, that they've shortlisted, and then eventually come to a doctor that they are most comfortable with. Younger patients are very comfortable with tech-savvy doctors. So, and this was my story. I was lazy for the past, I got my domain in 2014, but didn't build my website for 4 years. And like I said, now my online presence contributes to probably 50% of all my patients. Oculoplastics gives you an advantage because it's a very, like I said, a before and after photo works, which may not work particularly for, say, retina or say cornea, but the ability to create content and wider, say, informative blogs, small snippets on how to home remedies, etc. This is amazing. The scope is amazing in all specialities. Like I said, look at features that you like on other websites and incorporate that in your website. Accessibility is key. On my website, there's a one-touch link to the phone of the hospital, the email, and the Facebook page, and integrate all of them. You can even request a consultation on your own website. Like I said, blogs, frequent blogs, small notes, columns are very important, because the more new content or the more unique content that repeatedly gets refreshed on a page, the higher it comes in the search engine. Instagram, I think I've already said enough, is probably my number one referral. Patients write in, send in their videos. Sometimes you have to weed out through the irrelevant posts, and they just come and say, "Doctor, eye surgery cost." So those things you need to be a little patient and try to take time to respond, not be dismissive of what people say. A lot of frivolous inquiries come, not so serious enough, but at the end of the day, all of it will trickle down. My YouTube channel is the other source of patient generation. Like I said, it's the widest reach, but it takes a lot. I don't have a team doing it. I have to do it myself. There is a pressure to be regular and maintain quality, but that's how it works. So to summarize, the moment you get into practice, even though you may not have anything to put, create your website. The dividend, much like investing in the stock market, the dividend in online presence works on how long you've been online. Take a multi-pronged approach, have all the components of a Facebook page, an Instagram page, and a YouTube channel along with your website, link all of them. And there is always an incubation period. For the first year or year and a half, you may not see patients coming into your website. You will see your analytics, you getting 10 hits a day, etc. It's persistence that matters. Things that you need to be very careful of not talking on online or putting in public is pricing, prescriptions, and photos, pictures, patients' pictures without their consent. It's not a popularity contest, it's a reach contest. The wider you reach, because most patients or people who see your post don't come and like or share, they just read, consume, and make a note of it. So be very mindful of that, and surely you'd be able to do it yourself without having to hire an online or an SEO consultant, which of course is also a good idea. But sometimes you find that you tend to know more than an SEO guy. So read. There are a lot of YouTube videos and tutorials on how to maximize your search engine optimization and your presence. And it's something that I keep telling people, I am not tech savvy, and if I can do it, anybody can do it. Thank you.
Thank you so much, Dr. Akshay. Great talk. I differ a bit on certain aspects.
Yeah.
So I have a very popular Instagram account, I would like to believe, almost 40K subscribers, followers. But I think I've had 1 or 2 patients through Instagram till now. I've been having the account for the past 5-6 years now. On the other hand, Google listing, that I don't think you have a Google listing.
I don't have a Google listing, no.
So why you don't have it, number one, and that helps me by far the most. Almost 5 to 10 patients on a daily basis, and through Google I have had patients from Goa, from Mumbai, somehow I don't know why, from Chhattisgarh and all those places. So that has worked really well. YouTube is also a very great source, but it needs a lot of efforts. You need to put videos and
consistently.
And one more thing that I want to talk to you about, which you touched upon briefly, about hiring someone. So has anybody hired somebody for taking care of the
Zen?
Bad
Yeah.
experiences. So what I feel that they don't do anything, they just have templates and they
Exactly.
And why don't you have Google?
Yeah, so primarily because I don't have my own practice center, and because my website came up first, it's actually listed as the first entry that when someone searches for me. My Google listing, if you do search, comes up linked with the hospital that I practice. So because I don't have my own practice, I have consciously not listed myself on Google. The Google also has a flip side. You can't curate reviews. If someone writes something nasty about you, it's there, unless you go behind them and force them to take it down or something. So it's a double-edged sword. But I agree with you. Google is very, very it's vital, and everybody looks up, the first thing they look up is Google and Google reviews. So
Another question that I had is that, the topics don't cover grassroots level or a door-to-door level kind of marketing. So today, in today's day, like when if you have a general practice where 70 or 60% of your practice would be cataract practice when you start out. So how important or how many conversions, that means if a patient comes to your clinic via online search versus via a referral, how is your surgical conversion? Like, anybody take this question. Surgical conversion to a surgeon. It's a very different ballgame.
I know.
I understand that.
But just to give a perspective, I think from a patient, a lot of times, what I have also seen with colleagues is the average number of surgeons that a patient visits before a cataract surgery is between 2 and 3. At least in a city like Bombay, there are always 2 people that they would visit to get an idea. And surgical conversion rate, I think, if you're able to convert 1 in 3 patients whom you've advised, that you're in the higher range of surgical conversion for cataract.
My question is that if somebody's referred via grassroots level marketing versus online marketing, like a patient comes in via an online search and says, okay, you have a cataract, how likely is he to convert to a surgery versus?
I'm going to ask Rohit to try to answer
How much funding
that.
should you allocate to online?
Okay.
If you have a marketing budget of say 15,000 a month for a starting practice, how much would you give it to online marketing and how much would you give it to a grassroots level marketing, a referral kind of a practice that you want to develop for a general practice?
I believe the best way to market, if we are doing a comprehensive ophthalmology practice, is word of mouth. So that patient conversion is almost 100%. If somebody has come through word of mouth, if you're talking about referral practice, I do not believe in a referral practice through a PRO, through a family physician. So we don't do it. I'm not saying it is a bad thing, but I and Shraddha, we have taken a call at the beginning of our practice. We don't want to do it for some reasons. So
by referral, do you mean actually paying people to bring patients? Is it?
Yes, that is something that nobody wants to discuss in this.
No, I think it's very important.
It is very,
But
very
yeah, and I think it's okay to give it a trial. Say 6 months. See, everything has an incubation period, and even a referral practice or a referral strategy, whether through a PRO or direct one-on-one, give it 6 months to a year. And I think what you need to be diligent about is making a note of how much you've put in time, effort, money wise, and how much it's giving you back at the end of a year. And you yourself can take a call that, me going out and meeting all these people or doing these small meetings and giving dinners or say hiring a PRO is not working for me. This is working for me. That is working for me, and accordingly allocate. I think one more question, 1 minute, since we are quite ahead of time, is creating, blogs and questions or columns that we get patients who ask us, but not commonly found online, are good say things to write about. Which IOL should I choose? Which lens is better? Exact phrases like these. You can write a small blog on this, make a YouTube video on this, a short 1 or 2 minute. So when patients look for exact questions and they find someone talking exactly about that, then they know that that again that immediate connect is made, and then somehow they'll be reassured that okay, this guy knows what he's talking and he'll come. So look for questions, pay attention in your clinic, and the most frequently asked questions are things that you could make some kind of online content on, whether it's a page, whether it's a Q&A session or a small Instagram short or a YouTube video. How soon can I resume exercise after surgery? What can I take bath after cataract surgery? It's a 1-word answer or 1-sentence answer, but there are enough ways you can make it into a 2-3 minute clip. So all of these help, because the more content you have, the more videos you have, like how people have hijacked, certain hospitals have hijacked the term LASIK, Contura in India. You search up and there's only 1 or 2 hospitals that show up. That's you need to, that's the competition we have. So
you need to hijack more stuff. So coming back to your question, see, it depends a lot on the demographics and the geography, what works better. But I feel a good social media profile, a good Google profile, the way it works for me is there are a lot of patients who come through that. A lot of patients who come through other channels or walk-in patients and are posted for surgery my counselor just tells them at the end of the counseling session, Doctor Saab ko Google kar lena ek baar. So then they come back that yeah, there are 500 5-star reviews, and so it both ways it will help you having a good social media or a Google profile. Will definitely help.
But just touching upon that, my question to you and everyone, Akshay sir as well, that when you do aggressive social media marketing, so now when you reach this level, do you still spend a lot of money on it? Because see, from what I saw in your presentation, everything seemed to be, yeah. So do you need to spend that money? But I don't know, because for Instagram, Facebook, for people to see your videos, are there ways how you can advertise it if you're doing it from your page, or do you do it like just put it up there and with time it gets views?
In say on Instagram, on YouTube is very organic. You can pay for it, but at the end of the day, people will look at it, like it, see it only if there is quality to it. Say if you're putting up a tutorial or a surgical video or giving a talk about LASIK, unless you're talking sense or it is good quality with good production values, someone not shot on a handle camera with the vertical camera, things like that, they make a lot of difference. So it's quality that matters, whether it's a post on Instagram, whether it's a post on YouTube. Even if you spend money and push it and boost it, if it's not good, people will not, they'll just scroll past it. Whether you should spend money or not, selectively choose posts that you think will help. If you've got a great before and after of say a corneal graft that you've done, or a LASIK patient with a testimonial, choose those that are likely to make sense to a patient, and they do help. But at the end of the day, like I said, it's organic, and the more high quality content you put, the better automatically it goes.
So last year I had hired a marketing team, and I had made about 6-7 videos as per their recommendation, and only for one of those videos they had paid money. I don't know what they did. That was on retinal detachment. That got some 20k views up till now, and the ones I made on LASIK were not marketed for some reason. They are, I think, at about 50-60 views right now.
Yeah.
So I just want to know how important is that? I mean, if
one thing is that we have talked about content, the other thing is consistency. So once you do it yourself, I was just going through some post about the algorithms that keep changing on Instagram and YouTube. It's all about algorithms there. How your feed will come up and how it will become viral and stuff. So what they recommend for Instagram is 1 post a day, a reel or anything, and 6 stories a day. So that is what you need to actually popularize your channel. And how consistent can you be? So maybe that is where the role of hiring someone comes in. They can be consistent on your behalf. You can just give them stuff. But they don't have any clue, because most of them don't have that much experience, and they are having so many clients, they just copy paste stuff. Like World Health Day aa gaya, to aapka bhi naam dal diya, that kind of thing. That doesn't work, those kind of posts. Right? So you can utilize them for being consistent. Other than you have to drive them.
Can I ask the panelists to look here for a second? I need to post 1 story for the day then. All right. Huh? Keep it straight and take. Oh, okay. Thank you. I'll do that. Like this. Yeah. Okay.
Thank you.
Thanks.
Thanks, Akshay. Now we would like to invite Dr. Rajat Jain. He is a leading phaco-refractive surgeon as well as a cornea specialist working in Delhi in a highly competitive atmosphere. He has built up his own practice, and discussions with him have taught me a lot on how to maximize returns from packages. Over to you, Dr. Rajat.
Thank you, Rohit, and thank you for the amazing team of YOSI. So I'll be sharing my experience of how to maximize returns from packages. All this content which I am supposed to share in the next 7 to 8 minutes is my own experience, and nothing is from the books. So first and for all, what do you mean by returns? So we are trying to maximize our returns from packages, but what we have to first know is the definition of returns is different for a surgeon, it's different for the patient, it's different for the management from which you work, and it's different for your public relations committee. So for a surgeon, the best return is there is no substitute for a good, uneventful surgery. And there should be no compromise on this as regard as a surgeon is concerned. So how does it? How do you get a good uneventful surgery? Yes, you should have a good machine. Dr. Devakant was referring to this a while back, that you should have something basic to start up in a bigger, especially in a bigger city like Delhi or in a second tier town. If you start from very basics, you might not end up where you want it to be. So a good machine is a backbone of a good practice. Everybody says the rider is more important. Yes, the rider is important, but the horse is also as important as the rider. So yes, the surgeon is the primary thing, but the surgeon ke haath mein jo phaco probe hai, how important that is also very important. Good instruments. So this I'll tell you my experience. I used to use a lot of Indian and basic instruments in the initial part of my career. I am a transplant surgeon, so there is a huge difference if you do transplants from not very good instruments and very good instruments, no financial interest, epsilon instruments. So the finesse and the capability of yours using those finesse instruments is really different. So you should invest in instruments because they are one-time investment and they work for a long time. The most important is a good training. So good training gives you good confidence, and good confidence gives you, confidence to venture into uncharted territories. So there is no substitute to good training. If you think you are less trained or if you think there is more scope, please go ahead and improvise your skills. Good training is the most important. No financial interests here. I have a NIDEC AL scan. So good IL per measurement is very, very important, especially if you're going into a premium cataract practice. A trained staff. So the last 2 points, a trained staff and peace of mind, are very important for while you're working. So in my OT, there are always Kishore Kumar songs running through. Chahe I am operating in the morning or in the evening or at night, there are always songs in the OT. So it gives me a calming atmosphere. I ask the patient if you want any special bhajan to be put inside the OT, and if they say some kind of a bhajan, then I put that bhajan inside the OT. So some kind of music is always running. And I'll tell you my tagline. It's in relation to the songs. It will come later on. What tagline I tell the patients. So what does the patient returns mean? Every patient wants surgery should be sasti, jaldi or sabse achhi. Cheap, best and fast. What you have to make them realize is they can have only 2 out of 3. So if it is cheap and best, it can't be fast. If it is cheap and fast, it can't be best. If it's fast and cheap, it can't be. If it's best and fast, it can't be cheap. This thing has to be made, realized to the patients. They can't have everything. Doctor sahab, sabse sasta kar do, sabse acha kar do. They can't have the facilities of America at the cost of Ethiopia. That is not possible. So this concept of sasta versus acha has to be clearly explained to them. We have packages for both, but then they can't have both. The next thing which a lot of patients taught me was this. Doctor, mere padosi ko chashma nahi aaya, mujhe aa gaya. And people who don't know Hindi, what this means is, see, my ex-person got operated by Dr. Y and you are operated my eye. He doesn't wear glasses. I'm wearing, supposed to wear glasses now. So you are the culprit here. So what you need to make them clearly understand is how to choose a perfect IOL. That's what Akshay was just referring to. So this is what a few slides which I have a presentation made in my hospital. I tell them clearly that there are a lot of TVs available. There is Tata Sky, HD, Tata Sky 4K. You have to choose whatever you want. And there are differences among all these different television screens. So what we also tell them is that now the visual requirements have changed. They are distance, near and intermediate. Toricity is a concept which we definitely refer to. And my standard protocol is that if the K rating is, if the clinical power is more than 0.6, I would always refer to go ahead and put a toric IOL, or at least tell the patient that if you don't get a toric IOL, you will have to use glasses. This thing has to be clearly told to them because they will not understand this in the initial part, and they will tell you after surgery कि आपने हमने ढंग से बताया नहीं. इंडिया में एक और प्रॉब्लम है, हमने समझा नहीं, कोई नहीं बोलता, आपने बताया नहीं, सब बोलते हैं. So there is a difference which I have to clearly tell you that we have told you and you have not understood it. So this is my standard slide which I show to all patients how to choose my IOL depending upon the toricity, whether you have to go for a multifocal or a monofocal or a toric, whatever. So this is what I show them. And the last one is very important. Everybody would say, मेरे पास mediclaim है, सबसे अच्छा कर दो. So you have to tell them that multifocal and torics are not covered in mediclaim. You have to shell out extra from your pocket. If you are ready, then we'll go ahead. So this is the table which I show them in the end about how much vision they'll be getting, what will be the difference in contrast, glare, halos, and then comes the surgery cost. I've hidden my surgery cost as of now. And what you have to again tell them is there is no perfect IOL. The example which I tell my patients is, अगर आप अपने बेटे के लिए एक लड़की चूज करने जाते हो, आपको 10 में से 2 चीजों पर कॉम्प्रोमाइज करना पड़ता है और वो करना ही पड़ेगा. You cannot get 10 good things. So that is what is also in the IOL. You cannot get everything. You will have to compromise on something. Depends upon what you want to compromise upon. So this is again the final slide of that counseling. What different IOLs have, what packages they are there, panel के patients हैं, insurance के patients हैं, what all they want to have. And then I give them my recommendations, but obviously with riders. Finally, this is a cartoon which I have put in my clinic also. Every patient before surgery, when especially in LASIK, they don't see like this. But as and when surgery is done, doctor साहब एक आंख से ज़्यादा अच्छा दिख रहा है. So they are not one-eyed. They have to see with both the eyes. So best results are obtained only after both surgeries are done, especially in cataract surgery. This I have told, so I'll skip. This is the most important. So we have a consent printed on a like consent typecasted and printed, and we write and we tell the patient to write it with their own hand that they have chosen a monofocal IOL or a toric IOL or multifocal, and what are the advantages and disadvantages of that particular IOL. So written consent has to be there, and we give one copy of that to the patient to keep it in their file. Management returns from management obviously is money. So I have my own hospital, so I am the doctor also, and I am the manager also of that hospital. So for me, obviously, money is important. But you have to understand that money can be calculated in three terms: profit margins, which are affected by the competition, and turnover. And mind you, it's only a game of turnover, because you cannot increase your prices over a certain limit. You have to keep the market rates into consideration. So I am using a high-end phaco machine. Somebody else is using a very basic phaco machine. My per surgery cost is more. Their per surgery cost is less. But even then, my package cannot be too much higher. So it's a game of turnovers, because once you are achieving certain numbers, which you will definitely get after a certain period of time, the fixed cost will remain the same. Fixed cost means your infrastructure, your OT, machinery, all those things will remain the same. And consumable cost is almost nothing in a cataract surgery. So it's a game of turnovers, and the ultimate goal is to increase your referrals. I'll finish in 1 minute. Next thing is maximum returns from packages. Now, please remember, please define your packages clearly and give this copy to a patient. What does your package include? What does it include? The surgeon fee, implant fee, or whatever. And what does not include? What it does not include is very, very important, because then they will tell you कि आपने तो कहा था ये सब. Very commonly it happens in medicines after cataract surgery. Sir, आपने कहा था सब फ्री में हो जाएगा. हमको clearly बोलते हैं जी आपको लिख के भी दिया हुआ है कि medicines are not included in any package. So all these things has to be really clearly explained. Now I'll tell you 5 cardinal rules which I follow in my practice, 5 or 6, and I think they should go ahead. And I've learned this in the last 10 years. These were I have made all mistakes, but I follow them now. There is a difference between commodity and experience. Coffee में वही चीनी होती है, वही चाय की पत्ती होती है, वही कॉफी होती है, वही पानी होता है, but वो 5 स्टार में 5 रुपए की बिकती है और 30 पे 10 रुपए की बिकती है. You have to tell them there is a difference. You are not eating a coffee here on a 30. You choose your client, you choose your machine, you choose your doctor. But then there's a difference in the commodity and experience, and you have to make them feel that experience. ऐसा नहीं है कि आप बोलो और उनको फील ना कराओ. Experience means जब वो हॉस्पिटल में घुसते हैं और जब वो निकलते हैं, सब कुछ उनका अच्छा होना चाहिए. And invest in that. Second is sell your skills and not the IOL. I see a lot of ads कि हम लोग सिर्फ IOL का पैसा खर्च करते हैं, बाकी सब फ्री में है. अब ये हम obviously हम भी जानते हैं कि हम पेशेंट को बेवकूफ़ बना रहे हैं, but ये करना ही क्यों है? You should tell us I am a good surgeon and I am taking for my skills. अभी भी पेशेंट मुझे बोलते हैं जी लेंस तो 15,000 का, आप 30 क्यों ले रहे हो? भाई मैंने काम किया है, मैंने सीखा है, मैं उसका ले रहा हूँ. आप अगले दिन अच्छा देखोगे, मैं उसका ले रहा हूँ. आप कहीं भी करा लो, लेंस तो 15 का ही आपको पता ही है, 15 पे करवा लो, मैं क्या मना कर रहा हूँ आपको. लेकिन यू हैव टू लर्न टू सेल योर स्किल्स. दिस विल बी वेरी इंपॉर्टेंट वंस यू स्टार्ट इंश्योरेंसेज, बिकॉज इंश्योरेंस कंपनीज ने IOL पे कैपिंग कर रखी है 7,000 रुपए की. आप उसके ऊपर नहीं ले पाओगे. सो सेल योर स्किल्स, टेल देम आई एम अ गुड सर्जन, आई विल मेक यू ओके. आपको ये फीलिंग उनके अंदर लानी है कि मैं ही तुम्हारे लिए भगवान हूँ, मैं तुम्हारी आँख ठीक कर दूंगा. दिस वेरी इंपॉर्टेंट. फाइंड योर निश. सो आई एम प्रैक्टिसिंग इन दिल्ली. Somebody is practicing in Mumbai, the third person is practicing in the second tier town, somebody is practicing in villages. आपको अपनी niche के हिसाब से अपनी setup को build up करना है. Somebody is doing a mass practice, somebody is doing a class practice, somebody is doing IOLs at a profit margin of 10%, somebody is doing at a profit margin of 20%. ये आपको खुद देखना पड़ेगा आप कौन से एरिया में प्रैक्टिस करते हो, आपका स्किल सेट क्या है, what is your skill set. So suppose I am a very confident surgeon, I have high-end machines, I might keep my profit margins higher, but I might do less number of patients. Somebody might do more number of patients. So ये आपको अपना खुद ढूंढना पड़ेगा. This I was telling you, my the OT में मेरे हमेशा गाने बजते हैं. You have to find out your own USP. My USP is cataract surgery in less than 2 songs. So I will tell my every patient that आपका 6 to 7 मिनट में सर्जरी हो जाएगा. एक गाना स्टार्ट करेंगे और सेकंड गाने से पहले आपकी सर्जरी 99.9% केसेस में हो जाती है. So you have to find your own USP. For me, USP is a fast surgery. See, avoid free. Free is a whole. Once you start doing free, you create your own worth and you create your own clientele. ये मेरे एक सीनियर ने बताया था जब मैं कॉर्निया सर्जरी स्टार्ट किया था कि तू 25,000 में ट्रांसप्लांट करेगा या 45 में करेगा, वो तेरी कीमत डिसाइड करेगा. सो वॉट एवर यू वॉन्ट डू इट, बट देन वंस यू स्टार्ट डूइंग अ लॉट ऑफ थिंग्स फॉर फ्री, देन अ लॉट ऑफ हाई एंड पीपल विल नॉट कम टू यू. जब कूटॉन्स की शर्ट 80% डिस्काउंट पे बिकती थी तो उसको फुल रेट पे कोई खरीदता नहीं था, तो उसने अपनी औकात ही 20% की बना दी. सो यू हैव टू डिसाइड व्हाट इज योर ओन वर्थ. एंड फाइनली give yourself time. It is a long-term game. It is not a short-term game. Everybody will take 5 years. My dad was a practicing ophthalmologist. It took me also 5 to 6 years when I joined his practice. So everybody will take time. Give yourself time. It's a long-term game. The last point is learn to say no. If you think यार ये पेशेंट ना बाद में परेशान करने वाला है, जैसे जैसे बाल सफेद होते हैं ना, आपको पता लगता है कि इस पेशेंट को मना करना है. तो learn to say no कि this patient will give me a problem in the evening. Sir, I think I will not be able to, एक डायलॉग मेरा बड़ा फेवरेट है कि सर मेरे को लगता है मैं आपकी ना एक्सपेक्टेशन उतर नहीं पाऊंगा. नहीं सर ऐसा नहीं करो, आप करो हमारा सर. फिर वो अपने आप अपनी औकात नीचे कर लेते हैं. सो यू हैव टू लर्न टू से नो, एंड 2 to 3% पेशेंट्स को ना करने में ही भलाई है, नहीं तो वो आपकी बाकी सर 98% की टेंशन फालतू में दिलवाते हैं आपको. So I think that's what I've learned in the last 6 to 7 years, and I'll be happy to take any questions if there are any. Thank you.
Wonderful talk, Dr. Rajat. I have a question for the panelist. When I was discussing with a few of my friends in Mumbai, one thing you have shown is that you have shown all the packages to the patient. When you are talking about monofocal, toric, trifocal, bifocal, and one of the friends told me that I just keep a single package of 60K, and obviously if patient is choosing a trifocal lens, then it's higher, and in that 60K either he would put IHANS, or either he would put a Indian multifocal, or he would put up a toric. So what's your approach? Make it simple for the patient, or give a menu card kind of a approach?
I don't think having a single package for the patient will work in a city like Delhi. I don't know about because I also keep multiple packages and give patient an option. But I also think that there is a little bit difference between the practice pattern in Delhi and Mumbai, because the insurance rates and the TPA packages are totally different what they offer in Delhi. I was just reading a insurance paper. The GIPSA rate is almost double that what they offer in Delhi is almost 1.5 or twice they offer in Bombay. That is probably some reasons why.
So in Mumbai, luckily, a good percentage still doesn't do cashless.
Exactly, yeah.
So obviously
probably that is the reason, yeah.
And so my thing is that what my friend told me is that most of the patients get converted at 60, and if the patient is not comfortable, then he comes down and he says, I have Indian IOLs, I have monofocals and other lenses also. But he says 60% of his practice is 60K. That makes him a premium.
See, I think if you club two different IOLs with two different properties into one package, I don't think that should make sense, because EDOF will provide you something other than what a multifocal will provide you. So probably you can come. What I would do in your case of scenario would be, I would probably say Indian IOLs का मेरा ये package है जिसमें 2-3 type के हैं. Imported में मेरा ये package है, EDOF में ये package है. But if you combine a EDOF with a multifocal, you cannot probably tell the patient what he is getting into. And if you probably combine a multifocal or trifocal, you cannot combine lenses with two different properties, I should say. But if the lens has similar properties, probably 10% ऊपर नीचे you can combine it. That should be the case.
Thank you, Dr. Rajat.
Thank you.
It was a wonderful talk, and the tips are really useful in practice. Next, I would like to invite Dr. Ikeda. She's a fellow of LV Prasad Eye Institute. She's an anterior segment surgeon and a cornea specialist. She's going to speak on how I took my father's practice to the next level. Thank you, Dr. Ikeda.
Thank you, Dr. Rohit, for inviting me to this wonderful session and for a topic which made me think for almost 10 days that how am I going to approach this. So I put my thoughts together. I'm going to be highlighting few of the salient points about my thought process in the last couple of years that I've been in Delhi. It's been about 6 years now. So since we are talking about how I took my father's practice to the next level, the first thing we will address is what do we really need to run a successful practice, right? First and foremost, we need to be trained, well-trained and competent, and there is no substitute for that. We need to build a practice at a good location where there's enough space so that our patients feel comfortable. And as ophthalmology is a very technologically driven branch, we need to upgrade ourselves constantly. For all of this, we require funds. We need to plan financially. Equally important is the patient experience, and a lot of that comes from how our staff is talking to them. So we need to have well-trained staff, and we need to be visible, we need to be accessible, and we need to market ourselves in the best ethical way possible, with the ultimate aim of developing a mutual understanding between us and, in my case, a parent that I'm working with or a senior that you're working with. And that's what would help you achieve the perfect work-life balance. So let's start with training first. Once we finish our ophthalmology, we have two options. When we are done with our post-graduation, we can either directly join our parents' practice and or we can go for further training and fellowship. So let's look at what really happens in each of these case scenarios. If we directly join the practice, we might be viewed as a trainee or as a junior for a very long time by the patients, by our staff, and even to some extent by ourselves. We might feel that, I can never be better than the mentor that I have. You might not feel confident enough to bring in new procedures. Whereas if you go for further training or fellowship, what you're doing is you're adding to your confidence, to your skill set, and you will be viewed as a trained expert in your field by your patients, by your staff, and even by yourself. You add value to the practice. If you already have a practice to come back to, you're adding value to that practice. You can start new procedures. So I would suggest it's only 2 to 3 years of time in a whole lifetime, if you look at it that way. A rigorous training, there is no substitute for that. And I'm very thankful to LV Prasada Institute for the wonderful training program that they have. So that's the first thing I did before I came to Delhi. The second is location, or where you're practicing. So when I came to Delhi, decided to join my father's practice, he had a clinic inside a residential colony and he was working in Gangaram Hospital. Now patients would search for him and come to him no matter where he was. But I realized this is not going to work for me. We need to be more accessible, visible. We need a larger space. So one of the first few decisions was we decided to move to the main road. This is a new center now, to enhance our visibility and to have larger space, pay attention to the interiors, because overall experience of the patient counts. So they need to feel comfortable when they are coming to you. Then the next step was to upgrade our technology. So we upgraded our existing microscope, our phacoemulsification platform. See, you need to be comfortable as a surgeon. So whereas my father would have been comfortable on what he was using, but I might not have the same comfort level, and I have to find my own comfort level to be able to deliver the results that I want for my patients. So we bought a lot of new equipment. We bought Pentacam, we bought the Zepto device, tattoo gun, and many others, many cornea instruments, of course. And I started to, begin to set up my cornea practice, to get the HOTA licensing and buy all the instruments that are needed for that. So that was the next step. And then we decided that we are going to set up our own LASIK practice, and we are going to purchase the LASIK platform, which is a huge decision financially. And I'll dwell little into it why we decided to do this. So the first reason is that if you have something of your own, if you have your own platform, you will learn so much more, versus when you are going to somebody else's center to operate, you will not have that much understanding of the machine, versus when you own it, then you will know everything inside out about it. Second is, it really helps in enhancing your practice. So if a patient of LASIK comes to me, he would get his parents operated by me. He would not want to go to another surgeon. So the whole family comes to you. It's not just the LASIK that you're doing, but the entire family, their friends. There are a lot of referrals through LASIK. And third is, now we talk about premium IOLs. Now, suppose you do a trifocal or a multifocal or a toric IOL and you have, God forbid, a refractive surprise. You don't have to take the patient to another center to correct that power. You can do it comfortably at your own place. So for all of this, of course, you require funds and you need to plan well financially. And here I truly believe that investing in yourself is the best kind of investment in your practice and in your future. And what we did was we delayed the purchase of liabilities. For instance, I did not exchange my car or buy a new car, or did not buy a house as soon as I came here. So we decided that we're going to channel on that money into the practice. A very important aspect is how we are talking to the patients. We need to be confident and comfortable, and both are equally important. And what I really mean by comfortable in your own skin is that when I came to Delhi, I heard a lot of, oh, wear a sari, you need to look older, you're a female, patients would not want to get operated by you, you look too young, they'll compare you to your dad and they'll all go to him. So I did not listen to any of this advice, because I know what I'm comfortable wearing. Of course, you need to be well dressed and you need to be formally dressed. But if I'm not wearing comfortable wearing a particular attire, and that gets transmitted, patients can feel your vibe, your energy, and they know that if you're not comfortable, you're going to transmit that to them. So this is something that I think we should avoid. We should be comfortable when we are talking to patients. Be confident and speak in clear, simple language, in language that they can understand so they feel connected to you. Another very important thing that I felt was crucial was I never forced patients to get operated by me. If a patient of cataract came to our center looking for Dr. Harbanslal or to get operated by Dr. Harbanslal, I always told them it's completely your choice. We both operate, and whoever you're comfortable with, you can go ahead. And also avoided over-counseling or seeming too eager to operate, and that actually brings the patients back to you. When you try to coerce them too much, I feel like you drive them away. They feel like something is off. And a very important aspect is that we kept the same consultation and surgical charges for all consultants in our center. For instance, which means basically that I kept my charges and my father's charges, we kept the same. We did not decrease my charges, because that you are automatically downgrading yourself. If you, as soon as you join and the junior's charges are lesser, then that, creates a difference in the patient's mind. So this is something I completely and strongly am dead against. We should not do. Then, of course, we increased our staff. So my father had a staff of 5. Now we have a staff of 25. We hired trained competent optometrists. Training the staff for cornea procedures was another important aspect. And now over the years, what I've realized is that I never do financial counseling by myself. I talk to them everything about the different packages, different IOLs, but I tell them the financial aspect of that will be dealt with my counselor. And I often feel that the counselors are able to negotiate much better than as doctors we are. So now over the years, I've completely stopped doing it. As much as possible, I avoid bargaining with the patients. And of course, to keep the staff motivated and well-trained. Documentation again becomes very, very important. We started with our EMR, we started with the proper consent form for various procedures, and of course, we need good slit lamp photography, being an anterior segment surgeon. I would just like to end with this slide. At the nutshell, or to summarize all of this, what is really important to make it work, whether it's your family member, your parent, your father, your mother, or even a senior, is to have respect for each other, to know that both of the surgeons are equally skilled, to trust each other's approach and decisions, and that would help you to split responsibilities, and that will ultimately help you to achieve the perfect work-life balance that all of us are striving for. Thank you so much, and I'd be happy to take any questions.
Because of the paucity of time, we'll move on to the next talk.
Sure.
May I invite Dr. Nikunj? And he is a refractive and cataract surgeon in Indore. He'll be talking about starting a refractive practice from scratch in a new city.
Like, I agree with what Dr. Ajat sir said, that it takes you around 5 to 6, 7 years to, even if you are a second generation ophthalmologist, to take over that patient load. Because I still remember when I joined my father's practice, I used to see patients, and abhi bhi I see a lot of patients. I see them in a heavy OPD and I dispose them, and their question is, Doctor Saab nahi dekhenge kya? So you have to give time and make them believe that yes, you are also practicing. Even unfortunately, like when I joined my practice, my dad stopped operating after COVID. So that time also a lot of patients used to come, and they used to even say like, "Theek hai, aap kar lena," but he'll be there in the OT. So it takes time. You have to be patient and give time to it, even if you are a second generation or third generation ophthalmologist.
The transitioning takes time, right? So, Nikunj, over to you.
Yeah, so thank you so much. I would like to thank Team YOSI for giving me this opportunity today to talk about starting a refractive practice in a new city from scratch. So let me just start with a little bit about me, that why I'm talking about this. So basically, I'm from Gujarat. I did my undergrad and postgrad from BJMC Ahmedabad, followed by Narayan Netralaya at Bangalore. My wife is from Bhopal, and she did her MBBS and studies from Indore. So that's how Indore was there in our picture. And I'm currently where I'm working is actually not my own setup, but is Dr. Kushagra Jain, and his father takes care of the setup. He is a very good friend of mine from my PG days. So I started as a cornea cataract refractive surgeon in 2021 at SRJ Netralaya Indore. So it is a new setup completely. We started it from, I'm associated with them from the first day one, from ground zero. Even I've been aware about the hospital when it was under construction by itself. So we are actually a team of 4 doctors. Dr. Kushagra is a vitreoretina surgeon. He takes care of UVI and ROP as well. My wife is there, Dr. Shivani. She is a glaucoma and cataract surgeon. She takes care of her own specialty. And we have another orbit and oculoplasty surgeon who is also a very good cataract surgeon. And that's how we complete the team at our place. So why refractive practice, and is it just about LASIK? So when you are thinking about refractive practice, wherever you are practicing, you have to understand what is the scenario in your own area and is there enough demand of that. And apart from that, there are other certain factors that you would like to consider. So I'm going to talk about those in a quick time. So first thing is market consideration. So if I talk about Indore, so Indore has been a very famous for refractive surgery since the time of radial keratotomy, RK surgeries. Many senior surgeons may be aware of Dr. Hadia, who used to practice RK in Indore, and people used to like crazily come to Indore just to get operated for RK by him, and from all over the parts of India and even outside India. That's what I've heard. So another thing is, when you are starting a refractive practice, you have to think about cost consideration because the investment is huge. So I'm working with Dr. Kushagra and Dr. Rajesh Jain, who takes care of this setup. But Dr. Rajesh Jain is a physician by himself. He has other 3 hospitals, multi-speciality hospitals. So they have a good financial backup. So the investment part is taken care of by actually them, but I'm handling the rest of the things. And obviously you need to be a surgical expert before you start wherever you are starting in your field, right? So I will be talking about 3 different things. The first thing is the man behind who works tirelessly for you and your LASIK setup, where we need to have a good LASIK assistant, because the machine related problems are very troubling whenever you are starting, especially you are also new in that area, and there are a lot of problems which we have faced related to gas, argon fluoride gas, or machine related glitches. Sometimes the table is not moving. All those things has to be handled by an expert, and you cannot call engineer each and every time. So we have an assistant who has 15 years of experience exclusively for LASIK. He's also an optometrist, and he's a very good human being. He has seen more complications in LASIK with different surgeons than I have done myself till now. So that is also very important. When you start about refractive practice, you need to have a competent LASIK assistant who is exclusively work for LASIK, or at least know a little bit more about machines than you do. Another important aspect is obviously the machine when we talk about LASIK. So we have Alcon Wavelight EX500. We don't have Femto yet because it's a new practice. We are working with MK, Moria SBK, Microkeratome, and both of them have good track record, and we are able to give good results since we started. So this is the machine, and you need to have good mentors. So I did my long-term fellowship in cornea, but for refractive, I did a short term with Dr. Rohit Shetty sir and Narayan Netrale, and Dr. Pooja Kamar is also there. I mean, it is actually the temple of refractive surgery in India. So obviously, when you are starting, it's basically for young surgeons. You need to start with a wet lab. Obviously, just like any other surgery, we learn. And obviously, you cannot directly jump into sitting directly on a patient when you are operating a refractive patient, because you are dealing with a crystal clear 6/6 vision, and you need to give it without glasses. So I mean, there is a very little margin of error when it comes to refractive surgery. So I have learned this from my cataract days, that I always have a habit of recording all of my surgeries. So be it PRK, be it LASIK, it is important to record your own surgeries, because there are so many minor mistakes also you are going to make when you are starting out, or even if you are practicing for longer time, because complications and difficulties are going to happen if you are operating. If you are not operating, you will not have complications. Simple as that. So it is important to record surgeries and look back whenever you get the time, because there are certain minor things like if I talk about LASIK, so there are certain things that if we are working with a microkeratome, right? So for microkeratome, choosing the right ring size, getting a correct flap size, centration, all those things are different for each and every cornea, because keratometry values are different for each and every patient. So with experience, you come to know that for this cornea, this size of ring is going to make a good flap with a central flap and stuff like that. So recording is very important when you are starting out. You need to have a good mentor, a guru who can help you when you are in trouble. So I have one, Dr. Satish sir, who is practicing as a refractive surgeon in Indore for last like 35-40 years, and he has been very kind enough to guide me when I was completely new in the new city. So important thing is, see, refractive surgery is not more about skills. It's all about patient experience. It's all about the guidance, how you guide your patient. So I spend a lot of time for my counseling, especially when you are also having a new practice. You have time for counseling, and you need to give time for counseling because there are other surgeons, and refractive practice is very common nowadays. And patient can get surgery everywhere, anywhere. But when whatever time you give for your counseling, it is important for patient to connect with you, right? So I always talk with my patient, explain about their refractive power, how we are going to do the surgery, what are the pre-operative things, intra-operative things, post-operative things. I always show them pictures about the surgery, and there are certain patients who want to see the surgery also, and I always ask them first, because you have to take showing the surgery a little bit carefully, because certain patients, they get scared after looking at the surgery and looking at the microkeratomy. If you are practicing microkeratomy, or even if it is femto, it can be scary for certain patients. So whoever is agreeing or comfortable seeing the surgery, I show them. Otherwise, just pictorial representation is also good enough. And just to enhance a little bit of experience, we have a glass window in our LASIK OT, which is obviously we have taken into consideration about the sterilization part and everything. So that gives an experience to the families. Actually, it is not our own concept. It is inspired by Dr. Arun Gulani, who is a refractive surgeon in Florida. He has kept a window for relatives to see when their somebody is getting operated for LASIK under him. Similarly, we are also we allow the patients, relative who want to see their child or somebody, whoever is along with them, their surgery, they can view it. So it is just to enhance the refractive practice. And obviously, never forget the reviews. As Dr. Akshay Nair and all of my other friends have talked about nicely about that, how the social media is playing important role. So obviously, we are doing all the social media things which has been talked about: Instagram, Facebook, Google reviews. It is very important, and they have already talked about the pros and cons of each of things. So it is important to have that. I have got many patients who have read about Google reviews about us and they've Googled it. They've done, their research in itself in the city, that what are the other hospitals providing, what kind of machines other hospitals have, what kind of machines we have. And after that, they've come to us. So Google reviews are very important. And when it comes to refractive, don't just limit yourself to LASIK and PRK. If you are a good cataract surgeon, and obviously if you have to understand about, you understand the tissue handling and intraoperative machine handling and all those things, obviously you can think about phakical practice as well. So I do a lot of ICLs and IPCL as well. So it is important to have more than multiple options for when you are actually talking about refractive surgery, because not all of your patients are going to be eligible for LASIK, right? So I'm not going to show the complete surgery as due to paucity of time, and it's not about that. Another important thing that we discussed, that you need to have a good relationship with optometry friends, because there are a lot of optometrists who are actually practicing, and they have their own practice, they have their own patients. And many of the refractive patients, the first person of contact is actually their optometrist, from whom they are getting their glasses. They are regularly getting checked by them, and so many patients even consider them as doctors as well. So I mean, that is how you get your referrals from them. And just to highlight that, we recently did a CME just with optometrists on the World Optometry Day, and we talked about how refractive surgery works, how the corneal surgeries work, and stuff like that. So it is important to have that.
Dr. Nikunj, can I request you?
Yeah, just last slide. So just to, it is important to make your patient feel extra special. So we take photograph with all of our LASIK patients, we post it on social media, and we share it with them, so that whenever they see their photograph or something about it, or it relates to that they have got surgery at our hospital. And sometimes even if they want to refer some patient, they will definitely think about your own hospital when they see the photograph, right? So just to conclude quickly, in 2 years we have operated many patients. I'm not going to go into details about that. And it is important that it is all about patient experience, because surgery, obviously they can get anywhere done, but experience is important. Thank you so much.
I would request Dr. Dibakant Mishra to felicitate our panelists. Request Dr. Pooja. I would like to invite next Dr. Zain. Dr. Aman Khanna.
request Dr. Rohit Modi to kindly honor our speakers. First, may I have Dr. Abhishek. May we have Dr. Akshay Nair, please? May I request Dr. Rajat to please join us? May I request Dr. Ikeda Lal to please come up on stage? Last but not the least, Dr. Nikunj.
Requesting Dr. Devakant sir to honor Dr. Rohit Modi for planning an excellent session and conducting it so well. And requesting requesting Dr. Rohit Modi to honor Devakant sir for moderating the session. Right. So, welcoming next team, medical legal team on the dais to take over.
I invite you all to our medical legal session. Can we have the slide, please? This has been my dynamic team with Dr. Harti Heda, Dr. Dipanshu, Dr. Sayantana, and Dr. Devanjan. We have been arranging medical legal webinars every monthly on third Fridays around at 9 p.m. and they have been uploaded on YouTube also. Please have a look. We are a group. We are trying to increase the awareness of medical legal issues among young ophthalmologists. It is my privilege to introduce Dr. Anujit Paul, who is currently a vitreoretinal fellow at BBI Foundation, Kolkata. He is a recipient of IGO Platinum Award 2021. He also received TNOA Gold Medal in 2021. He has to his name 23 PubMed Index publications and he has presented papers in state, national and international forums. He is passionate about ophthalmic education and research. I'll invite Dr. Anujit Paul to please come to stage. Please. We have with us Dr. Sahil Bhandari, who is currently a vitreoretinal and cataract surgeon at Guru Hasti Chikitsalaya, Pipar, Jodhpur. He is a recipient of AIOS Sun Pharma Quiz, Irudio and AIOS SNEC fellowships. He has 20 PubMed Index publications in PR Index journals and he has presented papers in multiple forums and he is passionate about academics and mentorship. It is my privilege to introduce and welcome Dr. Deepsekhar Das, who is currently the assistant professor at Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIIMS, New Delhi. He is a consultant in oculoplasty and pediatric ophthalmology. He has multiple peer-reviewed articles and he is passionate about academics and mentorship. Our speakers include Dr. Prakriti Garg, who is a DNB student at iCare Eye Institute, Noida. Dr. Sayantan Ghosh could not be present today, but he has sent us a video. We'll play that. He is an assistant professor at CNMC Medical College, Kolkata. He has also done, along with MBBS, he has a LLB degree. He has special interest in medical legal issues and he has presented papers in state, national and international forums. We have very dynamic artist Subhas Heda, who has been the backbone of this team. She has a degree in medical legal aspects, which is called PGDMLS. She is a consultant and anterior segment surgeon in Pune, NIO. She is the associate editor of Global Journal of Cataract Surgery and Research in Ophthalmology. She is the surfing the anterior segment is the brainchild of her. She is also a team member of medical legal cell and academic team of AOC. She is one of the most dynamic members of AOC and we are thankful for her great contribution to the society. And she is the national and international coordinator for International Society of SICS. She is EO committee member of Pune Ophthalmic Society. we have very dynamic Dr. Dipanshu Agarwal, who is a vitreoretinal surgeon. He did MBBS from Bangalore and DOMS from B.R. Ambedkar Medical College. He also is very active in medical legal sales, and we have been it has been possible to continue the sessions with the sincere help of our team. And I am Dr. Kaushik Tripathi. I am a consultant vitreoretina and UVA at AIOS Hospital, Kolkata, and I have editorial positions at IOWiki and StatPulse and clinical case reports. Thank you. I'll now invite Dr. Prakriti to please come on stage and deliver his talk, hard talk. We'll take the questions later because we are already going out of time. After the talks are over, then we'll take the questions and discussions. Thank you.
Hello, good afternoon everyone. Myself Dr. Prakriti. I'll be speaking on the topic of informed consent. So this is basically what we do not want in our clinical scenarios. Now coming to what is the definition of informed consent, as directed by the AMA, it is stated that it is the process of communication between a patient and a physician that results in the patient's authorization of agreement to undergo specific medical intervention. What this means is that the consent should be voluntary, that is, the patient should give it under the free will, not under any influence of fear or misconception. It should be informed, that is, it should be given after knowing each and every detail, pros and cons of the procedure. And when we think of consent, just a picture of a form pops up in our mind. This is not at all true. Consent is not just a form, it is a whole process which begins right at the advertising stage till the patient ends up in the OT. So who are legally valid to give the consent? As per the section 90 of IPC, the following all are legally able to allowed to give the consent except three situations. First, the patient should not give it under any influence of fear or misconception, and the person taking the consent should know that he or she is not creating any fear or misconception in the mind of patient and the attendants. Second, the consenting person should be in a non-toxicated state and in a complete soundness of the mind, and can comprehend the situation for which he or she is giving consent to. Next, legally stating under 12 years of age, child cannot give consent. For such a child, the guardian gives the consent. Now, why is it important? The two main reasons are the ethical, moral, and the other is the legal one. Now, stated under the section 3.5 consent under the duties of physicians, it states that a physician must seek a fully informed consent prior to the performing a treatment or a procedure in the presence of witnesses. Now, the next important thing is the legal issues. First of all, there is no such law as which states that a consent is a must, it is a compulsory, but it is highly recommended for the following situations. First, like if a patient, specifically a female comes with a with a case of immodesty, then a informed consent taken and in the presence of a female attendant will help save the doctor in that situation. Next, written consent also helps in protecting the doctor from civil and criminal liability. As stated in the section 87 of the IPC, if a patient undergoes sustains death or grievous hurt by a complications or risk of a procedure for which he or she consented, and in such a situation, the doctor is not liable provided there is no negligence involved. So this is important thing, that consent will not give you immunity for any negligence, because the consent was taken for the complications and risk and everything, but the cases are usually filed for the negligence or the substandard treatment given in the facility. So in that negligence case, the doctor is liable under section 304A of the IPC. Next, the thing is marketing and advertising. They can also be considered to be part of the informed consent process by the courts. So while making them, we need to keep in mind that there should be no deceptive material. All the risk and benefit should be portrayed in the equal proportions, and all the claims should be those should be made which can be fulfilled. No tall claims, and as they commonly say, promise less and deliver more. Next is when should it be taken? It should be taken well in advance and not on the day of the surgery, so that patient can go to home and take time to weigh the risk and benefit and then make the decision. And sometimes not too in advance also, because they say that they have changed their mindset till the time they got operated. So what we can do is, on the first of all, when the patient comes for the counseling and everything, we can give them the consent form, ask them to go at home, read about it and make decision, and come back on the next day with the queries, solve them, and then have them sign the consent form. Certain situations when it is not necessary, like first is the emergency situations. In that, we have to keep in mind that emergency is the one which is life threatening in such a case, and the patient is not able to give the consent, not able to give, and because a patient might be in delirium or any other language issues, and the substitute decision maker is also not available, and we can prove in the court that it was done in the best interest of the patient. The thing to keep in mind is that in emergency situations, patient not able to give the consent and patient not willing for consent, these are two separate things. If the patient is not willing, then we can't force him to give the consent. And in such a situations, it is better to have a written statement with the patient stating that I am not consenting. Okay, the next situation when we do not need consent is therapeutic privilege. This states that if a doctor thinks for the psychological well-being of the patient, it is not necessary to give all and each and every information regarding the procedure, then he or she can get away without giving the all details. This is therapeutic privilege. Next is therapeutic waiver, in which some of the times we see patients saying that I'm okay with whatever decision you make. I don't want to get involved in the decision making part. So in that situation also, we can go ahead. Now next is what all to document while what all should be there in the consent procedure. First, we have to describe the nature course of the disease and the consequences it will have, and why the procedure is necessary, how it will go about, what will be the probable risk and complications, what are the alternative solutions like refractive surgery versus spectacles or other examples. And next we have to clearly tell about the end result, that we are treating only for example for cataract, we are treating only for the cataract and not for the refractive part, and other ocular pathologies which might hamper the visual prognosis. Next, we should tell about the cost and the comparative cost, like for the Indian IOLs and the branded IOLs, and all the anesthesia risk involved. While documenting, we should have a surveillance of camera or voice recording, or in the presence of two witnesses, signature and thumb impression, date and time, contact information, all should be taken care of. And one thing is, we should try to keep it a hard copy, not a soft copy, because it can get corrupted. Now next point while documenting is language. That language should be the one which is understandable to the patient. In case the patient's language is not available and we are using a translator, then the name and relationship of the translator should be documented. It should be clear and unambiguous. Next is procedure-specific consent forms. We can get away with just one consent form with blank for the name of the operating patient and the name of the operating surgery. We need to have different consent forms for each surgery, because we have different complications and different risk factors and different procedure for all. So these are few of the AIOS consent forms that I took from their website for the cataract, and both in the English and Hindi languages, and any other native language that is required. At last, I would like to conclude that informed consent is informed, voluntary agreement given by a sound mind adult or the guardian. It is ethically and legally important, should be taken well in advance, and it's not just a form. Thanking Dr. Nupur ma'am for helping me introduce to the YOSI Society and encouraging me to take up this opportunity, and Anujit sir also for helping me with the content. Thank you for being a patient audience.
Just I want to know what's your take on generally video consents. I mean, how frequently do we take actually the video consent?
Sir, it is preferred if we take a consent video recorded, especially in the cases when it is a very guarded visual prognosis, or in the cases we think the patient might in future land up with a case against us, like a patient going for a premium IOL and
And do you give any kind of written, when we take a written consent from the patient, do you give any copy to patient also, or do you prefer, is it a more of a
It is advisable if we give a copy to the parents, to the patient or to their relatives, so that they can read it in detail at home.
and as you mentioned, if a person is not willing to give consent,
Yes, sir.
so should we go ahead for treatment or just deny the treatment?
No, we should obtain the written statement that patient is in sound state of mind and is denying the treatment and is not giving the consent, so he and she is referred.
But like from a legal point of view, is it safe even if it, because these written statements, I don't think so they have value. And when we go into the court of law, and most of the things are denied. And, like most of these written things are not of any value, as you yourself mentioned. So in the, I'm not very sure if patient is really not willing to give consent. What do you think, Dr. Vashi?
If patient is not willing, then if it is a cold case, if it is a routine case, you have like it is legally unsafe to operate such case because he is of safe and sound mind. He is not consenting. He is a human, not goat or something. You cannot operate. But if it is an emergency and a life-saving situation, and you think that patient is of unsound mind, and if that thing is not done immediately, that the death, there might be death or some fatality. That is, there is some emergency. In that case, you can try to revive. Like some person is dying, you have to do CPR because there is no, you cannot take consent that time. So this is when there is a life-saving situation or there is an emergency situation, then you can go ahead without consent. But definitely, if patient is of sound mind, you cannot operate a patient if he or she doesn't give consent, and or if he or she understands. Sometimes you explain the consent and patient says नहीं आपने ऐसे GVP कैसे बोला, मेरा तो जस्ट कैटरैक्ट है, विजन क्यों नहीं आएगा पूरा, आपने समझाया उसके बाद भी पेशेंट बोल रहे नहीं सर मेरे तो सभी को कैटरैक्ट होता है, ऑपरेशन हो जाता है, नॉर्मल विजन आ जाता है, मेरा नहीं होगा तो कैसे करेंगे. इफ पेशेंट हैज डाउट इन माइंड एंड इफ पेशेंट डजंट ट्रस्ट यू एंड इफ इज नॉट गिविंग consent, do not proceed further, do not operate. पेशेंट को आप बताइए, आप you go home, you search details and you read about thing. If you think that you want to get it operated under me, you can get operated under me. You can take second opinion, encourage the patient to take second opinion. आप जाइए और किसी को पूछिए, and if you consent for that, if you are willing for the surgery, and every surgery has risks, if you are willing for the risks, then only we will go over for surgery. Thanks, Dr. Prakriti, for an excellent talk. We'll take the Dr. Sayantan's recorded video now. Unfortunately, he could not come today.
A very good morning. So I'm going to present on how to respond to a medical legal notice. I'm Dr. Shantan Ghosh from Calcutta National Medical College, Kolkata. So what is a medical legal notice? What is medical legal? Medical legal comes from medical plus legal, although it's a misnomer. The second one is who can send you a medical legal notice. It can be a lawyer's notice, it can be done by a court, or it can be done by different bodies, maybe private or government. Now, if it is done by the court, you have to see the hierarchy of the court. Which court is actually sending you the notice? It can be a consumer court, it can be Supreme Court, or it can be High Court. Weightage given to all these courts are different. Like a consumer court, you have got a time for 21 days, but for Supreme Court, usually the time is written over it. So the time refers exactly, either time referral is exactly given in the notice, and if not, then implied in the notice. So time is important. It gives you the leeway when you need to react after getting a notice. Now, what to do in case of a legal notice? Like we being lay doctors, so first of all, when a legal notice comes, we think that we are going to land up in jail. So read between the lines. First thing, who sent the notice? Why the notice was sent? And is there any time limit given to reply? Now, all physical and oral communication with the party in case of a doctor versus patient suit should be stopped immediately. This is very important. Suppose you have treated a patient A, and still there are communications going on with you and in between you and the patient A through many forms, maybe WhatsApp, maybe call, or maybe clinic visits. But at the same time, you are getting a notice from the patient A. You should stop any kind of communication with that patient. at immediately, and that's prevention is here. Notices by bodies, this is a different kind of a notice. It can be given by a government body, like the hospital if you are a government doctor, or like any department of the government you have been working to. So first thing is you should follow the rules. So what are service rules? If you have engaged in a government service, there are service rules. For individual state services, there are service rule. At the same time, for central services, there are service rules too. So you need to know what are the service rules. This is kind of a general thing granted by the court, that minimum 3 unanswered or unsatisfiable show cause notices are there before suspension. So any legal notice by the government body even does not mean termination. It's a distant option. Even suspension is not termination. Termination is getting rusticated from job. That's a very difficult thing for the government to do, because it has to prove that you are incapable of doing the job. Chances of defense is always there. So that this defense starts from the lower down government categories to the higher ups. Like you can go to the immediate boss of yours, to the principal, or to the principal secretary. So there are layered or hierarchical defense system. Hierarchy of appellate bodies are always there. And the legal sections, so what are the legal section under which you can get a notice? It can be a summon, it can be evidence, it can be privacy laws. Negligence can be criminal or can be summon. So what is summon? Summon is even asking court or any body is asking you to present your case before them. What is the evidence? It can be an oral evidence. You have been given legal notice for, like to give a oral description of the facts, or any prescription. That's a substantial evidence. And what are the privacy laws? This is very important, because whenever you are asked to give an evidence in a court, be very careful. Are you breaching some privacy laws? Or even in the legal notice itself, is there any implied privacy laws? These are the most commonly used laws against doctors. First is Consumer Protection Act, and second is Prevention of Corruption Act. In fact, these acts have been modified so many times, but doctors have never been debarred from these acts. So what is negligence? These are the terms, common terms used in legal notices. Negligence can be criminal or can be civil. Naturally, criminal negligence has more weightage than civil negligence. It can be a more severe kind, like homicide. And now again, it's a culpable homicide not amounting to murder or amounting to murder. And death by negligence. So death by negligence naturally comes under the criminal negligence. These are the possible ways you can be convicted upon. An injury can be deliberate, can be not deliberate. So you have to prove that an injury done to a patient during surgery or during any procedure to be non-deliberate. And the notice will be sent that the allegation is there that the injury is. Now, for this deliberate injury, culpable homicide, it's very important to have a proper consent form, because whenever you are doing an intervention like surgery on a patient, it's very important to get at the bottom of it. So you should have a better consent from the patient, or if not possible, then the patient party. First of all, demographic details should be there. So confirm the identity, especially if you are doing an institutional practice. Probably very difficult to personal practice. You cannot ask for Aadhaar card from each and every patient. Remember, suppressed identity is a good defense for a suit, but for your sake or for institutional sake, confirmation of identity is a good thing. For a minor, the identity of the informant should be noted. If it's mother, his or her mother, then this mother's identity should be confirmed. Consent for a minor and major procedures are different, definitely different. A major procedures, the consent form already AIOS has consent forms in their websites. These are quite detailed consent forms. But for minor procedures, these consent forms are different than the major procedures. Now, having a consent form and explaining a consent form is different. If you can't, then probably you should hire an assistant to explain the details of the consent form. For a major surgery, all surgeries available should be explained. This is again important from the point of view of a doctor, that for a simple cataract surgery, you better explain that these are the options you are having for cataract surgery, and this is the reason I am opting for a phaco emulsification. So this is just an example. Similarly, for a vitrectomy, you have to explain that this should be done and this could have been done, and I am preferring this option other than others. Patient should understand why the intended option is rather better than the others. Possible side effects should also be explained with each and every option, each and every intended surgeries you are explaining. Outcome in case of uncomplicated surgery, outcome expected would be, that should be in your explanatory part. Otherwise there will be unrealistic expectations. In case of best possible surgery, the outcome would not be better than, especially in case of vitrectomies. So you better first underestimate your outcomes. That's a better option than overestimate. Who will sign the forms? Patient should sign the forms in his or her own vernacular. If patient can't read or write, then the relative. If not, then attendant. If not, then other party, especially in the emergency situations. Take a LTI of an identify and also signature. Doctor should countersign the patient party relative attendant has consented after being informed properly in front of me. This is in fact from a case law, that rather in presence of me, the front of me is a better option. There are legal battles for that. Now, who will sign the forms? Because legal notice comes from that too. Suppose you have given a fitness certificate for a BSF or CISF personnel from your chamber, and the person has been refused by the board there, and you have been called upon by a legal notice in the High Court. So, fitness certificates are to be taken care of there too. It gives you a very paltry amount of money, but can give you a lot of headaches. So evaluate very diligently. Commonly missed things like fundus examination should be done, and peripheral retina should be used. Lattice and hole have been cited as the chance of cause of refusal for a BSF recruitment. Color vision, number of plates should be there. Especially if you are signing for any fitness certificate, ask for what are the standards they are having. Usually in the advertisement, the standards are given. An adnexa should be there. So ptosis, if you are missing a ptosis, even if in a mild ptosis, the patient actually may be refused in Army Recruitment Board. Take the signature and the photo of the certified if possible. Photo is always good. If not, then the signature, and that should be attested by you. False identity is a great defense. At least the signature should be attested. Your signature should be clear and full and short, and if it's short, then better be of one type rather than be of multiple type. Lastly, do not oversell. So if you are giving Botox, do not oversell that you don't require repeated injections. For cataract surgery, premium, toric, multifocal, how much difference they have from the normal IOL, you better explain, and do not overestimate that yes, multifocal is best for you. Kind of that. And vitreoretinal surgery, chances of rebleed, like if you are doing a diabetic retinopathy retraction, TRT, and there are chances of rebleed there. So explain it from the first hand. Do not oversell yourself in face of competition, right? So to summarize, any medical notice or answers to be prepared through a lawyer or by a private bodies. If the corporates, then you should check the agreements and clear the gray areas, and the medical record should be kept there for at least 3 years, and if possible for 5 years. Thank you.
Clearly AI is taking over. Panelists must be finding it difficult whom to discuss it with. Now I would like to invite Dr. Kaushik Tripathi sir to give his talk on professional indemnity insurance. Over to you, sir.
Thanks, Dipanshu. So I'll check whether people are awake or not. So I'll ask who doesn't have indemnity insurance till now in the audience and in the panel? Indemnity insurance. Do we have anybody who doesn't have indemnity insurance?
Who does not have, please raise the hand. I think we have one in the audience, back at the back.
So
Bhavya has.
there are fellows, but once you start practicing, it is must to have indemnity insurance. So I'll discuss why, when, who, which, and how of this indemnity insurance. Why? Because there is very high compensation approved by Consumer Protection Act 2019. Does anyone know what is the maximum amount which can be compensated by order of the national body formed by Consumer Protection Act? डॉक्टर भव्या कितना 10 crore. ठीक है, तो डिस्ट्रिक्ट अप टू 1 crore, स्टेट 1 to 10 crore, नेशनल लेवल दे कैन गिव पेनल्टी अप टू मोर देन 10 crore. ठीक है, and also there are multiple judgments in which the compensation has been allowed very high, and add to that the interest. If the court case is going on for 10 years, 12 years, and if you add to that 8% or 18% interest rate, then if it was 6 lakh, you will have to pay 12 lakh or 30 lakh because the court case itself went so long. Whenever you are starting a practice, if you are practicing, if you are seeing patient, if you are not operating that time also, if you are seeing a patient, whenever you are managing a patient, you need to have indemnity insurance. Because कभी कभी किसी की कोई लोग बोलते हैं मर्द को दर्द नहीं होता, मेरे को कुछ नहीं होगा. ठीक है, आई एम प्रैक्टिसिंग एथिकली, आई एम वेरी कॉम्पेशनेट, मेरे को कुछ नहीं होगा, मैं गवर्नमेंट सेक्टर में हूँ, मेरे अगेंस्ट कुछ नहीं होगा, हॉस्पिटल के अगेंस्ट होगा. इट इज नॉट दैट. देयर आर मल्टीपल केसेस अगेंस्ट गवर्नमेंटल सेटअप, अगेंस्ट पीपल हु हैव ट्रीटेड देम इटसेल्फ. लोग आएंगे, लोग देखेंगे कि लिस्ट में डॉक्टर कौन से डॉक्टर का नाम है, सबके नाम पे डाल देंगे, कोर्ट जो नोटिस जाएगा सबके नाम पे चला जाएगा. तो इफ यू हैव नॉट डन इट येट, गेट इट टुडे एंड कंटिन्यू इवन आफ्टर रिटायरमेंट्स, बिकॉज you might have operated some case and they sometimes after some day they feel that yes, the problem they are facing is due to your negligent surgery or your negligent management, then they can actually sue you. So doctor should definitely get himself insured. You have to insure your hospital also and cover all qualified and unqualified staffs. This is important. If you reduce the cover without unqualified staff, the premium reduces, but you lose the chance if there something happens due to the fault of your unqualified staff. If you are transferring a patient on wheelchair, he falls down, he breaks a leg, then this is fault. This is actually human error by the staff, but the vicarious liability will be on you and the hospital. Get it insured. And as I said, providing ethical or compassionate or charitable or humanitarian work or working in governmental setup doesn't protect you from medical legal issues. So it is, you might have done your best, but how patient perceives about you, that is most important. You might have done your best, you might have done the best thing, आपने मल्टीवोकल लगा दिया, everything is okay, 6 N6, patient is seeing everything, but patient को जो खिचखिच हो रहा है, आँख में जो गड़ रहा है, that is a problem. And they'll think कि आपने कुछ गलती कर दिया, कुछ लेंस गलती से डाल दिया, and they feel that you have done something wrong. That is the problem, and they can submit negligence, medical negligence case against you. Which insurance to take? So this is a difficult decision. So there is something called AOA and AOY, that is aggregate 1 year and any one accident. So if you take 1 crore sum insured and if you make the ratio 1:4, then the premium reduces, because the insurer will say that I'll give you 25 lakhs for each case, not more than that. If you have 4 separate cases, you will get 25 lakh each for this thing. So this is a wrong plan for you. Though premium reduces, you are in the losing end. You have to take an insurance which has AOA is to AOY 1. That means even we are not negligently operating or negligently doing. This is a rare scenario, and this will happen very rarely. And it is very rare that 4 people will submit, 4 cases will be submitted at the same time. So this should happen, that my cover should be 1 crore, and even if one person applies for a case against me, I should be able to take this cover 1 crore. So retroactive date is another concept in which the date in which you started your medical indemnity insurance, that is the retroactive date. So you need to continue the policy. You can transfer to other service providers, but you have to renew your policy before 1 month of the policy, so that you can continue the retroactive date, because people might challenge you for cases you have done before also. Minimum sum assured is one of the most important thing. Does anyone know what is the minimum cover which is recommended by medical legal experts in ophthalmology? How much should I have minimum cover in India for a individual doctor? At least 1 crore. At least, because you are operating surgeon, most of the ophthalmologists are operating at least 1 crore. If there is hospital, at least 2 crore. There are certain group insurances which have some total, they take, like they have 100 members, they have a sum insured of 15 crore for everybody, and this is a common policy. In this policy, if the members, 1 or 2 members consume the sum insured, then other people are just, they will be hungry. If they are a case arises against them, they will not get the money. So get a individual cover, and try to look for society endorsed brokers, because they make a good deal and they can get your premiums cheaper. They should have expert legal support. That means they should have a legal lawyer support, and this lawyer, there is the lawyer who are LLB, they might not have knowledge about the medical legal issues. So medical, they should have senior panel of doctors and people who have medical legal degree, preferably people who have MBBS and LLB both. Also check what other your friends are doing, and check for testimonials. Ask your broker to how to give the numbers of people whom they have helped. There is an interesting thing which is called co-payment clause. They are saying that they will give you 1 crore, but they will not give you 1 crore. There is a minimum amount which you will have to pay. The majority of the A will have this 1.25% and minimum of 12,500 by ICICI Lombard. But I only found out my policy, United India has 5% co-payment and minimum 1 lakh co-payment for me. So this, if it is 1.5, 1 lakh 5,000, then they'll give me 5,000. I'll have to give 1 lakh. And also ask them about the claim settlement ratio. That means how many claims they have settled. So insurers, they want your premium and they do not want to give you money when you need it. So, and if they allow you out of the court settlement, and if they allow all, if you operate, there are many surgeons who operate at multiple places. If they allow outside like your main premises, you will have to ask whether it is covered or not. And also look for if other associations have contacted the broker, and if they have association with that. And also will the broker or insurer give you choice of own lawyer, and will they pay them? And there are certain provisions in CPA that if lower court has ordered some penalty against you, if you are trying to go to the upper court, you will have to provide 50% of the penalty to the court, deposit as security money, if whether the insurer will give you that. And definitely look for discounted premium, look for exclusions. So these provisions are usually there. Use of spurious prohibited drugs which can be used for Avastin also. And many insurances will not cover clinical trials, criminal acts, misrepresentation, or it is done before a retroactive date, or if you are operating under alcohol or something. And even cosmetic surgeries are not excluded in this. And definitely, whenever you are having a notice, immediately notify the insurer in writing, and also get a receipt, because many times insurer will deny that you have informed them, and they'll say ki we deny to provide the claim because we were not informed, and renew before 1 month of expiry. And you can make the insurer a party in court and inform if you have any changes in your original proposal form. You inform them. Definitely, how do you do it? You contact your society. Maharashtra Ophthalmic Society has their own insurances. Ophthalmic Society of West Bengal has their own discounted premiums for their members. We at EOC are trying to talk with people to have discounted prices for our members also, and fill proposal from yourselves. And our take home points are: get medical insurance today if you do not have now. Do not allow policy to lapse. Contact insurer immediately on writing and get an acknowledgement. And keep in touch with colleagues who have interest in medical legal issues. Thank you. We thank you from our local court team. Thank you.
Thank you, Kaushik sir. It was really enlightening talk for everyone. Now I would like to invite Dr. Aarti Heda ma'am. She will speak upon telemedicine and its medical legal aspects. Over to you, ma'am.
So, good afternoon, everyone. I hope everyone is still awake. So, I would like to thank YOSI and legal core team. We have come quite far when it comes to medical legal aspects in ophthalmology. So, why am I showing you this picture? If you see this image, you will realize the importance of telemedicine. So, what happened in Ramayana when Hanumana was sent to get Sanjeevani booty? He did not know which is the one, and since there was no telemedicine, Hanumana had to lift the whole mountain to save Lakshman. But that's not possible in today's era. So telemedicine has been in fashion since the year 2000, when the smartphones started making their presence in the market. Then came the messaging app like WhatsApp and Telegram to popularize it. I'm sure each one of us would have treated medical patients, relatives, friends over phone. And yes, this is what is telemedicine. However, the telemedicine practice was banned by few state medical council. For example, Karnataka State Medical Council had reportedly warned doctors in the state of Karnataka against offering the online consultations. And they actually threatened the doctors by saying that their medical practicing license will be cancelled if they continue the practice. In spite of all these things, telemedicine still flourished. So let's get into the history of telemedicine a bit. There was a case in 2005 where a patient died of acute pancreatitis that was being managed by junior doctor as per the advice of the senior doctor over phone. And the court awarded compensation of 10 lakhs on the ground that patient was given medication without proper physical examination. There was another psychiatric patient who was prescribed injection Serenase over phone and he died of cardiac arrest. And the compensation awarded in this case was also very huge. So there was another case from Maharashtra that was observed, was of a young couple who were treating a pregnant lady over phone. The case went to High Court and then to the Supreme Court, where the court stated that treating the patient over phone without physical examination amounts to gross negligence. So there are too many concerns when it comes to telemedicine. Who should be doing telemedicine and for whom can it be done? What medicines can be prescribed and how to generate a prescription? What about the consent, how to maintain the records? What if there are any complications? What is the liability of the doctor? And most important, how can an emergency situation be handled? So we all know COVID has set few things wrong, but yes, few things were set in the right direction. Board of Governors on 25th of March 2020 superseded what was given in Professional Conduct, Etiquettes and Ethics Regulation 2002 and showed a different way to telemedicine, enabling registered medical practitioner to provide healthcare using telemedicine. So they categorized the drugs into various categories. So this is the most important part of the presentation. So even if you are talking, just concentrate for next 1 or 2 minutes. It's important for us to have clarification on these categories of drugs. So first is category O. Paracetamol, ORS, multivitamins come in this category. Also medicine in case of any emergency, Government of India says everyone should take, for example, anti-malarials falls in this category. Then there is list A medicine. So for these medicines to be prescribed in first consult on telemedicine, you need to have a video consultation. It's important for us to know that ophthalmology eye drops such as ciprofloxacin, falls in this category. So for us to prescribe these medications, we need to have a video consultation when you are prescribing for the first time. This category also includes the refill medicines, like the patient is already on any antihypertensive and antidiabetics. Then there is list B medicine, which are add-on medicines. Say a patient is already on antidiabetics and you want to add another medicine to that, then this falls in category B. So be very, very clear when it comes to these lists, list O, A and B. For us, important is list A. The prescription that has to be generated has to be exactly in this format, and it is clearly mentioned on this that this prescription is generated on teleconsult. So this format has been given by the Board of Governors, who gave us the guideline how to practice the telemedicine. So next question is, who can do telemedicine? So according to the notification, anybody who is enrolled with the State Medical Council under the IMC Act 1956 can practice telemedicine. It was also specified that there will be an online course which one has to take, and that course will teach us about the details of telemedicine. The course is expected to be available in 2023, and we are keeping an eye, will inform each one of you when it comes. So what are the fora that can be used for telemedicine? One can use video, audio, text, etc., whatever is available for telemedicine. For us, what is important to remember again is ophthalmology drugs falls in category A, so for which we have to have the first video consultation. So what cannot be done on telemedicine? First one, you cannot start a video and tell someone how to do a phacosurgery. You cannot tell a junior that, okay, fine, now you can go ahead and do the phacosurgery, I'll guide you over phone. No, that's not allowed. So if you cannot provide consultation outside the jurisdiction of India, say supposingly you have a patient who is now in Malaysia and he needs a consultation. He calls you up and tells that, I want a teleconsultation. You cannot provide him a teleconsultation. You have to ask the patient to go and see a local doctor there. There are 4 types of telemedicine practices that can happen: patient to RMP, caregiver to RMP, RMP to RMP, and health worker to RMP. So all these formats will be described under telemedicine. The guidelines to practice telemedicine are very well described in the manual which was generated by Board of Governors in 2020 March, and they specified 7 elements to be considered before any telemedicine consultation. You can go and read about them in details. Yes, identity of the patient is very important in telemedicine. RMP should know the patient and the patient should know the RMP. If the patient is a minor, teleconsultation is allowed only if the minor is consulting along with an adult whose identity needs to be ascertained. What about the consent? Consent, we have heard so much about consent since the session has started. If the patient initiates the teleconsultation, then the consent is just implied. But explicit consent is needed if a healthcare worker initiates a teleconsultation. Consent can be in the form of video or email, or you can just send a consent form to the patient for signature and the patient sends you back. All the consent forms are to be attached to the patient record. And yes, these records are to be kept as per the MMC guideline for at least 3 years. Yes, as usual, it is on us when it comes to legal liability. So be very, very careful while you do the teleconsultation. What is the definition of misconduct in telemedicine? It's important for us to know this. RMP is insisting on telemedicine when the patient is willing to travel to a facility and or he requests in-person consultation. Misusing the patient images and data, prescribing medicines from the specific restricted list, and the penalties for misconduct are same as per the IMC Act. All the records of telemedicines are to be kept for 3 years, and all the other rules and regulations of physical consult are applicable to telemedicine as well. Fees can be charged as you charge for your physical consultation, or whatever you feel is appropriate. You can generate receipt or invoice for the same. So to summarize, doctors can choose the medium of teleconsultation. Doctors has to maintain the same standard of care during teleconsultation as during the in-person consultation. Patient is responsible for the accuracy of the information. Caregiver is deemed to be authorized on behalf of minor or incapacitated patient. Doctors should maintain patient records of teleconsultation. Patient's personal data should not be disclosed or transferred without written consent of the patient, and doctors should not deny emergency consultation but limit it to immediate assistant or first aid and refer the patient. So thank you.
Thanks, Dr. Arti. I'll invite Dr. Dipanshu for his talk on important landmark judgments by Honorable Court.
So we have been highlighting all the points like why do we need consent, why there has to be proper documentation, why the medical records have to be kept properly, why we should have professional indemnity insurance. So I would like to highlight few of the cases which have the claim has been there has been cases against the doctors on which compensation has been awarded from thousands to crores. So I'll just brief you guys with some few of the cases. So why are we burdened basically? So it is basically because of the high cost of technology that we are using currently in ophthalmology, increasingly competitive environment and social demand, pressure to progressively lower the cost to consumer, and to keep costs down there is tendency to do as many surgeries as possible. So now I have summarized these cases speciality wise so you guys can have a look at it. So first case is from cataract specialty. This was in Madurai 2018. 66 cataract eye surgeries were done and 61 eyes lost vision. The compensation awarded by lower session court for all the patients who had lost vision was a total of 92 million. And then further they approached Madras High Court, and that compensation was reduced to 22.5 million rupees for the victims of the negligence in medical camps. The basic points that were highlighted by the court were that there was no approval to run the hospital, consent to operate was not taken from the State Pollution Board, no proper design and maintenance of the operating room, no anesthetist, no pharmacist was available, no facility to do pre-operative laboratory tests, then no formalin which was intended despite it being out of stock. So these were the points against which court had given the compensation for the medical negligence to the patients. Next case was way back in 1989 in UP. The 88 eyes were operated from doctors from Rajasthan. They had come for a medical camp. It was a free of surgery camp, then free of cost cataract camp. All eyes developed endophthalmitis. So they had awarded compensation initially when the case was reported. Actually there were no guidelines before this mishap had happened. So during this, state government had provided compensation for to the medical negligent victims, and initially they had asked them to pay 5,000 and with additional amount of 12,500 to the victims. The remarks given by the court was they had laid down guidelines after this for organizing camps, that there should be qualified experienced ophthalmic surgeon who should be registered with State Medical Council or Medical Council of India. The camp should not be used as a training ground for postgraduate students, and operative work should not be entrusted to postgraduate students. Also, there should be a pathologist to examine urine, blood, sugar. All the pre-operative work should be done by pathologist, and all medicines to be used should be of standard quality, and the doctor should verify them in such high volume setups themselves. Next is the cornea. The cornea and the cataract services are the subspecialties which receive maximum number of cases or claims. So this was in Delhi in 1993. It was a post-surgery, post-surgery for pterygium patient was advised mitomycin C. It was in diluted form and topical mitomycin C was advised. The guilty was the patient kept using that. The doctor in the prescription did not mention that for how many days the patient has to use it. And patient did not come for regular follow-up, and he kept using that. The justification given by the doctor was that he had only made the patient available only single vial, but the patient somehow got multiple vials on the follow-up, and he did not come to the doctor on the follow-up. So it was basically mixed kind of negligence on both the parties. So 50,000 compensation was awarded to the patient. Next case was retina. Retina is definitely rising, especially in the field of ROP when it comes to medical legal cases. It was in Chennai 2015. First, the pediatrician, it was against the government hospital pediatrician
where there was failure to inform parents about ROP screening. That is a very common mistake pediatricians sometimes do. They do not inform the parents regarding the ROP screening, and ROP being a very progressive, fastly progressive disease. These children, this child developed stage 5 ROP, and it was detected during the fourth month visit of vaccination. A huge amount of 1.8 crores. Initially, they had gone to Supreme Court, National Consumer Forum, where it was 5 lakhs. Then they had again filed the case in Supreme Court of India, and the compensation of 1.8 crores was awarded. The remarks given by the court was the compensation is against past medical expenses, future medical expenses, compensation for mental agony and lifelong dependence and care, and also annual interest of 6% from the day the disease was diagnosed till the time payment has been done. So it was a huge amount. Next, again, in Hyderabad in 2015, a patient reportedly lost vision post-intravitreal bevacizumab. High quantities of pseudomonas and Klebsiella were found in the drug. It being a off-label drug, the doctor had mentioned it, but it is not illegal. They said that it is not illegal to use off-label drugs, but the patient has to be informed about the pros and cons. They said that single vial has to be used for every patient. You can't do aliquoting or use it for multiple patients from single vial, and that's why 5 lakh of compensation was given to the patient. Coming to pediatric ophthalmology, in Ernakulam 2016, 9-year-old child underwent squint surgery. It was obviously under general anesthesia, but during the surgery suffered a cardiac asystole, and a successful resuscitation was done, but subsequently the child expired in ICU. I could not get the amount for which the compensation was done, but the remarks given by the court was routine consent was only taken for surgery, not really an informed consent. Retrobulbar, according to the doctors, retrobulbar block was given, but anesthetic notes, anesthesiology notes or physician progress did not have any mention of that, and they had used abbreviations like glyco instead of glycopyrrolate for the drugs. So they said that confusing abbreviations is considered deficiency in service. Coming to neuro-ophthalmology, it was a case of Panipat where following dengue, a patient had developed intraocular hemorrhage. A patient was immediately referred to Delhi, where the patient was admitted in a hospital in ICU. In the evening time, patient told the nursing staff that he is not able to see, but that was ignored. The senior doctor was not informed. Senior doctor only came next day morning, like almost 12-13 hours later. And the patient had probably, the MRI was advised then, patient had probably developed optic neuritis bilateral, and there were vitreous hemorrhage as per the reports. And also in this case, Delhi Medical Council, medical board formed by Maulana Azad Medical Council had ruled it in favor of the doctor that it is not the it is not doctor's fault, but court did not follow that follow that report, and they still charged the doctor for compensation of 35 lakhs because there was a significant delay of 12 hours. They should have intervened. The doctor should have been informed prior to that. Coming to refractive surgeries, luckily this was in favor of doctors actually. It was in Delhi 2018, a patient following LASIK surgery for high myopia underwent toric implantable colamal lens. Later on, patient had filed a court like after many years saying that a compensation of I think 1 crore was 60 million was asked, and the patient the court said actually the hospital had hired investigators. That's what was written in the PDF, that they had hired investigators for this. The patient who had underwent refractive surgery has completed his education. He has started his practice, like he's working now in an IT company. His social media page did not show any signs of difficulty in carrying out his day-to-day life. So thankfully in this court, due to its exorbitant claim, the court had not awarded any compensation to and dismissed the case. Now these were the subspecialty wise like mistakes while during the surgery. Now if we look at the medical records, it was in Mumbai 2018. Cataract surgery was done. Patient later on follow-up developed some corneal trauma. Following that, there was end-off. So patient had filed case against the doctor saying that there is endophthalmitis due to cataract surgery. So records were reviewed, but there was no fault of the doctor in this. But during the review of records, they noticed that consent was not properly taken and preoperative examination was not done. Like routine preoperative systemic evaluation was not done. So that's when court ordered only 25,000, but it is a significant amount. Back in 2016 in New Delhi, again a case of negligent case of premature casual ROP, developed stage 5 ROP. Earlier, National Commission had ordered 64 lakhs of compensation, and further Supreme Court of India ordered 12 lakhs of compensation. I would like to finish by this case. Post-op, this was in Kurnool in 2015, where post-cataract surgery patient who was a coolie was not given post-operative instructions. Like he has to probably take rest for a week before going on to the field. He developed corneal injury and subsequently he had reduced vision or loss of vision. He was given a compensation in view that post-operative instruction should be written and very diligently told to the patient. So basically, Consumer Protection Act had in 1986 excluded free services from purview of Consumer Protection Act. Honorable Supreme Court has decided that doctors providing fee service also would be covered within purview of Consumer Protection Act. And after that decision has not been reviewed later. In India, we operate high volume surgeries, but recently there is an increase in the number of cases where exorbitant penalty has been imposed by the courts, and time has now come to introspect to factor cost of litigation and compensation into cost of surgeries, so that we not only benefit patient but also safeguard ophthalmologists. Thank you.
Thanks, Dr. Dipanshu. We are already out of time. I'll ask Dr. Deep his take on medical legal issues and.
It was a very enlightening discussion. Not discussion, as in the talks were very enlightening. We have to be very careful because in the recent past, the number of cases, medical legal cases has increased. Patients are quite educated these days. They are not, and they are also quite intrigued in the number of symptoms which they are having. For example, even after surgery, a patient came for dimness of vision, but then again developed irritation, even for the irritation, or even for myelomatosis, which can be seen in cases of cataract surgeries. They are actually looking for putting up a case against the doctor. So it's up to us to actually take time out and counsel them properly, thoroughly.
Dr. Anujit, your comments?
Just to reiterate what the first speaker said, that everything starts with consent, and taking good consent and having a proper discussion with your patient, being very kind to the patient, using sentences like, may I have your consent, may I do this, these are the risks, informing the patient, separating black and white and keeping the gray parts aside help a lot. And one small point I'd like to add is that even for daily OPD procedures like capsulotomies or diode lasers, we often rush through the consent, especially me in my residency days. I have done that myself. And sometimes we as doctors don't read the consent forms even once before making the patient read it. Reading the consent forms ourselves help us answer the questions that the patient has. We can redirect the patient to the consent form and saying that you're signing this off. You don't need to ask me about it. It's in the consent form, but I'll be happy to explain it nevertheless. So everything starts and ends with consent. Taking good consent from the patient goes a long way.
Thanks, Dr. Anujit. I'll now request Santosh Honavar sir, please to kindly come on stage and please from our speakers. Dr. Shahid. Dr. Anujit. I'll invite Dr. Lalit sir to please come on stage and facilitate our speakers. Dr. Prakriti. Lalit sir, please come on stage. Dr. Dr. Arti. Dr. Dipanshu. Thank you, sir. We conclude our session on medical legal issues. I'll hand over the mic to Dr. Nilesh.
So, thank you, medical legal team, for conducting a wonderful session. And we have the AIOS dignitaries among us now. So, we will be proceeding with the inauguration ceremony. Just we will request 5 minutes patience till the stage is set up.
It is indeed a privilege, and with the support of AIOS and blessings of our seniors, we've been able to conduct the 5th edition of the AIOS YOSI Forum. We've had a long journey, a lot of planning sessions. We've had a big team for this. So big thanks to all the team members who've participated in making this program what it is. So I would start by welcoming the Honorable President of AIOS, Dr. Lalit Verma, onto the stage, onto the dais, please, sir. President-elect of AIOS, Dr. Harbans Lal. Honorary Secretary of AIOS, Dr. Namrata Sharma. Honorary Treasurer of AIOS, Dr. Rajesh Sinha. And Editor IJO, Dr. Santosh Honawar.
And to the wonderful governing council of YOSI, I would like to call our immediate past president, Dr. Digvej Singh, sir, to the stage. Our vice president and acting president for today, Dr. Divakant Mishra, sir, on the stage. Our secretary, Dr. Karan Bhatia, to the dais. And our treasurer, Dr. Avanish Upadhyay, to the dais. So any inauguration or any auspicious occasion in our country starts with lighting the lamp. So I request all the dignitaries on the dais to please light the lamp and start the session.
Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada.
Without the guidance of AIOS and the governing council of AIOS, who have been blessing us for last multiple years since the inception of YOSI, it would not have been possible to have this forum. So as a token of gratitude, I would like to request our immediate past president, Dr. Digvijay Singh, to honor the president of AIOS, Dr. Lalit Verma, sir. I would request Dr. Devakant sir to honor Dr. Harbans sir, our president-elect AIOS. I'd request Dr. Karan Bhatia sir to honor Namrata Sharma ma'am, Professor Dr. Namrata Sharma ma'am, Secretary AIOS. I'd request our Treasurer, Dr. Avnish Upadhyay, to honor Honorary Treasurer, Dr. Rajesh Sinha, sir.
I request our Joint Secretary, Dr. Nilesh, to honor Dr. Santosh Honavar, sir, at IGO.
So our president, Dr. Sonal, is unwell and couldn't make it to the meeting. She has recorded a video for all of us. Can we have the video, please?
Greetings from Jaipur to this August gathering at the 5th AIOS YOSI Forum 2023. My heart is filled with joy and pride at the prospect of this milestone event for the young ophthalmologists of India. Since this is a video recorded due to health reasons, I kept wondering how to begin the presidential address. After all, the term presidential itself sounds so daunting, but AIOS really simplified my task. All my racing thoughts began with and ended with nothing but sheer gratitude for All India Ophthalmological Society, without whose unflinching support this wonderful program wouldn't have happened. For those who are new, let me share the story of YOSI briefly, and those who are there from its inception will surely enjoy the walk down memory lane. One small step in the right direction started bringing like-minded people together on New Year's Eve in 2014. Dr. Tarun Arora, who is now in Bahamas, started YOSI and YO Times when he was a senior resident at RP Center in AIIMS, New Delhi. Via YOSI and the Young Ophthalmologist Times, I got connected to this stupendously successful young ophthalmologist, and the movement gained traction. Despite the length and breadth of this vast country, social media helped us come together as one when we discussed about our common issues like exams, thesis, fellowship, diagnostic dilemmas. With growing demand, Rajesh Sinha sir guided Tarun Arora and the team to have the first ever standalone meet for young ophthalmologists of India, the YES Meet in 2015 in New Delhi. The Delhi Ophthalmological Society had the first state society session for YOSI, but it was Pink City, Jaipur, which was the first place where YOSI started to take steps outside the NCR. With some trepidation but great hopes, like the Three Musketeers, Dr. Vijay, Dr. Tarun, and myself organized the YOSI session in 2016 at Jaipur. We got immense support from Rajesh Sinha sir, Harshul sir, Basavara sir, and Arup sir for that particular session. Natarajan sir encouraged us to start a new venture to inspire young ophthalmologists to think and express themselves freely. The writing competition that began that year in 2017 has been a regular feature. The first session itself brought winners like Divakant Mishra, Apurva Ayachit, Kirandeep to work harder for the cause of young ophthalmologists. YOSI began to spread its wings internationally as well. Dr. Divakant should be applauded as he has been instrumental in the fruitful collaboration with numerous young ophthalmologist organizations worldwide. Team YOSI was growing by leaps and bounds. Its needs were growing, and so was its impact in Indian ophthalmology. A slow and steady rise. I feel lucky to have been a part of this new team that came into force in 2018 and ushered in a marathon of activities for the betterment of young ophthalmologists of India. This was a landmark event, the first AIOS YOSI Forum in 2018, as it brought international young ophthalmologists a live webcast and an exciting program for and by the young ophthalmologists only. This couldn't have been possible without the support of AIOS, especially Professor Namrata Sharma ma'am and the immense hard work put in by Divakant Mishra that year. 2019 was an even grander 1.5-day event at Delhi for the AIOS YOSI Forum, and we are grateful to that team for the opportunity to bring the best values of India to a common platform. After COVID-19, YOSI members collectively engaged in an array of online activities, culminating in an online format for the AIOS YOSI Forum in 2021. And a similar online session for the AIOS YOSI Forum happened in 2022 as well. The All India Ophthalmological Society office bearers and the local organizing committee have been kind enough to grant us time and space to create a cocoon for young ophthalmologist activities in the form of Vayo Pavilion year after year. Last year was no exception, as we had an excellent time nurturing minds full of ideas and thanking our mentors during the All India Ophthalmic Society conference at Mumbai, the DreamCon. For me, the personal turning point was taking over as President by USI during the AIOC 2022. We had our YOSI GBM there. Dr. Vijay sir, our phenomenal leader, the first president of YOSI, was succeeded by Dr. Digvijay Singh. And that year he could not join us due to COVID, but Dr. Saurabh Patwardhan sir came to help us in the proceedings. Dr. Digvijay Singh is an epitome of virtues, and he has been capable of handling even complex things expertly. His guidance has brought YOSI to its present shape, and he continues to be an inspiration for me, this team of YOSI office bearers, as you can see here, and all of YOSI. After continuous Zoom meets, day after day, calls with the entire governing council, especially Karan, my husband asked me if I'm sad because I'm not able to attend the conference in person. And perhaps the team must be feeling a bit let down as well, isn't it? To which I replied that teamwork has immense strength. You see, the impeccably smart duo of Karan and Nilesh, the governing council of YOSI, along with the excellent team of the YOSI executives, make me proud every moment. They will surely put in their best efforts, and I am now going to support them till their last minute from afar as much as I can. Myself and Karan decided to make presidential working groups for expanding YOSI activities last year. Some of the teams formed last year, like the YOSI website team, the YOSI Journal Club, Medical Legal, Socio-Cultural, have worked industriously, and other teams are also bringing in new ideas and results this year. It also gives me great pleasure to share that in June we had the Vayo Pavilion at AIOC, and thereafter a physical event of YOSI at multiple conferences has happened almost each month till now. Hubli, Patna, Pune, Kota, to name a few. Dr. Karan Bhatia will be sharing the details of online and offline activities, but I must congratulate the teams whose activities have made YOSI a hub for regular young ophthalmologist activities in the Indian scenario. This galaxy of ophthalmic stars present here have made it possible for us to say welcome to the AIOS YOSI Forum 2023. Each of these luminaries in these photographs and on the dais is not only an office bearer of the governing council of the All India Ophthalmic Society, but they are an ophthalmic institution in themselves. YOSI members are truly standing on the shoulders of giants, and we feel blessed to have these opportunities today at New Delhi with us. With pillars of Indian ophthalmology by our side, young ophthalmologists can definitely feel secure that their future will have umpteen opportunities and they will keep growing. Thank you to all YOS, the YOSI members, the AIOS dignitaries, and all of those who have supported this venture. Thank you so much.
PPT. Yeah. So, I'm Dr. Karan Bhatia. I'm the General Secretary of Young Ophthalmologist Society of India. After Sonal's inspiring words, I'll take you through the activities that we've been doing in the past year. So, YOSI is a registered society with the AIOS and the ICO, and we cater exclusively to the needs of young ophthalmologists in training or under the age of 40. And we want to act as a bridge between senior leaders and young ophthalmologists and positively impact the lives of young ophthalmologists. So we are a democratic society. We have elections which are conducted every 2 years. The last election took place in April 22, which was an online election, and it was presided by the then President Dr. Digvijay Singh, the past President Dr. Vijay Sharma, and the OC election observer was Dr. Saurabh Patwardhan. And just to say that any governing council, that is the office bearer, cannot repeat their post. The YOSI Governing Council consists of Dr. Sonal Kalia as the President, Dr. Digvijay Singh as the immediate past President, Dr. Devakant Mishra as the Vice President, I myself, Dr. Karan Bhatia, am the General Secretary, Dr. Avanish Upadhyay as the Treasurer, and Dr. Nilesh Kumar as the Joint Secretary. We have 20 executive members who are very active and helping out in all of our activities. The various presidential groups that we have are the YOSI Membership Drive, the YOSI website, the YOSI state chapters, the YOSI legal cell, the Bio Times, which is the official publication of YOSI, the YOSI slides, the YOSI fellowship help desk, journal club, programs such as monthly programs like the Surfing the Anti-Rest segment, where the Late Right Retina, a job portal. We are working on support for travels and conferences. We have a social media group. We have a residence network. We have flash notes. We have our own YouTube channel, record keeping, as well as a socio-cultural group. So our membership is expanding, and that's a very good sign for us and for the young ophthalmologists. So we recently launched the new website, which we will be showing after this presentation. A big thanks to Prasanna, our executive member, who has really worked hard for it. At Yo Pavilion, we had, with the blessings and support of the AIOS, it was possible for us to conduct a wonderful young ophthalmologist pavilion where we had 118 YO faculty, which consists of residents, fellows, and consultants. There were keynote talks by Dr. Suvin Bhattacharya ji on patency. Dr. Sabyasachi Sengupta spoke upon the research-based, and King's Crux was spoken by Pranesh Balasubramanian. We had the surgical anterior video segment competition as well. We had training sessions from residency to fellowship, what to do after that, short-term trainings, everything was discussed over here. We had sessions on finance and practice management. We also have a unique program, which is called Meet the Mentors, which we've been doing for a couple of years, where young ophthalmologists interact with seniors and educational heads of various top institutes of the country, and they are on the hot seat, and we are the ones asking the questions, and it also bridges the gap, and what to write in a CV. Simple questions are answered, and it's a big benefit for the young ophthalmologists. This was this year's AIOS YOSI writing competition, and Team YOSI is grateful to the esteemed panel of judges, Dr. Harbans Lal, Dr. Chaitra Jaydev, Dr. Vishali, and Viraj Vasavada for it. Our winners were Dr. Sahiban Sethi, Dr. Saiz Dhira, Shweta Suryakant. Consolation prizes were given to Dr. Aswini, Vikas Veerawal, Ujjwali Pandey, and Mausami Banerjee. Such a good feedback was received from various YOSI members. A couple of them I have put over here. These are WhatsApp messages to me and on the groups, and it was very well appreciated, and it was all big thanks to them. AIOS has been very kind to us and very helpful to us, and this was another session that we had this time at AIOC 2022 as a part of the main conference. In SFO, the team was invited, the YOSI team, for the presentation there, and our team won the Science and Fun session and came second in the science session. We had a surgical video anti-rest segment competition in June 2022, followed by a session in July by the Telangana Ophthalmological Society, a session there. In Iskaris, August 2022. The I Milan in Noida Ophthalmological Society in August 2022. In Vision 2020 conference in Siliguri, we participated and designed our own session in September. We also had the privilege of organizing a session in the World Ophthalmology Congress by the ICO, and we got involved with the various yo leaders, and a wonderful session was laid out. Dr. Digvijay was also invited to review the abstracts for the conference. In October, we had a session by the Rajasthan Ophthalmological in the Rajasthan Ophthalmological Society, followed by in DOS. Then on World Sight Day, the YOSI socio-cultural team celebrated it wonderfully on Zoom with Dr. Namrata Sharma as our chief guest on it. They are doing a wonderful job. In Odisha also in November, we had a session. Asmini Behra had taken the lead over there. In South Asian Academy of Ophthalmology, we had a session in November. In COSCON in December. Then in UP State Conference in December again. Then the AIOS midterm conference where Nilesh, our joint secretary, had taken a lead. We had a wonderful session which was attended by a lot of young ophthalmologists, and a U pavilion as there as well. We were also involved in January 23 in Winter IRSI. The MOS YOSI hackathon took place in February, which was led by Rohit and Zain, Ashish, and it was a wonderful initiative where doctors and engineers got together and came up with innovative ideas to help ophthalmology as a whole. These are some of the pictures of it. We have a couple of collaborations with MOS, and this was a session that we had on practice management in February. We were also invited in iFocus, and I got to speak on what does YOSI do for young ophthalmologists. The Karthikeyan had taken a lead over here along with Niranjan and Prasanna and Pranesh, where the first ever Tamil Nadu YOSI online case presentation competition known as No in ID took place. In IRSI YOSI session, we also had a session there where it was a session of when the going gets tough and the tough gets going. The second session of the MOS YOSI session was in March, which was on financial planning in practice management. YOSI is also expanding internationally. Devakant has represented us in AAO. I have spoken to people in AAO, and Devakant also represented in the Singapore and then in the APO conference that took place in Malaysia recently. Dr. Aditya Sethi was sent by YOSI to Turkish Ophthalmological Society, where we were invited for talks. We have also had the privilege of a couple of international interviews as well. So we are networking with a lot of international young ophthalmologists, and we are helping or partnering with other YO societies as well. As of 2020 June, we also became a member of ICO. This is what our Facebook page looks like. We have an Instagram page as well. This is our publication, that is the YO Times. The 15th issue was particularly special, where more than 2,000 downloads, more than 80 articles on specifically focused on vitreoretinal training was there. This is our YouTube channel. I am the editor-in-chief. Devakant is the joint editor, the assistant editors. Zain takes basically most of the work nowadays, and Nikunj and Pranav. This is the last year's data. We have got about more than 5,000 subscribers, a lot of playlists for all types of collections, and then this is the playlist of all the different webinars that we do. These are our most popular videos. This one video has got more than 53,000 views, and it is just on the basics of SICS. This is just everything that we do online is on our YouTube channel, so it's free for everybody to access it. The YOSI Flash Notes, Avanish started it, and we have around 73 YOSI Flash Notes and one YOSI Flash video up to date. And you can just correct everything about the disease in that point. This is their Facebook page and their Instagram page as well. Late Night Retina was again started by Avanish, and there have happened about 25 episodes in 2 years, where young retina surgeons come and discuss some interesting cases, some complex things, and come up with solutions together. Aarti Heda takes the lead in surfing the anterior segment, where we discuss from simple to complex anterior segment cases. The YOSI Legal Cell was also recently started. The team leads are Kaushik and Aarti, Dipanshu, and basically what they're doing is the talks such as consent taking, Consumer Protection Act, record keeping, indemnity insurance, how to react to a legal notice, tips to avoid medical legal cases, and important landmark judgments have taken place, and these are available on our YouTube channel again. The Yo Slides initiative. Now, these are basically curated content slides which are verified as well, and you get ready-made presentations, verified presentations of any topic that you want. This is the team led by Ankita Ashwarya. She couldn't make it because of an accident which she had yesterday. We have 40 Yo slides till now, and 12 patient awareness Yo slides. The OC Journal Club also we started recently, and we have had 13 online sessions. We have a presenter, a monthly mentor, a moderator, research expert, panelists, and Nupur and her team do an excellent job in it as well. So USC Socio-Cultural has been very active as well. They keep on doing a lot of programs, from dances to this and that, and World Sight Day, as I said, Namrata ma'am was the chief guest for it. We have a UC fellowship help desk, so whenever you have any queries, you send it to our email address, that is secretariat@uc.in, and the second one is secretariat@ucedu.in, and we help you whatever queries that you have, or we help you connect with senior or young ophthalmologists for you, which are better for your career. We have a job portal as well. We have a residence network. You don't have to be a member to be part of the residence network, but we help you connect still, and it really helps. So what is the process of involvement or inclusion in UC activities? As in this forum, we circulate a form to all the members, and everybody fills out the form, their topics of interest, what they want to present. Then the team sits, and then we gather all this, and we try to have maximum participation, because that is the aim, to give opportunities to young ophthalmologists to showcase their talent. So why UC? Become a part of one of the largest UO groups of the world, get access to various UC publications, and participate in webinars, programs at national, international level. You have a lot of access to the various material that UC has, and you become eligible to various awards of UC as well. There's a writing competition, fellowship held desk, and basically we want to act as a bridge between senior leaders and young ophthalmologists, and there is much, much more. So we basically give you opportunities, we give you chances to connect, and even we give you guidance. So I would invite you to the second Young Ophthalmologist Global Summit that is taking place in January 2024 in Singapore. UC has a session, and we would be grateful, if you all come to that session to be a part of it. We are also very grateful to AIS for having our support in the UO Pavilion as well, and we are extremely looking forward to the conference in Kochi for it. So come and become a part of UC. A big thanks goes to the entire AIOS body for all its support, because without them we wouldn't be where we are today. Thank you so much. Now I would invite our president from AIOS, Dr. Lalit Verma, to come and say a few words and inspire young ophthalmologists. Mic can be given there only, sir.
I was telling Karan, I am not so old that can't get up, and I am not UC. UC is young. You see, it's always a privilege to be amongst the youth, because youth, I think youth is freshness. Youth gives a lot of motivation and is full of ideas, and youth is energetic, and youth is future. Basically, youth is future, because there's a lot of hope from this young generation that they will take ophthalmology in India or AIOS to the next level. Whatever little we have done may be nascent, but I am pretty sure that once UC enters, all of you will cross 40, and I am 100% sure that the kind of activities which Karan has enumerated are so extensive, and UC is doing fantastically well. Even AIOS, sometimes we feel we should have part of some groups like this, which we don't have. And you see, more than 18 presidential committees or working groups is a very nice job being done, and very thoughtful process by the leadership. So Dr. Sonal, Dr. Digvijay, Karan, Nilesh, Avnish, Devakant, I'm very happy to be here at this fifth UC forum, and you people should have big ambitions. Big ambitions. Think for the best possible thing on the earth. But believe me, with ambitions comes responsibilities also. It's not that you keep looking up, but you have big responsibilities. And sometimes you may require some guidance or direction, for which all of us are here, and we do not hesitate. And Namrata has led from the front in initiating a lot of UC events. And I feel all of you have good potential. The reason we love young people around is because you see they give a lot of ideas, and based on that sometimes I will formulate some research projects and carry on. The difference between RP Center and the Center for Sight is YOSI. YOSI means, you see, always feel that I do not have residents around so that ideas don't percolate. Only thing what we do now is, do indirect and do service component only. So that is what I miss at Center for Sight. Although we have started fellowship programs and, they are running pretty well. All of you, are bubbling with knowledge. Sometimes we tend to forget, but these fellows around, they will, tell a lot of ideas. Some of you may have very clear thoughts about what you want to pursue, about your goals, about what you want to do in your life, and what do you want to pursue, whether, go join government job or join practice, which could be solo or corporate or group. And some of them may not be very clear. Like I'm telling you, when I was your age, I was not clear in my mind what I have to do. So this generation gap is already there. And people who do not have much clarity in their mind that what to do between various job options, what I normally tell them is study your successful people, study your mentors, whomsoever you think is doing well. Spend time with them, go to them for a couple of days, weeks. But at the back end, you should always, have a passion. Pursue whatever you love. If you love retina, pursue retina. If you love cataract, refractive, do that. Because passion, believe me, has to be there. Because passion is a incredible motivator, and it fuels your thought process. It fuels your focusing. And other thing is, whatever you want to achieve, you should ritualize that practice intensely. But also, what you're already doing, take regular breaks. You already have a lot of opportunities, and always don't hesitate to have expert feedback also. But always be optimistic that if he can do it, so can I. That gives good results. And learn to take challenges. Believe me, if you are in retina, then learn whatever nobody is doing, you should try to do that. Learn to take challenges and learn to convert all your problems into challenges, and hence find solutions. Learn to see possible in impossible. It's very important, you see, at this age only, learn to do difficult surgeries. Believe me, as you grow, you tend to do simpler surgeries, but in this age group you do toughest possible surgeries. That's what I would like to say. Do not quit, keep working very hard. Believe me, life is a constant lifelong learning. You learn every day, you can't quit. But at the back end, you should have empathy towards your patient. Very important, because all of us are here primarily because of our patients only. The other thing, a couple of suggestions I had was that aim should be to develop skill sets. Skill sets is very important, because if you have a skill in one particular field, believe me, world is at your feet, because you should be master in that field. And aim should be to develop excellence in that particular field, that there should be no other person who can do better than you. That should be your aim. Believe me, achieving excellence is not a inherited trait. It has to be achieved by a deliberate practice, and keep practicing day in and day out. There's no shortcut to this, and there has to be a repeated hard work, repeated practicing that kind of surgery. And everybody I believe can become excellent. And believe me, there are no silver bullets that uska to ho gaya, mera nahi hua, but everybody can become excellent. And second is, I was motivated by Divakant and what Karan also presented. UC should increase opportunities for UC members to go international. I see few people do go international, but UC can consider starting some kind of fellowship program, or because everybody may not be able to travel. So one is develop skill sets. Second is try to project yourself internationally. And third, which is always, I always conclude by saying, be apolitical. Do not at this young age try to, associate just because of politics that you want to, enter into AIOS or do want to this. At this age, do not get aligned with any particular group, because aim should be at this age to learn, keep your best, develop excellence, and develop all the practical skill sets, and travel, develop international relations. That should be the aim, rather than becoming a political. So wish you all the very best. Wish each one of you all the successes in life, and I wish all of you become great clinicians with the tremendous skill sets, and wish all of you also become great human beings also, and have empathy in your heart. Thank you very much, and it was lovely lovely coming here and spending time with all of you. And I also echo what Sonal said in her last slide, that best for UC is still yet to come. Thank you very much.
Thank you so much, sir, for your kind words. And sir, I'll just also like to request you to bless us and inaugurate our new website, sir. You can just, the video has to be played, sir. You can just give the order.
So I'm very happy to be part of this small function of inaugurating your website. Congratulations on this fantastic website. You see, phenomenally, a lot of useful information is there. You see, Yoshi should owe their existence primarily to one person, that is Rajesh Sinha, because he was the person who told me about youth. And I remember that day in 2014 in Ashoka Hotel, Tarun was standing and this fellow Rajesh was there, and he said, "Sir, inke liye kuch karna hai." And then immediately we coined that term Yosi and requested Tarun bhai kuch karo aap log. Digvijay also, I think, and Colonel, what's his name? Colonel Vijay, he was also there, and this trio, they came into action immediately, and thus UC was born. In fact, a lot of hard work was done by Tarun at that time. Believe me, it is difficult to initiate anything, but for propagation, all of you are there. But they sowed the seeds of UC, and whatever you see is the fruit of, I think, that meeting we had at Ashoka basement somewhere. Where was that? Near that, that dinner was going on, and somebody said, youth has to be projected. Okay, thanks a lot, and congratulations on that new website.
Thank you so much, sir, for the blessings. And before we proceed, we would like.
The website was entirely designed by Dr. Prasanna Ravi Ramesh, who is our executive. Him and his team.
Website is very good, but believe me, the website has to be dynamic, and there should be every day some changes. Nobody should say that website is lying silent or dead for a long time. So It has to be very, very dynamic, and every day there should be something. Believe me, designing a website is one part, but maintaining it is all the best.
Thank you, sir. And before we proceed, I would like to invite Honorary Secretary of AIOS, Dr. Namrata Sharma ma'am, to bless us and give a few words of encouragement.
Respected Dr. Lalit Verma sir, Dr. Harbans Lal sir, Rajesh, Santosh, Digvijay, Devakant, Avnish, Nilesh and Sonal, who is not here with us. It is a pleasure always to be standing before you and to be talking to you. I remember when we took over as Secretary Treasurer, myself and Rajesh, in 2017 we didn't have any YO program. But ever since I've been going since 2003 to ASCRS, ESCRS, AO, there was always a separate young ophthalmologist group, which was a YO group. There was always a separate networking area, which was a YO lounge. So we wanted to do something on the same lines. And then in 2018, we started YO Pavilion, that is Young Ophthalmologist Pavilion. And we started this AIOS YOSI Forum. Of course, at that time, it took a lot of effort to convince people in the leadership of All India Ophthalmological Society. The leaders were different. They were not the same who are sitting here. But it was difficult because this was something which was not there. But having done that the first time, I think everybody really appreciated it, liked it. And so it has been continuing since then, thanks to Dr. Devakant, who was very persistent at that time. And of course, Digvijay, who's from RP Center only. So I think this time you're having a Unite also. Unite is also something which other societies have, but we don't have, and it is good to know that YOSI is growing by leaps and bounds. I'm very proud to say that YOSI or YO representatives from our country are doing extremely well in APO. And Devakant has taken APO YO to yet another level, which means that the global presence is there. And I would say that global presence of YOSI is there much before even our own society was there, and which is good to see. I'm sure you're going to be hosting the global YOSI summit soon, 2025. You've already got it allotted to India, and I'm sure that again is going to be a great event under your leadership. And likewise, just like young ophthalmologist, I am again happy to say that Dr. Lalit Verma sir has also agreed for a SO lounge, which was inaugurated in Patna. SO is senior ophthalmologist, which we again don't have. And so I think that is something that he agreed, and we inaugurated that also. Although the YO Pavilion was started in 2018, but we take pride in every time we do a AIOS annual meeting. We take a pride, and all of us go and inaugurate it, despite the fact that it has been inaugurated so many times. I think you all are doing a great job. I think there are two important things which one needs to focus as young ophthalmologist. One is the career placement of the young ophthalmologists, whatever they want to do, whether they want to practice or they want to do a government job or they want to do an international fellowship or observership. I would request all of you to adopt a program which I call the Conference Plus program. The Conference Plus program means that when you are attending an international conference, 2 days before or 2 days later, please tie up with some center which is there in that particular city. Of course, you should visit places also, but this is very important because once you go there in a different setup, it's a different culture, it's a different way of working, and you pick up something subconsciously which you may not realize. It is also networking. So you should always have a Conference Plus program whenever you go. Don't just present your paper and come back. I mean, that is important, but other things like this are also important because that kind of broadens up your horizons. And of course, second thing is do a observership or a fellowship internationally, because that gives you again a different kind of confidence, a different kind of stamp on your name, and a different way of looking things. So these are the two things which I think you should do. Thank you once again for having me here. And I'm sure the next leadership who takes over, one of them is going to be secretary sitting right here amongst you. So I'm sure they are again going to give a huge number of opportunities to USC. Thank you very much.
Thank you so much, ma'am, for the kind words. And we are now going to start with the awards of YOSI. And to begin with, we are going to have the YOSI Leadership Award 2023, and it is none other than Dr. Digvijay Singh sir. He is the past president and he is a key anchor for us. Whenever we need help, be it day or night, he is there. We have been on call, I think, for the last 10-15 days every night, and sir is like phenomenal and inspiring. So, sir is the director of Noble Eye Care Gurugram, HOD of ophthalmology at Narayana Super Specialty Hospital Gurugram, and HOD of ophthalmology at Madhukar Rainbow Children's Hospital, New Delhi. And he holds a special interest in pediatric strabismus, neuro-opthal, and glaucoma. And he has a phenomenal CV, I think you can all see. So, I'll request our president from AIOS, Dr. Lalit Verma sir, to honor Dr. Digvijay sir with the YOSI Leadership Award.
For this program also, two people who have been in touch with me are Karan and Digvijay, and hats off to them for being so persistent. नहीं सर करना ही जैसे भी आप. Thank you, sir. Thank you, sir.
Thank you so much, sir. And
I think the important thing for all of us to realize is that perseverance pays, but then you have to have a mentor like Dr. Lalit Verma who has to also keep pushing you and say कि तुम्हारा हो रहा है ना program कर रहे हो ना, what is the status? So sir also used to keep us, keep following up with us, and I think it wouldn't have happened if you hadn't given your nod the way.
You see, once a new team takes over, don't forget the contribution of these people. I was requesting Devakant also. Let them be there as advisors, even though they may cross the definition of YOSI with 40 se upar ho gaya. But let them be there as advisors at least, because of the time they have spent in nurturing YOSI. It's important that you take a experience.
so, to answer ma'am's question, officially, like few are approaching 40 right now, so they are going to be officially your mentors, and they are going to guide us throughout the journey, ma'am. Leading to the month, next will be the YOSI International Award. We have an active collaboration thanks to Dr. Devakant sir. We have YOSI collaboration with all the major YOSI societies across the globe, and we are constantly having to and fro discussion and collaboration. So we have 3 of our international YOS who are present. They are a star in their own country, and I would like to invite them on the stage, and I'll request Dr. Namrata Sharma ma'am to honor them for their presence. First of all, I'd like to request Dr. Ashrafullah, a leading ophthalmologist from Bangladesh and AIO president over there, as a token of thanks for being here and supporting us. Next, we have Dr. Poshan Singh from Taiwan. He has traveled all the way overnight to be with us, and tomorrow he's going to deliver his talk also. And next we have Dr. Kushal Pokhrel. He is the president of Nepal Young Ophthalmic Society and also a joint secretary of Nepal Ophthalmic Society. And we thank him for being, he's a lovely fellow, and I think we all will see him tomorrow in action. Thank you, ma'am.
I would like to mention, at a very short notice of almost 2 weeks, all 3 of them consented to participate and they make the long journey. So special thanks to the International.
So before we proceed, we will like to have a few words of blessings from our President-elect, Dr. Harbans Lal, sir.
First of all, let me congratulate you all for bringing the UC to such a high level, and particularly the Vijay Singh, Karan Bhatia, Divakant, Avnish and Nilesh. And Lalit and Namrata have already given you a lot of inputs how to do clinically and academically well. So I will not dwell upon that. And what I see, only thing, I think everything is great, but the attendance to my mind is little thin over here. And probably the finances are the backbone of any conference. So as soon as I take over, I'll ask your executive to come and meet me. We'll fix up in the May itself and ensure that there are enough of funds to have next gathering at least minimum 500, maybe 1000. So that should be our target, and there will be no shortage of the funds whatsoever. So the AIOS money is your money, and we will teach you how to collect the money. At the same time, if there is any shortfall, we'll ensure that the AIOS pays it to you. So there is absolutely no problem, and we are going to have a very big event next time, and we'll fix up the calendar, seeing our midterm annual, because this is probably not the right month, just 1 month before the AIOC, when many people are preparing their presentation and planning to go to the mega event. So all of you are welcome, and we'll sit down and discuss how to take it to the next level. And thank you, all of you, for inviting me over here.
Thank you so much, sir, for your kind words. And we will also like to have a few words of blessing from our Honorary Treasurer, Dr. Rajesh Sinha, sir.
Well, thank you. The only thing I would like to tell you is that you have gone beyond my expectations. Long back in 2014, when we, Tarun, Vijay and myself, we sat together and we started planning for it, we never thought that it will reach this level. The way Karan was presenting all those activities that you are doing, I mean, that's amazing. So hats off to you, and I think till now there has not been a big round of applause for Yosi, so let's have a big round of applause for Yosi. And these young leaders like Digvijay, Sonal, then Devakant, Karan, Avnish, Nilesh, and all of you, you all are great leaders. I think the way it's moving on, well, this may become the most sought after society, wherein you are doing so many things, and you are also thinking about the career of the young ophthalmologists. So I mean, that is something which is really good. So I would like to congratulate you, and I would like to thank you for giving some ideas to us also, which we can incorporate at a higher level. So thank you very much, and many, many congratulations. Thank you.
Thank you so much, sir, for the kind words. And now moving on, what we are seeing Yosi today is not just because of our governing council or office bearers. There are a lot of young ophthalmologists who just constantly keep us giving ideas, and they don't only give us ideas. When we give them, we ask them to take it forward. They take it forward to a level where there are like every month there are 4 or 5 activities happening at Yosi. So we would like to appreciate them for what they are doing for the society. And the first award is to Dr. Aarti Heda. She is untiring, inspiring young ophthalmologist, and she is leading the Surfing the Anterior segment and medical legal team, and she has taken both of them forward. So I'd like to request our President-elect Dr. Harbans Lal sir to honor Dr. Aarti Heda. So, sir, I would request you to stay back and honor our next young ophthalmologist who is taking care of the medical legal team, and he's a brilliant academician, Dr. Kaushik Tripathi. The next appreciation award goes out to Dr. Prasanna V. Ramesh, who has taken care of our website and all the dynamic things that are happening in the digital space. He is a glaucoma fellow. He is heading his own practice. Thank you, sir. Thank you so much. Thank you, sir. Next, I would like to request Dr. Rajesh Sinha, sir, to honor our next yo, Dr. Zain Khatib. Dr. Zain Khatib is an excellent surgeon, and he keeps on putting on videos on YouTube and taking care of that. Apart from that, all the hackathon and everything. Then, so the next award goes to Dr. Nupur Goyal. She is taking care of the YOSI Journal Club and the social cultural team, and she has been given an untiring effort to this forum also. The final YOSI Appreciation Award is to Dr. Rohit Modi. He is a brilliant fellow, and he is also a master of finance and personal private practice management. He is heading the sessions on finance and practice management. Thank you, sir. And now we are going to. So now we are going to move to our next set of awards, that are the annual Yo Slide Awards, and I would like to request Dr. Santosh Sonawar, sir, to honor the winners. The first award goes to Dr. Lipi Mittal. She has published the best slide for the last year on Yo Slides, sir. She just won the competition on 1st of April. And the next award goes to Dr. Aishwarya Rathore, who has the second best award. She was the runner-up of the annual Yo Slide competition. And sir, we would also like you to request you to give the awards for the YOSI Journal Club also. It is a monthly event where the journal articles are discussed in depth. So who better than you to give that award? The winner is Dr. Ayushi Agrawal. She presented the best journal article in the previous edition. She is also winner of last year's Yo Slide Award and writing competition, and she has been winning all the YOSI awards. So the runner-up award for YOSI Journal Club is being given to Dr. Anujit Paul. He is a brilliant young ophthalmologist from Kolkata, and he is active everywhere. He is publishing a lot, and he is present in all YOSI forums and all the major podiums. Sir, I would also like to request you to say a few words to us.
I think everything has been said already. I just want to congratulate you for this wonderful program and all the spectrum of initiatives that you're doing. And IGO runs because of yours. In fact, if you look at the list of assistant editors, it's all young ophthalmologists, and you actually run the journal. That's what I would like to say, and congratulate you for all the effort that you have put up in running IGO on time, every time. 2,400 new authors have been added to IGO. Out of that, 70% are yours. and 70% of the new submissions are by young ophthalmologists. So I think that sums it up, the power of yo. Congratulations.
Thank you so much, sir. And for the last set of awards, I would like to request Dr. Krishna Prasad Kudlu, sir, the member scientific committee from AIOS, to come on the dais and honor the winner of your flash notes. There are three winners, but two of them are with us today. So the best. So the best your flash notes and poster segment is won by Dr. Ruchi Sood. I would request her to come on the dais and collect her award. The best flash note in anti segment is won by Dr. Shilpa Ghosh. Sorry. And the best Yo Flash Notes for the last year has been won by Dr. Prasanna V. Ramesh. Thank you, Kudlu sir, for being here and blessing us. Coming to last part, I would like to request our acting president, Dr. Devakant Mishra, to give us the vote of thanks.
Thank you, Nilesh. And I would really like to extend a sincere, heartfelt thanks to our AIOS leaders for being here today and making this event possible. Especially Dr. Lalit Verma sir, Dr. Namrata ma'am, Dr. Harbansh Lal sir, Dr. Rajesh Sinha sir, Dr. Santosh Navar sir. The whole team YOSI, I will not take any individual names. We work like a team and it's a very cohesive unit. And we are very happy that during this event and various other events, we have never had an issue in conducting it. Everything goes on so smoothly. So thanks to team YOSI. And next, of course, Sipla for helping us financially in this event, and Mr. Kripal for being the backbone from AIOS side. So, and all of you who have taken out time, who have joined us here, and later who will see this through online, our social media platforms as well. Thank you so much, and the lunch is ready now. Thank you.
relevant session of the day. So for today's session, I'm Dr. Shraddha. I'm a private practitioner in Bombay, and with me I have Dr. Mohan Kanam, who is going to coordinate. He is a pediatric ophthalmologist, neuro-ophthalmologist, and an anterior segment surgeon based in Hyderabad. Now on the panel we have Dr. Sonal Kalia, who couldn't be here for medical reasons. She is the president of YOSI. Dr. Nilesh Kumar, he is the Joint Secretary of YOSI and he's based in private practice in Ara, Bihar. We have Dr. Nupur Goyal, who is an active member of YOSI and she's based at Noida in eye care. Dr. Piyush Bansal is here. He is a vitreoretinal surgeon and he is in private practice in Pune. And Dr. Sahil Bhandari, he's based in Jodhpur and he's a vitreoretinal surgeon. So we'll not wait and we'll start with a simple discussion. Dr. Tejas Shah sir, you're here. Why do you feel that this whole session would probably be important for young ophthalmologists? Do you wish that this session were there when you were a resident fellow?
Is why do you want me to start? Let the youngsters speak and then I will try and give my expert comments.
So newspaper articles.
Really?
Your say.
Mm-hmm.
So I mean, let's just begin on a very positive note, sir.
Absolutely. So finance is probably the backbone of anything. Nothing can be done without money, but it is actually you need to calculate your return of investment. I see so many youngsters coming up with a huge clinic with a lot of instruments. Frankly, they are not actually earning. If they actually go ahead and make a chart of the return of investment, they are actually degrading their amount, their deposits and their investment. And if you should have non-ophthalmic business people as your friends, and they will actually laugh at you. In fact, when I bought my femto, they were all laughing. For 3.5 crores, I'll make it double in 5 years or 4 years. And here, my 3.5 crore femto, which was bought in 2013, is not even selling. You understand? That's the reason finance is very, very important, and it also makes your practice go a different way. If you do not have a lot of burden, probably you are going to practice in a different way. And if you have a lot of financial burden, God forbid, it might also make you take some wrong steps.
Right. So that's the whole goal of talking. Let's start talking about this in public forums like this, so that we know the questions to ask our mentors, the seniors, and otherwise we just keep mum about it and quietly slip away when this topic is being talked about by the seniors. So, with you have something to say, sir?
No, I was waiting. I thought I still have to speak.
We'll ask you something later. So, we have our esteemed panel who's now full, and Dr. Pooja, I'd like to invite you for the first talk. Dr. Pooja is a corneal anterior segment surgeon. She's trained from RP Center, and she's now in private practice in Mumbai. And she's going to talk about the challenges faced by young ophthalmologists.
I think at the outset that this is one of the most relevant topic which is never taught in medical school. So when you kind of come out into your into the practice, you're pretty much clueless about where to start, how to manage your finances, the tax brackets. So I'll be introducing a little bit of everything and what are the difficulties that most of the students would face when they become consultants. So a big thank you to Shraddha. All the slides are taken from her. Most of the doctors would finish their fellowship or even their PG training programs, anything extra that they want to do, and they start maybe by around 30 years. So if you're very decided that you want to jump into a private practice, starting younger is always better. Training in ophthalmology, unlike other fields, is also capital intensive. A lot of people, when I picked up ophthalmology as a field, said that why are you picking up ophthalmology? Dental and ophthalmology are two very capital intensive fields when you start out on your own. A physician would need a stethoscope and a room, but ophthalmologists, the bare minimum equipments needed are slowly going up. As time progresses, as chain hospitals come in, the ambience, so a lot of things that go into your budgeting. And it's just not about practice. At the end of the day, you want to live your life, you want to have all the luxuries and the amenities that come with it. How many residents are actually here? Maybe one or two. Yeah. So once you kind of pass out, you always think, do I want to go into a corporate job or do I want to start out my own practice? If you're a first generation ophthalmologist, then you have to very seriously think about the seed capital, the initial capital that you have to start your practice. Whether you want to generate it from your family, you want to work some jobs, take up corporate jobs. A lot of chain hospitals have come in, so you want to collect your own capital and then slowly scale up. Just for your reference, a basic OPD setup, how much would it cost to start? Equipments we can divide into two categories. Absolutely top quality equipments that you should buy at whatever market rate is there, and you shouldn't compromise on those equipments. And something that can be compromised on, that means you don't need a very branded chair unit. A second-hand chair unit is okay, but ARK is something that you wouldn't compromise on, because that decides your ultimate results. Your practice grows only if your results are optimal. And I have given a rough summary of the basic equipments that you need in your OPD, and at the present at present juncture, the total cost would be around 11 lakhs. So if you say, okay, I collect 11 lakhs, do I start an OPD? No, there are other costs as well. So most practices would start on a rental basis unless your parents or somebody or your spouse already has a place of their own, which is commercial, can be used for commercial purposes. So I have, your daily rentals are there, staff salaries there, and this is like the bare minimum. So if you start out with 1 or 2 people as your staff in the initial OPD days, this is what is necessary. Everyday utilities also have to be accounted for, and cost of marketing. So if you say, okay, I'm going to put up a banner outside, I'm going to start my OPD, that is now how your own private practice works. So marketing accounts for good 20 to 30% of your input into your practice. So you're looking at a monthly outgoing of around 60 to 80,000 if you start in a 400-ish, 500 square feet space, depending on which city you start out your practice. Then there is a one-time cost of interiors, furniture, other appliances like a laptop that you need, a printer that you need. So practically you have to actually calculate all these costs. So that 11 plus 9, so around 20 lakhs is what you're looking to just start your practice, and a recurring cost of around 80,000 per month. Once you have decided to start your practice, there is something called as break even of your practice in terms of your monthly outgoing and eventually the cost that you've initially invested into your practice. So how many years are you looking to kind of get back your money? And then it is profit. Anything after that becomes profit. So approximately practices would take around 2 years to start making an actual profit. So if I make, let's say, 2 lakh in the first month, that 2 lakh is not my profit. You have an outgoing, you have a depreciation value which you for your instruments that you take against it, and then what you take home in the initial few months would be hardly anything. So you should have a contingency fund, and so when you take up a job, only when you have that contingency fund ready with you or somebody is ready to sponsor you for that, quit at that point. The other challenges that most of the young ophthalmologists would face is that no exposure to taxation. People don't understand taxation. Other than that 10% TDS or whatever is cut during your residency days, and we fall under the category of professionals. So we have a lot of advantage in how taxation is calculated. Even if you make like 50 lakhs at the end of your year, you could still save a lot because a lot of expenses can be taken up as your professional expenses. Certain financial literacy in terms of taxation also is important. So understanding depreciation. How, when you buy instruments, what tax benefit do you get? When you lease out instruments, what tax benefit do you get out of that? So when you start your practice, you have to account for all these things. So when you start out, it is better to sit out with a learned person like a chartered accountant. Grab hold of some senior who is practicing in an area around you and discuss all these terms. If you go in blindly, at the end of the day, how to maintain your balance sheet, how to balance your balance sheet is something that is very, very alien to you. Other thing that is, art of negotiation. Something that I learned from all my Gujarati friends. When you kind of start buying equipments, you have to, it's never the cost price, whatever the company quotes you that you buy the equipment for. So how much lower are you willing to go? How much lower are you willing to bargain? So that is some things that you kind of learn on the go. So it's just not about practice, it's also about your own life. Savings for your old age, contingency fund for your own personal life. People would eventually go on to have children, so children's education fund. A lot of these things are something that you have to kind of pick the tab on as you go ahead in life. And at the end of the day, don't forget leisure, because a trip to the Himalayas or the beaches of Florida can rejuvenate you and bring you back to a great practice after that. So with that, a special note on female ophthalmologists. So this is Shraddha, something that Shraddha told me, and she's smiling right now. So once you actually, the reality is you're going to have kids and you need to take a break in between. That is a reality. So how would you approach that reality? You want to go to private practice, limited working hours, which is absolutely possible in private practice, vis-a-vis a job. So all these things you have to think of, and also group practice. So I think this forum hasn't discussed group practice previously, but as a part of a small group practice, I can tell you that this is a very fruitful thing that you should sit across, discuss with your friends, like-minded friends, keep your egos aside. First step, keep your egos aside, and group practice would halve or maybe reduce your financial burden to a great extent and give you that little initial fillip, little kick that you need to start your private practice. With that, I'll end this session. So looking at this, don't think about it as impediments, but as challenges which can be overcome by a proper planning approach. So grab your book, grab your pen, and write down how much do you want in the next few years before you decide whether you want to take up a job, and at what time do you want to quit it. All right. So next speaker after this is going to be Dr. Mohan, and he's a pediatric and a neuro-ophthalmologist and a general practitioner in Hyderabad.
Thank you very much, Yosi, for the opportunity. I won't take much time. My presentation will be only to answer two questions. One is why to invest, why not to put money all into your pocket, why you should start early. I'll start with the famous quotation or discussion initiated by our ex-RBI governor, by Mr. Raghuram Rajan, about dosa economics. So during the discussion, he was telling about why low inflation, low interest rates are much better compared to high inflation, high interest rates. So a part of the discussion was about inflation. So if we assume that in 2023 one dosa costs around 100 rupees, so what if you want to buy the same dosa in 2024, if it cost 110 rupees, if you put 100 rupees in your pocket, you cannot buy that dosa in 2024. You need to put in an instrument where at least it gives the 10% appreciation, that is 110 rupees, without taking extra money from your pocket. Whatever the extra money you are going to get apart from 110 is going to be your profits. Whatever the less, it's going to be a depreciation. So practically when you put money in your pocket, you are hammering it, not letting it to work. So where to invest? if you take any big fund managers to a common individuals, these are the sources of investment or the instruments of investment, what we call. Uh, Nothing beyond this or after this, there will be no one going to invest tons and millions of money apart from this. Our most conventional way of thinking is to put money into the fixed deposit, which just barely meet your inflation. Always, when you look at the inflation data and the fixed deposit, your fixed deposit just gives 0.5 to 1% more than the current inflation rate. And once you get the interest rate into your pocket, after cutting the taxation, you will be at loss rather than maintaining the same amount in the subsequent years. So second instrument is a bonds, which gives slightly better returns compared to fixed deposits. Goals, always we call it a balancer for our portfolio. And stocks, if you are a high risk taker and you want high rewards, go for stocks. Mutual funds, it's a balance between the risk and returns. PPF, exchange traded funds. NPS, if you take PPF and NPS, whatever the scheme you may hear in the subsequent days, if at all they are giving more than the fixed deposit than the bank, that means they are putting the money into the stock market without knowing to you, and they are getting the returns and they're giving a part of the returns. So no policy in India or across the globe is going to give more than the fixed deposit returns without putting money into the stock market. Please underline this. So way to go, which investment is best? There are two people in front of you. One is Warren Buffett and second is Robert Kiyosaki. You see n number of videos and everyone speaks about him. The only funda is like which instrument you believe a lot. One person on the left, he believed in stock market, started investing at the age of 13, 15, and he has always in the top billionaires list in the Forbes. And second person always believed in physical assets, real estate. He kept on buying lots and lots of assets. Then he is also into one of the richest persons in the world. So whatever the investment, you pick an instrument which beats the inflation, so that you put extra money into your pocket rather than giving it to the government in the form of taxation. So why early? So one part we address why to invest, because to beat the inflation, whatever you beat extra, you will get profits. Whatever you don't beat or the amount which you don't beat, you have to take away or give it from your pockets. So why early? Again, Warren Buffett is more known for his wisdom rather than his investing procedure. He's simple, straightforward person. His famous quote is like, you cannot produce a baby in 1 month by getting 9 women pregnant. So for everything, you need time. Start early. That's the funda. If you look at any financial books, this is one of the most commonly searched images on the net. If you took two persons named Shruti and Akhil, both started investing 100 rupees or $100 per month. One starts at 20 years, second person starts at 30 years. Both the money in both the pockets are growing at the 7%. But if you look at the initial lag phase, the 20 years to 40 years, you don't see much returns. That's why it's always important to start early. You cannot start at 45, 50 and start waiting for your money to get double in next 5 years. The earlier you pass this first 10 to 20 years, the better returns you will enjoy in the early part of your life and you can retire early. However, even though the 10 years difference is there between those two people, the amount of return that they are getting is almost the double. The Shruti is getting almost the double, even though she started early compared to Akhil. The amount of difference only 10 years, but the amount of fund that they are going to get is almost double. And the problem, one of the advantage about investing early or keeping anything or just buying the instrument which you like, either it may be real estate or stocks, it compounds. Albert Einstein said compounding is the 8th wonder of the world. If you start putting one seed in each box and double it in the next consecutive boxes, it will fill within no time. But if you look at these first 4 boxes, you can see almost it doubled within not much significant amount. Whereas if you look at the last 2 boxes, the amount of money the doubling or the amount of thing that it's getting doubled once you give significant time is massive. And this phase, if you pass as early as possible, the much more better returns you will get. So this is one of the example, most common stock, Indian Tobacco Company, ITC. It started somewhere in 1970s, and if you had invested somewhere about 5 stocks in 1980, let us assume, and it started giving dividend bonus in the following years, they gave almost 7 times. So during that time in 1980, the cost of the stock was around 20 rupees. So the number of shares of if you bought 5 shares at 1980, it would have almost 180, it would have become 180 shares, and the cost of present ITC is 380 rupees, and that just 20 rupees would have become 68,400. And when I say this, it is easier to say when you look things retrospectively. I still suggest to go and invest in these companies because they are gold standard. If they are collapsing, the Indian economy is going to collapse, and no government is going to take the risk. TCS, Infosys, ITC, whatever the things, no government is going to take the risk to let them collapse. So 20 rupees in 1980, 68,400 in 2023, you would have almost beat the inflation by maybe 100 times. So conclusion, save till certain point for your emergency funds or whatever the plans you are having, then start invest. Select your investment instrument, either it may be real estate if you believe, or your parents believe, or you force you to do, or if you are very much more into the stocks, which currently the golden year is going to come, golden years for the Indian stock market. If you believe that, you invest in that, and be patient. Don't check it daily that how much it has grown, how much it has decreased. Give some time, 15 years, 10 years, and you see enjoyment. For example, I have given a gift of 5,000 rupees stocks to my niece in 2019 December. The Reliance has grown by 60%, Infosys has grown by 90%, and one more thing, Wipro has grown by 40%. Imagine the amount of return that you got in the last 4 years, how much you will get in the next 5 years. All the best. Thank you. Happy investing.
Thank you, Dr. Mohan. That was very insightful. I'd now like to call upon Dr. Raj Shah. He is a practicing anterior segment surgeon. He is based in Mumbai, and he is going to talk about mutual funds. Dr. Raj Shah, over to you.
Good afternoon, all. Thank you, Yosi, for the opportunity. I'm Dr. Raj Shah, Shah Care Center, Mumbai. The topic for today is mutual funds, basics and portfolio creation. So first of all, can I know just one thing? How many are already investing in mutual funds? Already investing. So almost, I see 50% are investing, 50% are maybe not investing. Okay. So from here, we'll take on and see at the end of it, how much do we know more about mutual funds. So first thing, the first topic was invest early, retire early. But do we want to retire early? We've just started our practices. Okay. Yeah, but then obviously we want to grow our money. Early investing, the power of compounding, Dr. Kannan has told us. That's very important. So all of us want our money to grow, right? So what is the growth of the money is what he has very correctly explained. When the rate of return beats inflation. Like if my 1 lakh rupees becomes 1,10,000, but the rate of inflation is 10% for that year, my money has not grown. It has remained the same. So this is the reason, what's wrong with just savings? Whatever money you have, you just saved it. This thing eats up the money, inflation. So year by year, the value of whatever you have, if it is just saved, it decreases every year. This is one example. This is inflation like in 2021. If it is 1 lakh rupees with a rate of inflation of 6%, every 5 years you see the value of that same 1 lakh will reduce in 2056 to 11,468. This is the impact of inflation. Like if you just keep that 1 lakh rupees for the next 30 years in your bank locker, this is what will happen to that 1 lakh rupees after 25, 30, 40, whatever years with whatever rate of inflation is there. So your money needs to grow beyond inflation. That is when you earn money. So hence one must work, but at the same time you must learn the art of making money work for you. Real earnings are those which remain after beating inflation. So now this mutual fund investing is a way to achieve that. Even for people without much direct knowledge about stock market investing. You know, most people have this phobia that stock markets, we don't know anything. What are these stocks? This, that, we don't know. But we want to invest our money. So then this is the way for you. Without any direct knowledge also, you can participate in this stock market. This is a brief overview of the presentation. Like we'll discuss about what are the mutual funds, what are the types of mutual funds, you know, based on the structure, the investment objective, how to create an investment portfolio. So what are the various categories, what is goal-based investing, then how to invest in a mutual fund, what is a centralized KYC that you need to do before investing in a mutual fund, what are the various options of this mutual fund schemes like the growth plan versus the dividend plan, regular plans, direct plans, what should you go for. So all these in brief we'll discuss. Okay. So first of all, what is a mutual fund? Basically it pools money from various small investors, and it is invested according to pre-specified investment objectives. The benefits accrue to those that contribute to this pool. So there is this mutuality in the contribution and benefit that you gain from the investment, hence the name mutual fund. So basically, in simple words, there is an asset management company. That company takes money from you. There is a professional fund manager who invests that money into the stocks according to his or her knowledge. Okay, helps generate the returns, and those returns are given back to us. So this is what is the concept of mutual funds. Basically, what are the types of mutual funds? Now, when you are investing in mutual fund, there are broad categories of three. There is debt mutual funds, there are equity mutual funds, and hybrid. Hybrid as in which invests in both debt as well as equity. So, what is debt? Debt is when you are having assured returns, like 8% returns is given to you, that after a period of 5 years, you will have 8% returns per annum, and that is the final amount that you will receive. That is what is debt. Equity means investing in the stock market. Stocks is equity, and hybrid is a combination of both. Then based on the investing styles, there is funds which are invest in growth kind of stocks, then value kind of stocks. I'll be explaining all these things in detail later on. Active and passive funds. So now we'll discuss one by one. So again, this is again the same thing: debt funds, equity funds, and hybrid funds, which is a combination of both. So what is a debt mutual fund? Debt mutual fund scheme is which invests in fixed income instruments such as corporate and government bonds, corporate debt securities, money market instruments, etc. Debt funds are also called as income funds or bond funds. Now, when you go to a mutual fund website and all, you see various kind of funds, and people get confused. This fund, that fund, bond fund, short-term fund, long-term fund. So basically, all these terms: income fund, bond fund, gilt fund, debt fund, short-term fund, are all debt funds. So debt funds are less risky, but can only offer very moderate returns, like slightly better than the fixed deposits, but not very great returns. So these are the various examples and categories of the debt funds. On the left hand side, when you see in the first column, overnight funds, liquid funds, short duration, ultra short duration, XYZ, and this is what they invest in. On the right hand side is written the T-bills, which are treasury bills, corporate and government bonds, XYZ. So it is basically the fund manager who is investing into all these things. You don't have to worry about what is a T-bill, what is a CD, what is a CP. It's not for us to understand all these things. You just invest in these things and you get the returns. So this is just an example. This is just to show the various funds which are there. See the last column, 5-year returns. So this is for 2017. If you see the 5-year returns, on an average, you will find 8%, 9%, max to max 10%, and a single fund giving you 11%. So if you see 9%, but in 2017, even the fixed deposit were giving 8.5%. So what more did you gain? 0.5%. 0.5% from a fixed deposit you gain in a debt fund. So debt fund is basically for, not for small investors who want to create money in the long term. If you have large amounts which you want to keep for a very short period of time, which you then require maybe for after 6 months, you'll be requiring for some investment into a property or some other thing, or you are maybe transferring money from a debt scheme to an equity scheme, then it's more important. But obviously you can also consider it as an alternative to fixed deposits. 0.5% also it gives extra only. So next is the equity mutual funds. Equity mutual funds are funds that invest predominantly in shares and stocks of companies. So now, as we had seen previously also, that equity funds will be either passive funds or active funds based on the investment strategy. Also, they can be divided as large cap mutual funds, mid cap funds, small cap funds. Also, further classification can be done as diversified funds or thematic or a particular sectoral fund. So we'll speak about all these things also now. So what is an active versus a passive fund? So an active fund, what happens is the fund manager, there is an index. Always if you see there are two main stock markets, the NSE, which is the National Stock Exchange, and the BSE, which is the Bombay Stock Exchange. So they always have, okay. So I'll just continue. So these are two indices which are there. In an active fund, what happens is the stock manager researches about the companies and by himself decides which stocks to invest in. So they incur a higher cost than the passive funds. In a passive fund, what happens is any popular market index like a Sensex or a Nifty 50, we'll explain about that is also. It just mirrors the portfolio of a market index which is there. So hence there is no active stock selection which happens in a passive fund. So the cost of the fund goes less. Since the cost of the fund is going less, what we get will be more. So this is according to the market cap. Large cap companies, mid cap and small cap companies. Large cap is the first 1 to 100 companies.
We'll have to hurry a bit.
Sure. This is basically according to market caps. Then the sectoral funds are like the IT funds, pharma funds, banking funds, all these are the sectoral funds. As I told you, hybrid funds are a mix of all these various different kind of equity and debt funds which are there. So basically, we'll just rush through this, and index funds and all these are there. So we'll just go to the goal-based investing. So basically, you decide the goal, and then you accordingly invest according to the goal. Make an SIP, like which is a systematic investment plan. Always go for direct plans. Whenever you select a mutual fund, there will be a direct plan option and a regular plan option. So go for a direct plan, because in a direct plan, you are directly investing in the company. In a regular plan, you are investing through a broker who is then given commission. So because of that commission, what percentage you get will reduce. Then between growth and dividend options, these will be there when you select a mutual fund. So always go for growth options. What happens in a growth option? When a stock or a company declares dividend, that dividend again goes back into your investment, and your investment rises. Compared to a dividend option, where when a stock or a company declares a dividend, you get a regular income in your account. And in the growth option, that small dividend will be reinvested in your scheme only. So these are the various modes of investment. SIP, systematic investment plan. Just 2 minutes. This SIP is the main thing, so that I'll explain, and then we'll finish. So every month, a fixed amount, you should start doing this. As less as 500 you can invest. So if you're investing around 500, whatever amount is okay for you, invest that much. Every fixed date, that amount will be cut from your bank account and invest into that particular scheme. So over a period of time, what amount you will have is quite good, and that helps your investment grow. So see, this is the power of, this is what is called as rupee cost averaging. Like one investor on the right side, if you see lump sum investor who had bought 60,000 rupees ka units, he got 3,000 units. On the left side, if you see that same amount, 60,000, every month 10,000 was invested, and because of the market fluctuation, sometimes the market is high, sometimes the market is low. So you get more and less units, and in the end, the units which are there is 3084. So this is what is the advantage of SIP versus a lump sum investment. I will skip all these things. So basically now we'll directly go to the take home messages. Okay, so basically when you create a portfolio, invest not in more than 5 to 7 schemes. Take a mix of large cap, mid cap, small cap schemes and flexi cap schemes, and an ELSS. ELSS is equity linked savings schemes, where you get the tax benefit. If you are investing according to the old tax regime, 1,50,000 that you get under Section 80C, which you get in PPF or other investments also, you get in this mutual fund scheme also. That is ELSS scheme. Always have a higher investment horizon, because this equity and all takes time. It will not be like in 1 year, 2 years you will get the return, but around 7-10 years you will make good return. Invest via SIP mode, do goal-based investing, invest in direct plan with a growth option, and diversify. Don't just invest in stock markets, is that. Invest everywhere. Invest in gold, have some FD, have some PPF, but invest in mutual funds also. This will give you great returns. Okay? Yeah, thank you so much everyone.
Thank you, Dr. Raj.
Yeah, sorry for exceeding my time.
That's completely fine. Thank you. So we have Dr. Nirav Raichura next. He's an oculoplasty consultant who's based in private practice in Mumbai, and he is going to go against Dr. Raj Shah and tell you why you should invest in equity and a few basics about that. Over to you, Dr. Nirav.
A very good afternoon to one and all. I would like to thank Team YOSI for giving me the opportunity to speak here today, and also thank Dr. Shraddha and Dr. Rohit for making me a part of this session. So I'll be talking about equity investment, the what, why and when of equity investments. So I've tried to keep this as simple as possible and break it down to the simplest of what can be done in terms of equity investment. So at the outset, or to begin with, one should know the difference between investing versus trading, and here we will be talking about investing mainly. So the difference is that investing is for the long term, it is based on fundamental analysis, and it is for all, means everyone can and should do equity investment. Trading is for the short term, it is based on technical analysis, and it is typically not for us doctors, it is for the stock market professionals who are doing this 24/7. So equity investment is for the long term, like I said. The minimum horizon one looks at is about 10 years. This is for wealth building. It is not for cash flow generation. Means you are not looking at having a fixed amount of cash generated out of your investments every month or so. This is for long term wealth building that we are doing. The idea here is to increase the assets over time and to build a retirement corpus or leave a good fortune for the next generation. So why equity? To begin with, it's not difficult. it's not as difficult as it is made out to be. Obviously, you have to devote time, like every good thing in life. The returns in equity are the highest amongst all asset classes, and this has been historically proven. Diversification, like my colleagues here have already spoken about, don't put all your eggs in one basket. So if you already have enough of your portfolio in mutual funds or fixed deposits or PPF, equity is one way of diversifying. The effect of compounding can be taken advantage of in equities too, like Dr. Mohan has already explained us. And according to me, equity is the only asset where you are the true owner. So by true ownership, what do I mean is that you are legally owner of the company you hold the shares of, to the extent of your of the percentage of shares that you are holding. It may be as minuscule as 0.0001%, but you are still legally the owner. And the good part is that no space is needed to store this asset. You don't need a cupboard, a closet, a locker, or any kind of real estate to store this space. It just virtually lies there in your demat account. It cannot be stolen or borrowed or taken away or claimed by anyone. So now coming to the questions. These are the questions that are routinely asked. So one is, when should I start investing? At what age? So the simple answer is start as early as you can. Maybe start investing from the time you get your first stipend of internship or PG. So we have a very good example of an ophthalmologist in Maharashtra. I will not take the name. That ophthalmologist started investing out of his internship stipend into just one single company. He just picked up one company and kept on putting small amount of money in that company called MRF. And when he completed his ophthalmology post graduation and was about to start his private practice, that money had grown exponentially to such an extent that he could buy all his equipments from just selling part of the shares of MRF. So that is the kind of growth that you can see in equity. I'll not explain this chart. This is about compounding. Dr. Mohan has already explained us that. The next question that is asked is when to buy. Is this a good time to buy? Should I buy now or should I wait for the market to fall? The simple answer here is there is no right or wrong time in the market. There are always individual opportunities, whether the market is a bull market or a bear market. You can always find opportunities. So start now. Obviously, you keep adding, you keep on investing more, and you can be more aggressive when the market falls. Like Warren Buffett says, be fearful when others are greedy and greedy when others are fearful. So when the market falls, you can be more aggressive and invest more. The next question is, when do I sell? So the simple answer here again is don't sell. Why would you want to sell a good investment? Do you sell the gold that is lying in your house just because the gold prices have gone up? No, right? So don't sell your stocks either. Okay. I would say the only time to sell is when you are in genuine need of money and there is no other asset that you can mobilize the funds from. Like say you want to start a new practice, you want to take a new equipment for child's education, etc., etc. You can sell your stocks at that time. And the second time is when you realize that you had made a bad investment in the past. So if your opinion about a particular stock in your portfolio has changed over time, then you may sell that stock and put that money into another better opportunity. Having said that, so you do make mistakes. It's not that you can't make mistakes. So even experts make mistakes. And here, this is a quote from Peter Lynch. He is an author and one of the best investors of all time in Wall Street. So he said, if 7 out of 10 of my stocks perform as expected, then I am delighted. If 6 out of 10 of my stocks perform as expected, then I am thankful. 6 out of 10 is all it takes to produce an enviable record on the Wall Street. The next question is what stocks to invest in. So again, here you need to do a little bit of study. You need to study the fundamentals about companies, but you can keep it as simple. You can stick to the very fundamental basics. You don't need to go into depth. So you don't need to be a master at economics or a master of mathematics or statistics for this. But yes, you should know a few simple terminologies or jargon in the stock market, like stock price, high low, PE ratio, face value, book value, net profit, return on capital employed, EBITDA, market cap, debt equity ratio, dividend yield, etc. So these things, yes, you should know a little bit about all these things, but not into too much of detail. Okay, so don't get boggled by the terminologies here. We'll still break it down even further. To simplify further, if you have to buy a stock, think of it as your next business. So would you buy the stock? So when you think of it as a new business, in what business would you want to put your money? A business that is profitable, a business that is more profitable compared to its peers, right? A business that produces profits every year, year after year, right? And the graph of this profits is on an upward trajectory. So it it's showing an increased profits every year, year on year. So that is the kind of business that you are looking into. So if you are studying a company, you would look at their earnings, and if the earnings are going up year on year, the profits are going up year on year, it's a good company. It's as simple as that. So to take an example, if I ask the audience here, can someone tell me which was the largest consumer car company in India in 2005? Which was the car company which was selling most cars in 2005? Okay, it was Maruti, right? Every one of us knows that. It's common knowledge, right? So if you would have bought shares of Maruti in 2005 at around 400 rupees, now it would have been 9,000. So that is 21 times, right? In just 18 years. This is phenomenal. So you don't need any extra knowledge for that. Everyone knew that Maruti is there. So instead of buying a Maruti car, if you would have bought shares worth that much, it would have grown 21 times. So again, HUL is a FMCG company. Every one of us knows about it. And if you would have invested in HUL just 18 years ago in 2005, your money would have grown 18 times.
Can you fasten it?
Yeah. So yeah, we're just finishing. So my advice is read financial newspaper, daily newspaper, one fortnightly magazine you should read, correlate news to business and identify opportunities. This is more important than studying the company statistics and balance sheets. So these are just some handy tools. If anyone wants to start newspapers, you can start Economic Times, Business Standard. Magazines are Capital Market, Dalal Street Investment Journal. Websites, Equity Master and Money Control, or Screener.in and TradingView.com. These are the handy tools. These are my role models. So one should read Peter Lynch, Warren Buffett, and Howard Marks to start investing. Thank you.
Thank you very much, Dr. Nirav.
Thank you.
So I welcome Dr. Shraddha, entry segment and cornea surgeon from Mumbai, to speak upon Get Good with Money Action Steps.
Thank you, Dr. Nirav. Thank you, Dr. Mohan. And I'd like to thank the YOSI team for incorporating this session and for the opportunity to present here. And my talk is going to be on Get Good with Money, the action steps. So we've spoken on some basics of finance, and then you're wondering, okay, now what? How do I start? So let's see how you can start. So I divide it into plan, what you do, what all you check, and then how will you improve upon, you'll take action to improve upon things. So in terms of planning, I would say that this thing can be the first starter, that you should have a mindset shift that you want to focus a little bit in life on money because it's important. So I would take it a little ahead, and I would say that we may have an elder person or somebody in the house who would take care of our finances, or maybe a spouse, but I feel that everybody should take complete responsibility of what is happening with their own finances. And for beginners, you can start off with reading some books which would give you a basic idea, and then over time you can switch over to monthly and weekly periodicals, or go online and check. The next thing is, you have to know that time is money. As a doctor, our ability to see patients, how much time we invest in seeing patients, that much income we can generate. So you should know your time is money, and have that in mind for anything that you do. The next thing is inflow and outflow. So you need to know how much you're making and where all you're spending. Now there's this saying which says that if there is a leak, even a small leak, it can sink an entire ship. So if you know your outflows, the way where your money is going, and you can plug those leaks, you will be able to manage your finances in a better manner. So simple thing, download an app and document whatever is inflow and whatever is the outflow. Even a small thing that you buy from the stationery store, you should put it in that app. Now, if you want the bigger picture and not go on a day-to-day basis, you have to write your financial goals. In terms of financial goals, you can make it into short term, mid term, and long term, and you can divide it into say 3 years, 3 to 6 years, and more than that. In that, just keep an open mind, write whatever you want. Now, after that, you put it through a sieve. The sieve would be you put it through security. Security means that for whatever are your basic fears in life or your basic necessities, you want to have some goals, such as say the retirement corpus. So you would invest that much amount of money in government bonds and bank deposits, which are pretty risk free and give you moderate returns. The next thing is, what are your goals related to stability? So you would want to invest in your child's education. So you would want to invest into stable large cap investments. The next thing is your ambitions. Somebody maybe wants a holiday home in Goa. So that would be the third level of investment. That would be the third level of financial goal. And for that, you can invest in say in equity or a small cap mutual fund. The next thing is, what will you do? So let's save. Let's save, because earlier we were taught income minus your expense is equal to saving. But the new age belief is that your income minus your saving should be your expense. And you should go from spending first to saving first and then spending attitude, because of the power of compounding. So if you start early, multiple speakers have spoken about, if you start early, your money compounds and it grows even further. Now, all of this that we are doing it to achieve financial freedom. But at one point, you need to save to have emergency funds. So you have to remember that emergency funds, it was very aptly shown during Corona that you should have about 6 months of emergency funds with you in very, very easily liquidable assets, so that you can take it out and use it in an emergency. Now, we are not all saints, right? We are not going to like save money and invest here. We have to spend too, right? So let's see where we start with our spending. Start your spending by paying your taxes. Find out the tax exemptions. You need to buy a house. So buying a house that you live in, that is not considered as your asset. That's where you will die. So that you cannot sell. So you need to consider that as something that you need to buy and keep. But the other real estate or property that you buy, now all the financial gurus, there's a big discussion about whether you should buy more property. Is it a good investment or not? To summarize, well, diversified investment into the stock market through equity or through equity mutual funds will give you much better returns. So property, by the current knowledge, is not a very good investment except the home that you own. The next spending is, you would want a car. So you have to see, if you have money, just buy the car. If you don't have money, then you have to think that, okay, am I going to take a loan? So if you have to buy a car of 7 lakhs, you have to remember that if you take a loan, you're going to pay extra for that car in forms of EMI. Or if you say, imagine that I'm going to buy a 7 lakh car in 5 years, you have to make that calculation and then calculate that in 7 years it's going to cost 11 lakhs 27,000 because of inflation. Then you kind of invest in a SIP, say 15,000 per month, to afford that car in 5 years. But I would also want to make a note of this. Virat Kohli recently sold all of his cars. So think about, before you buy that car, before you have that ambition, why you're doing it. Dr. Neerav rightly pointed out, buying the Maruti stock was much better than buying the Maruti car. So next thing that you need to invest is in insurance. Now, insurance is not an investment, okay? Insurance is something that you need to spend on. Now, you need to take life insurance if you have dependents, and term insurance is the way to go. Start your term insurance early, because a premium which is fixed, that is fixed for your entire life. And health insurance, you should buy a health insurance policy along with some super top-up policy. Next, you need to think of whatever conferences or meetings that you need to go for, and that's more important for people in academic careers. And for people who are in private practice, they would have to kind of consider the real estate that they have to buy. Do they have to rent a space for their practice, and the equipment they have to buy. Next step is checking. So keep a check on your loans, keep a check on your credit card. Suddenly you start earning because you've got a good job. You don't increase your credit card limits and splurge on things and increase your credit card spending. You need to look at your tax status, which starts on 1st of April every year. You don't look at on in March towards the year end. You look at it on April, and you plan your taxation throughout the year. So there are multiple exemptions like investment in PPF, something known as National Pension Scheme. There are multiple areas where you can read online about that, but make sure you take all the deductions which are allowed in your tax planning in April itself and not at the end. Now, you also need to have a retirement corpus, and I feel that was like the basic necessity. Now, why do you need to plan for retirement? The reason is there's inflation which eats up your money. Your average lifespan is increasing, so you may have multiple years of actually not earning and being slightly older, not being able to earn, and your expenses of medical expenses will increase. So you need to calculate your retirement corpus and start investing in SIP, in mutual funds or equity, so that you can have a good retirement corpus at the end. And it is a known thing that if you don't withdraw more than 4% out of it, then that you'll have sustained income all throughout your life. Also, you need to act on increasing your income. So for people who are doing monofocals, why do you go towards multifocals? To increase that income per patient, you have to add more services. Say you might want to add aesthetics, Botox and fillers in your practice of cataract. And whatever age you may be, you need to write a will so that the people who are there after you, they don't end up in a soup. So if I have to tell you something to do today itself, write your goals. Make sure that you have emergency funds, otherwise arrange for it. Plan your retirement corpus and check your tax benefits. And what you're going to do the rest of the year, that I've already spoken about. So the whole goal of this thing is to achieve financial freedom, and you work in a way which is very conducive, and you work and you see patients that you want to, you advise surgery that you feel which is absolutely required. So with this, I'd like to start off the panel discussion. We have with us Dr. Piyush, Dr. Sahil, Dr. Nilesh. Dr. Piyush, you had some comments regarding all the talks. I noted that you're very sincerely writing down all questions or comments. So do you want to start the panel discussion?
Sure, Shraddha. I am a very sincere person, so yes.
So just a minute. Before that, I just want comments from all of the panelists. What is your way of beating inflation along with your comments? And thanks, Shraddha, for the presentation.
Thank you, Dr. Mohan. Let's go with one-word answers quickly. Beating inflation.
Along with your comments.
See, right now, one-word answer.
Bolo.
Just invest. If you want one-word answer, you have to invest. There is no other way to beat inflation.
Is the instrument, what instruments you are preferring? Real estate?
In my case, everything.
Everything. You are mixing it up.
It's a
balancing.
It's everything. Yes.
So more preference toward one kind of instrument.
Equity.
Sorry.
Equity.
Okay.
Equity, mutual funds. These two things are, I think,
The bigger chunk goes to
almost like similar.
Balance.
Nothing, no balancing. Rest is obviously, if you are good at investing time in your share stock market, then I think that goes higher than both of these.
Dr. Nilesh, I think your preference is equity, right?
No, my preference is my business first.
Right.
So
okay.
because that beats inflation like nothing.
Right. I think that's a very good take-home point. Your business over both of them. That's a very
Just
good
one more
point.
addition to all of this. So you cannot have a fixed decision whether it's equity or mutual funds or gold or property. It changes time to time, and you have to see what suits your personal benefit also. So in case if you have a fantastic piece of land that is available, and instead of buying equity, if you buy that land, if you know for a fact that this is going to appreciate tremendously in the next 10 years, equity will not come close. So you have to see at that particular point of time what fits the bill, what fits your budget, and what is going to reap benefits for you in that particular situation.
So yeah, what you're saying is right, but at this point I'd like to interject a little bit. I showed you the pyramid of investing. So I feel that one pyramid, which is your stability, you should make sure that your investment in that retirement corpus, which will take care of your expenses till your old age, that kind of should not be touched in spite of having like a good property or anything which is in sight. because that if you touch, then you're losing that effect of compounding. Of course, others may disagree, but I feel that stability part should be don't lose that thing, that your stability part which you need for that financial goal you should not touch, and only that extra which you have for your probably ambitions, that you should touch and invest.
I agree with that, Shraddha, completely. The only difference is that you have to decide. There's no one rule for all. So it depends on what scale of practice you are at, how much of somebody had spoken about risk-taking ability. So risk-taking ability changes with every person. Just because somebody is young, that does not mean that his risk-taking ability is more. There could be somebody who's old, and there's a lot of funds that are there in the family. So again, their risk-taking ability is much more. So similarly, you have to take care of that stability factor. That is why I really believe in SIPs. Yes. So again, you have to make sure that is there, and only when you have a certain amount of funds dedicated to those, then you go out and venture out into these ambitious projects.
Okay. So another question which is quite pertinent is property a good investment? And if Dr. Tejas Shah, Dr. Krishna Prasad, sir, anybody wants to speak on is property a good investment in your mind, or anybody wants to speak about gold being a good investment?
Well, it all depends on your goal. Whether goal is your goal. Gold is a very liquid cash. So in fact, what I have done is I already have kept some gold ready for dire emergencies. You never know, those may come. But I would definitely put my egg in the basket of equity. And probably in Gujarat, we have a lot of friends. In fact, I have an entire group who are all builders. So that's what I said. If you keep on talking to them, they lead you to good investments. And in my 30 years of practice, I have found that if I had invested, say, for a land at 2,000 rupees, it has never become 1,800. Very rarely it has become 1,800. Yes, there were certain investments which stayed for 2,000 for 15 donkey years, but then they are now 30,000. So you can, and you should all understand that there is always a cash component in land. So that's the reason I asked what kind of a goal you have and what kind of a money you want to invest. If you want to invest all check amount, then equity is not the correct place.
Dr. Krishna Prasad, you are waiting to make a comment.
Shraddha, nice talk actually. I still remember your hospitality in Mumbai last time when I met you.
Thank you.
See, basically people should not follow me. Whatever I did in my life, sometimes by hearing lectures, I always feel very sad, because whatever I earned, everything I put it on my equipment. Place like Udupi, I think I do have got every equipment on the textbook, like from Visumax till Mail 80. You name any equipment, I am having. That was my passion actually. But but that is my passion. Whatever I earned, like it is my now 24th year of practice. That time, whatever I earn, I used to like earn 3 lakhs rupees. Okay, what is the equipment available? 5 lakhs I used to buy. But people should not do that. I personally feel that they should have a systematic plan that now I am advising all my youngsters that people invest in SIP investment. SIP means every month it will go. Without your knowledge, that money will go. Then suddenly after 5-6 years, you will see that a lot of money. This is all sort of equity only. The money will be accumulated. That kind of saving has to be done. But someone interested to invest on land also, that is also one good option. But I am bit against, my wife is always fight with me, against for buying gold. But you all ladies may hit me also. But I am bit, since beginning, I am bit against to the gold. But my wife, she is very much liking gold. So of course, having gold, that they used to do like, I think January 31st, they ended with something gold bonds. So my CA was pushing me that buy that gold bonds, which is going to be help you later on. But definitely buying gold, keeping like safety sake is also not a bad idea.
Right. Sir, you have something to say?
Yeah. See, the thing is passion for anyone who has to grow. First, foremost thing one needs to remember is that you need to develop your own passion and your basic profession which you are interested, which is your forte. So your primary investment should always be going towards the your own profession. That leads to ultimate growth which can multiply. Because for any other sources of investment, you have to bank upon the expertise of some of your friends or the so-called counselors part of it. And to my experience with 24 years, I have realized that when you bank upon them, it hardly grows. It hardly grows, be it a SAFE or a mutual funds, or unless you go in deep into it and you have time to invest into it. Now, regarding when you are developing your own passions and investing into your passions, like Krishna Prasad has said, one needs to remember how you should balance it against the safety stock. What I used to do is, for example, if I decide to buy a machine worth 1.5 crores, what I would do is I would put a small seed money into that, take a loan on that, while whatever amount which I would not put it, I would put it into the land or whatever I thought. So the growth in the land value which I would put it into a stable thing against the depreciable amount will be compensated. And here, whichever you have put into instrument, you are earning out of it as well. So do not put all your, even if you have 100 rupees, equipment is worth 100 rupees and you are having 100 rupees in your pocket, please don't put it exactly to buy fully at a go. Just put 20 rupees, 80 rupees, have a loan. Against it, you invest your 80 rupees into something called a land or places wherever you situated. You do study, and I think land does not really require much of your brains in today's way of investing. It is one of the safest investment which multiplies very decently.
So that's a very good point. The only difference that I would say is that you can buy land for sure, but you have to also have your money in equity or perhaps in the bank or in the form of gold. The reason being that you might need liquidity. And selling land sometimes is not that easy, or selling apartment is sometimes not easy. So again, you have to weigh both of them. If you can allow me, I would like to, for the benefit of everybody, also make some quick points.
So we make it just quick. Yeah.
So Dr. Raja had an excellent presentation, and one thing that he said was that this is the fund manager's headache. I would slightly disagree. When I started, I'm not a very old player over here. So I started my practice 7 years ago. So it's just recently in the last 1.5 to 2 years that I've started to invest. I personally think initially that's what I thought. I had 2 people, 3 people, these fund managers coming in, and my interest would be very less. So better than that, what I would suggest is people who are now starting to do it, you can just download some very simple apps. Zerodha is one of the most popular apps, Angel Broking, Angel One is. So you have many simple apps that you can use, and you can start reading them yourself every single day, whether it is SIPs, whether it is mutual funds. And,
we'll have to wrap up, Dr. Piyush.
Sure.
So, Dr. Nilesh, you had a quick comment?
No, it will again be very
long.
elaborate.
So can we invite Dr. Krishna Prasad Kudulu sir, Dr. Tejas Shah to please help us with the mementos for the panelists?
Prashant sir also, sir.
Dr. Prashant Bhavankar sir, please. So Dr. Krishna Prasad Kudulu, I'd like you to felicitate Dr. Piyush Bansal. Dr. Nilesh. Dr. Mohan, Dr. Nilesh, sir, you have to felicitate Dr. Nilesh. Dr. Sahil. Yes, sir, please go ahead.
My goodness, how many?
So we have 7 of them.
Okay.
Dr. Tejas Shah, can you felicitate Dr. Mohan?
You're very good here.
Thank you. Dr. Tejas Shah, next Dr. Raj Shah, can you please come? Dr. Prashant Bhavankule sir, can I please request you to felicitate Dr. Neerav Raichura?
Dr. Neeraj. No, sure. I request Dr. Prashant to felicitate Dr. Shraddha. Yeah. I request Dr. Pooja to come onto the dais, please. Over. Yeah. Thank you. Thank you very much. Now next session can continue.
Dr. Prakyat Roop, Dr. Ankit Agarwal, and Dr. Shilpi Naranvare. Are you here? Yeah, ma'am, please do come. Yeah. So, next 1 hour, we'll see some cutting edge innovations in the field of ophthalmology. And we are a team of 5. So, I'll be moderating the session along with Dr. Prithvi, Dr. Karthikeyan. I would request all the speakers to take your position on the dais. Prithvi, Karthik, Shishir Varghese, and Pranesh Balasubramanian. Want your concentration for a few minutes. We thought we'll do a demo of one of our innovations, then proceeding to the slide presentations. So this is called the ophthalmic metaverse that we have innovated along with my team at Mahatma Eye Hospital, Trichy, Tamil Nadu. So you can see here the demonstrator, Dr. Anugraha here. It seems as if she's moving through thin air, like the Iron Man movie where we saw Tony Stark, right? So this is the eyeball that she's actually catching. So this is all working as for us in pedagogy, simulative learning, where you can see that you can demonstrate the fundus examination, and that if you move forward into the eye, you can see a direct ophthalmoscopy simulation and all this whatnot. So this is going to be the future of ophthalmology is what, 1 second, it's just hanging. Yeah, so before we go to the slides, I just wanted to show a quick recap or of what you can expect from this session. So this was, can load it and keep it ready. Yeah. Now, so on top you can see, can you show the right hand side top? Right hand side, the neuro-ophthalmological model. Yeah, you can see that there is a neuro-ophthalmological model placed somewhere here. So the brain, the transparency has been reduced here, and you can go take it there. Yeah. So there is a circle of Willis model, there is a cavernous sinus model. Don't go far away, it will disconnect. So this is like demonstrating the structures in real time. You can actually see structures. No, cut edge. There is some connectivity issue. So as we have the slide presentations, so Dr. Anugraha will be coming to your place where you are sitting, and she'll be showing a one-on-one demo when the presentation is actually happening. So this you can see, just show the models around. Yeah, you can see all the models floating, and we have an MAGS simulator as well, where you can see that this is a G1 simulator that we have recently innovated. So these are all microsurgery which needs a dexterity of our hands, a right hand, a left hand, and even the neuro-ophthalmic structures in 3 dimensions. As you can see on the right, the neuro-ophthalmological features. So all these models will be come to your places. She'll come one-on-one and she'll be showing it. So we thought we'll have the session more interactive and more innovative as we promised. So for the next few minutes, 5 of us speakers will be showing some of the cutting edge innovations that we have done in the field of ophthalmology, and sit back and relax. Yeah, you can take them and show. Prithvi, can you help me with the Mac connecting? Yeah. So this is the 4-dimensional ophthalmic metaverse that we have innovated at our center here. So we just took inspiration from the Iron Man, Tony Stark, so which was once thought to be a science fiction. Can we really think of it as a science-based reality? And we innovated the 4D ophthalmic metaverse, which is a patent-protected technology of ours. And we have 6 innovations. I'll just quickly run you through as to how we actually did it. So it all started me being a glaucoma person, how we can convey simple concepts. As you can see, an iris process or a peripheral anterior synec. We make small animations, as you can see on your screen, and the iris process and the peripheral anterior synec. We started communicating these animations as a part of videos. So once we showed them an animation and then we took them into a real-time scenario, we felt the cognitive understanding of the patient was much better in match the following. And even if sometime a patient asks, why do we do a YAG PI? So we show them that this is a cause, and because of that the aqueous doesn't flow, and that is the effect. So the acute angle closure attack happens, and that's why we end up doing an YAG PI. So to make learning more interesting and learning more fun, there was something much more needed, as we needed to go transcend much further. So even can we really make glaucoma in a single minute? So you can see this is our own patient's fundus image. So we just marked with the tools of increased cupping that you can see here, followed by the increased cupping that is seen. The glaucomatous notch is brought in with simple 2D images, the bionetting sign, and bringing on more points thereafter, like the basic sciences. ISNT rule, is it breached? Yes, in this patient it is breached. And then you can see the RNFL defect here. The RNFL defect is very beautifully appreciated, following by the structural function correlation. You can see that the same patient, we can show the superior arcuate scotoma, followed by the OCT evaluation of the same patient where there is an inferior RNFL defect. So these are many videos you can see in my YouTube channel as well. We are trying to go with less is more, as simple ways of making complex things like internuclear ophthalmoplegia, abducens nerve palsy, and my friend Pranesh will be talking more on this teaching aspect as well. So even you can see here a difference between an ALT and an SLT, the spot size. These are things that not many neophytes get to do. But can we really sensitize them through means of animation? That is very much possible, and it's quite easy. So we make animations and show these kind of things so that we can really help them in understanding the process better. And in this animation you can see how argon laser peripheral iridoplasty, it is placed and it just pulls the peripheral iris away from the angle, especially for oppositional angles. Even some common scenarios like removing the lens, and you can see how the chamber deepens so great after removing the lens. A simple animation is what we all started up with. You can see once IOL is placed, the fate of the iris falls back. Even the ciliary body, you can see it falls back. So all these animations are made by us, and even the scleral spur, you can see it slightly falls back. And the peripheral anterior synechiae here, it also slightly falls back. So the more animations we started making, we felt unanimations is the way forward. Can we have something which is more real, like the cavernous sinus, which is all in 3 dimensions, which is very difficult to cognitively memorize because we don't have this dissectable. We don't get to dissect the circle of Willis. We don't get to dissect the eyeball model for that matter. So we went ahead and made an app called IMG 3D. If you have an Android phone today, you can get this app. And in this app, you can see what we have tried is, we have gave the user the freedom of choice. He can go in, choose the fundus or the anatomy or pathology, and once he clicks on to the anatomy or pathology, he can go and navigate into the eye in any way he wants to. So this is the second level in which we transcended, where we wanted to give the user the freedom of choice in the angle examination, fundus examination and whatnot. Similarly, not only in the normal fundus examination, even the pathologies along with autofluorescence, infrared, they were also added on so that it can serve as a multimodal atlas. You can see, to name a few, a normal, flecked retina, fibrovascular band, retinitis pigmentosa, can just keep adding on to this and this and this. Then we evolved into the windows, where if you want to have a bigger display and if your smartphone is not apt for it, you can go for the windows. And then came the real cutting edge innovation, the augmented reality innovation. As you can see that this is also brought into the smartphone, my dear friends. So Dr. Anugraha will be coming to you and demonstrating the HoloLens as we speak. And this is also available in your simple smartphone with LiDAR technology that the smartphones are coming up with. You can see that just with your smartphone, just like a pilot how he uses it as a simulator, you can navigate at any part into the eye. So the right hand side video is the phone video, what is synced in the left hand side video. So you can just move your phone in 3 dimensions and see the structures as they are in 3D. So this gives you a 3-dimensional orientation, and you can also have a simulative surgical training along with counseling and pedagogy. So we started making the structures of the circle of Willis in 3D in augmented reality model. So we were the first to do it, and not only that, we incorporated it into EMR as well as patient counseling. If we have an YAG-PA counseling or a SLT counseling, we show them what is their real angle, how does it look, and where we go ahead and place the spot. So this was a third innovation which led to another breaking innovation of the HoloLens or the hologram. So this was the first holograms with real-time ophthalmic images that was created, which my colleague Dr. Anugraha will be coming and showing it to you. Please feel free to wear the simulator that we have innovated to experience this particular model here. You can actually examine the eye as a whole with your touch sensation. You can go through it. You can see the different parts of the eyeball, the angle chambers here. Gonioscopy is one topic that I felt very difficult to understand. So can we really teach something like this? Yes. Patients counseling, yes. So you can see here, going into this gonioscopy, the side angle view, the cut section, everything can be beautifully demonstrated, even the fundus as well. So we started using all the imaging technologies, even the OCT filters for that matter, and we started incorporating it into surgeries as well. In surgeries, the usage is, we at beginning, we don't know whether we are doing an hydro dissection or a delineation for a posterior polar component. It may just fall in if you do a hydro dissection. But with this technology, your mentor will be able to exactly guide you in your simulation lab as to which plane you need to do the dissection or delineation. So that's possible with our simulator. So my daughter, you can see her also in this hall. So she is very fond of this technology. She uses it for her games. It's very difficult to take the HoloLens away from her. But coming back to ophthalmology, I feel in diagnostics also we are now currently working on it, where you can see on the right hand side the OCT images can be fed into the fundus, and the OCT can be extrapolated, and the multiple slices of the patient can be examined, which gives you a much better perspective. And this is a museum that we have in our center. So if you walk into my hospital and if you see me wearing this, you may think I'm insane, because what is he doing moving in thin air? But this is the frame that I'll be seeing into my eye. So we have created ophthalmic models and many more. So this is the workflow. A patient comes into the hospital, a fundus and a OCT examination is done. The OCT and the fundus are just integrated within 60 seconds, the software that we have innovated, and the holograms are ready for viewing. So this is an example of a patient before treatment, how the edema is looking in the macula with different slices, and you can see the same after treatment, how it looks. We can do the counseling. Even this can be used for corneal pathology. So this year we have started to expand ourselves into corneal pathologies, into cataract examination. So I'm just winding up in 30 seconds. Cataract examination and many more. The edema subsiding, the cataract examination. It has so many applications. So that's why we launched it in the phone as well. If you don't have a HoloLens, all you need is a simple phone and whatnot. And one more thing that we would want to highlight is the three-dimensional puzzles that we have innovated. So the circle of Willis, the cavernous sinus, and the eyeball models, just like an automobile engineer, why can't we have it in three-dimensional puzzles? So which Mr. Karthik will be circulating it to you. So the puzzles that we have innovated. So my dear friends, so this is a subtractive learning app, the sixth innovation of ours. This is also an augmented reality. You can delete structures that you don't want to see. That's the beauty about this technology. The structures that you don't want to see, you can just delete it. I'll also come to your place and demonstrate this to you. You can just remove structures. It's like a virtual dissection tool. It's something that has to be immersively felt and understood, that this is the next level of training, counseling, and even surgical angle as well. You can remove structures, go into the eyeball, do it, see it, simulate it. Everything is possible, and the metaverse is here. It is here to stay, and we have take privilege in saying that we are the first to do high volume work in this, and this is my team. I would like to acknowledge my team. And the main feature is we have used real images of the angle and the fundus. We have not used any extrapolated images. It's our own patient's images, and this augmented reality is going to be the future of ophthalmic pedagogy and counseling, or even EMR as well. So if you have missed the presentation, just take a screenshot of this. This is where you can get all the innovations and you can freely use it, and I am also available for you for answering any questions. So with this, I'll just end my presentation. So this is the latest technology, the MIGS simulator that we have worked on. You can see that my colleague here is moving his fingers, and it is coded in the metaverse. So this in SICS and FACO will revolutionize teaching, because it's very cost economical. You can see him just taking the simulator and taking it into the angle and injecting the G1 eye stent. So this three-dimensional coordination will take a long way forward in helping not only simulation, telemedicine, AI, and whatnot. So with that, I thank Team YOSI for giving me this opportunity to present on the 6 innovations of ours. And if there are any questions I can take, or we can move to the next speaker. Thank you. Prithvi Chandrakant, he is also another serial innovator. He has more than 10 innovations to his name, and he'll be talking about his innovative journey and throwing us more insights on innovations.
The outset, I would like to thank YOSI and Dr. Prasanna for giving this opportunity. I'll be talking about frugal ophthalmic imaging, and this is especially for YOSI, young ophthalmologist, especially peer postgraduate and fellows, when basically because we are not, it's not affordable for us to buy instruments which could image ophthalmic structures. So I've come up with few innovations which would help us do it yourself instruments. So the first thing I would like to talk about is anti-segment photography with intraocular lens, or ASPE. Over here, I'll show you a video. People can even take videos of this if you want. So over here, you can see as we take a chart paper, we cut it out, and as you can see, 10 to 1.5 centimeter chart paper is cut out. Be careful of the scalpel, and once you cut it out, we can fold it into half. This is basically for anti-segment photography, for corneal, iris, lens photography. And then we have to mark a round structure to make a hole so that we can keep the intraocular lens. So this is basically using an intraocular lens. We are making a phone to a macro photography device. This is a double-sided tape which we need to stick. And once you have stuck that, you can take a paper puncher and punch a small hole into the one end of the chart paper. So once that is done, you can see we can make a remove the other end of the double-sided tape and then put a intraocular lens. So anything between 15 to 20 would do the work for a anti-segment imaging device. So once this is done, you can stick this to the smartphone, and this will help you take images of the anti-segment. Also show you how it is done. So you can take a video mode on the flashlight and then go closer to the eye structure which you have to get photographed to. So this can be used with any phones with the side camera or the central camera. So this is how we use. Take it near to the eye to take photos of the anti-segment. So this is also published in the Indian Journal of Ophthalmology. So if you need to make it by yourself, it is already there. And one of our residents who have taken this innovation, and she has taken photos of these anti-segment pathologies, and we have published this too. So you can see how efficiently and how clear these images are. So this is not taken by any slit lamp, but just with an attachment of intraocular lens. These are all the images which were taken during her residency. And we have also been able to use this to get teleophthalmology consultation. And this is a recent publication where we have shared how teleophthalmological concept can be used with such frugal ophthalmic imaging systems. These are all the images taken by ASPE, and these are the images taken by Raster Treasure RedCam, which Dr. Shisha will cover on how to do it. The second innovation I would like to talk about is the cobalt blue filtering imaging device. This is also like the same anti-segment imaging ASPE. So this is these are the things which you'll require to make a Scooby-Doo. So it's called Scooby-Doo Smartphone Co-aided Cobalt Blue Photography with Intraocular Lens. So as you can see, the same procedure of how we have done the ASPE, but the folded edge is a little shorter. And these are all do-it-yourself, so anybody can actually do it in their house. Don't have to buy any of these things. Even the intraocular lens, you just have to get some expired lens which is already there, or something which has fallen down, which cannot be used for surgeries. So these are all the measurements. So one thing you need to know is the distance between the camera and this flashlight, because we'll be keeping the cobalt blue filter at the flashlight, so that the flashlight which comes will get through the cobalt blue, give you a blue filter. To make two holes, one for the intraocular lens, two for the magnification, and one more for the flashlight. So now this is done. You attach the intraocular lens and the flashlight. Over here too, you can use 15, 20 or 25 according to the magnification which you want. And 6 diopters and 8 diopters can be used for gonio imaging too. So now your cobalt blue imaging instrument is ready. So this is also exactly the same as ASPE. Just click on, attach it to your phone, and you can take images. So here's a picture of a series of picture of Seedles positive, and this is how we take the images. These are the other pathological images which we took from the Scooby-Doo. The third innovation I'll be presenting is IOL scope, and the fourth is SLIM. So basically what we have seen over here, exactly like how we have done ASPE, but over here we'll be connecting 4 different intraocular lenses of 30 diopters each. So 4 intraocular lens, 30 diopters are placed one upon the other using liquid adhesive like Fevicol. This will considerably increase the magnification of the images. So it gives a collective of 120 diopter magnification power, and with this you'll be able to take images of fungal hyphae, you can take images of parasites, etc. It's not so hard to actually make it. Just need a chart paper and intraocular lens. Again, 30 diopter lens can be easily found because most of them get expired also. Anything more than a 4 lens will actually give a very short working distance. So you can hold the the specimen of slide in below upon a torchlight or a phone flashlight or anything, and then your IOL scope is ready. So with this you can actually take images of fungal hyphae. Over here you can see the spore of Rhizopus, cage mound. You can see caterpillar hair. This is a parasite image. And here is a poster which we presented in All India to check the efficacy. And as you can see, these are the above images are from the actual microscope, and the one below is from IOL scope, which is very comparable. The next innovation I would like to show is the gimbal scope or smartphone retinoscopy. So over here what we do is we are using a smartphone to be attached to the retinoscope so that we can get images of the reflexes which was not previously seen, and you can do a live demonstration of reflexes of the retinoscope for teaching purposes. As you can see over here, these are all the images which we could see live with live demonstration on how to teach residents with the live retinoscopy reflexes. Thank you, and I would like Dr. Shishi to come and take over for the other 2 innovations. Thank you.
Good evening, everybody. My name is Dr. Shishir, and I'm practicing as a VR surgeon in Kerala. I would like to thank Yosi for this talk, and also Dr. Prasanna for inviting me. So my talk is just an expansion of Prithvi's work, but just that I helped him get approximately around 10 papers out of his innovations. So no financial interest. So now smartphone, there's a huge revolution, and that's probably going to be the future of imaging. I mean, not in your clinical setups, but definitely outreach and even, teleophthalmology. So I'll be talking about the smartphone-based gonio imaging. Now, 2 papers came out in 2020. One was by Dr. Nilesh, where he had imaged the gonio, the anterior chamber angle using just a plain smartphone, and one was a paper from AIMS where they imaged the angle using an iPhone 11, and they used it. So these are the two papers. So first one was where Dr. Nilesh, he made the patient lie down, put a gonio, and just image the angle directly using the smartphone. And there's a second paper where you required 2 observers to kind of get a slit image, but they used a higher grade smartphone with a macro lens to get the images of the angle. So Prithvi already talked about the ASPE, where he uses the intraocular lens to get the anterior segment images. And using the ASPE, we were able to image the anterior chamber angle as well. So it was a low cost device. So all we required was the ASPE, and we needed gonio lenses, either a slit lamp or a retinoscope if you wanted to obtain slit images. So here the IOL power required is different than what is actually required when you image the anterior chamber angle. You require a 6 diopter, 8 or a 10 diopter IOL power. Little difficult to get, but usually if they are there expired ones, you can use it from the OT. And gonio mirror, any of the gonio mirrors will work to image the angle, either a 2 mirror or a 4 mirror. Now even 6 mirrors are available. And you the methodology which we used was after routine slit lamp examination, just put a topical anesthesia, check the intraocular pressures first, and then use the gonio mirror, and then you image the angle using the ASPE. So we studied this in 33 patients, and we found that we can do it in any position. You can use this when the patient's head is on the slit lamp, you can use it in lying down, and you can even use it in a sitting position or in camps when you go for screening. So you require the video mode of the smartphone to be on when you are imaging the angle. And if you're using a 6 diopter lens, there's a reasonably comfortable distance where you hold the smartphone between the in front of the gonio mirror. But you're using a 10 diopter lens, then you need to be a little more closer. So the ideal would be to use a 6 diopter lens if available to image the angle very clearly. So using any of these mirrors you can image, but it's slightly more clearer when you have a contact lens based mirror like a 2 mirror, where you are there's a coupling agent, and then you get a slightly more better image when you use a contact gonio mirror. So these are some of the images obtained of the normal anterior chamber angle. This is one with post trabeculectomy, and then when you can zoom in, and then you can see the ostium there. And this is another image of a silicone oil emulsified oil in the anterior chamber of the angle. You can also obtain slit images, but for slit images you require one more observer. So if you need one person to take the image, the photo from or a video from the smartphone, and one person requires to hold a retinoscope and form a slit, and then using that also you can take images. If you don't want, if you don't have one more person to help you, you can place the patient's head on the slit lamp and take the same image. So the advantages of our technique was that it's good resolution. Any gonio mirror could be used. It's quick, inexpensive, and it's a good screening tool, especially in peripheral centers, and also excellent for resident education and training. And as Dr. Prasanna mentioned, that angle is quite difficult to understand. You can take images of the angle and then teach residents too. So few limitations, especially those who are trying out in the beginning, there's a small learning curve. IOL powers of more than 10 diopters cannot be used, and some phones in which the camera is central, you cannot maneuver the smartphone too much, otherwise you won't get a very clear image. So next imaging modality is a trash to treasure red cam. So there are a lot of devices available for fundus imaging. In clinics you have the mid-Adriatic and the non-mid-Adriatic fundus cameras, you have handheld ones, and then you have multiple smartphone based cameras. So it was from 2010 the smartphone based imaging was initially invented, and then it's gone a long way from there. So the principle is the same as when you do an indirect ophthalmoscopy, but instead of your eye, it's a smartphone which takes the image. So I've asked a lot of my retina colleagues to give me these images and what they do in the screening centers. A lot of them do this technique. They hold a smartphone and then they use a 20D lens to get images like these, but then there's quite a bit of movement, and you do get some images, but then it's not very practical most of the time. So red cams have been developed. So the first one was by Dr. Biju Raju, do it yourself red cam. Then the Me red cam by Dr. Ashish, and then we had the Jay's red cam by Dr. Jayatra. So all the two of them where you had to attach it to the slit lamp. So also different companies developed their own smartphone based red cams. We had the Welch Allen red cam that gives you 25-degree field of view. Then there's one by DI that gives you around 200 degrees view, and then there's Peak Retina, which gives the field somewhere in between these two. So, and then also Vogue developed their own type of like a smartphone based red cam, which they have discontinued now, which uses a iPhone SE, and using that you can also take pretty decent images of the fundus. Dr. John Davis, he has developed one from a 3D printing. He's developed one John Das pocket foldable fundoscope. So where you can, it's a pocket-based red cam. You can open it up and unfold it, and then put your 20D lens and get a good, decent images. So it's a low-cost, ultra-portable smartphone fundus camera. Patent pending, no, Prithvi? Patented, John's going to, okay. Yeah. So Prithvi has developed this T3R red cam, which is simple, affordable, portable, and wireless, and again, do it yourself. So this is the video. You need an old, used sanitizer bottle, which you can, make this incision using the blade and then cut out this portion to fit the 20D lens. Yeah, so you can place the 20D lens at the end there. And you can attach this smartphone adapter. So this is a universal smartphone adapter. It's available on Amazon for $480 bucks. And then you can attach the smartphone there, and now it's ready for imaging. You can probably insert a chart paper to avoid reflections. Yeah, and it's ready. So this is the adapter. It's available on Amazon. You can use it for this T3 red cam. And again, the same principle as your indirect. Instead of your eye, it's a smartphone which is getting the image. So you need to, the video mode needs to be on. Patient needs to be in a dark room, either supine or sitting, and then you can get a pretty decent image with this one. So you can also get peripheral images when you ask the patient to move the eyes up or down. So to increase the clarity of the image, you have multiple apps available on your phone, and you can use this in your screening when you're going for DR screening or in peripheral centers. Also, you can use it for getting ROP screening, during ROP screening, to get good images. So these are the few of the images which has been obtained using the do-it-yourself T3 red cam. And again, a small learning curve is there, and the smartphone flash should be coaxial with the camera to get a good image without any reflections. So the magnification depends on the lens used, and the maximum you can get is around 56 degrees. So this has been studied in multiple, in the peripheral centers using this thing, and then it reduces the time travel and cost and also loss of income. So you can just go directly and do screening by using the T3R red cam. So these are again few of the images which have obtained. So yeah, so multiple applications of the red cam for diabetic retinopathy, for ROP, for glaucoma, for even for pediatrics, teaching, even in emergency medicine. For it's very good and it's very extremely portable and can be used in telemedicine, teaching, and even for bedridden patients to screen for the fundus. So minor disadvantages: small learning curve, and there can be some amount of glare, especially if your lens is not great, and sometimes you need to have different adjustments and you're using different smartphones. So smartphone flashlight there was an issue before with that, but now they're saying that due to the latest models, they give a very high brightness, which needs to be studied further. So ASPI Gonio is a cost-effective tool for screening, imaging, and documentation. You can grade and image the anterior chamber angle. For fundus imaging, there are multiple devices and options available, but the T3R is frugal and easy do-it-yourself device, and the risk of photobiological damage by flashlight is less if the exposure is less than 1 minute. So these are the multiple studies we took out using our literature on smartphones. Yeah, thank you.
I first thanks Dr. Prasanna for giving this opportunity. Now I'm going to talk about measuring, how to measure the corneal diameter in infants without using a routine gastrovisual caliper.
A novel method for measuring corneal diameter in infants screened for congenital glaucoma. As is known, corneal enlargement is a common feature of congenital glaucoma. It is an important indicator for both diagnosis and monitoring the progression of the disease. Castrovici caliper is being routinely used for measuring the corneal diameter, but it needs examination under anesthesia or sedation. We devised a simple U-shaped tool using 3 shimmer strips or a printable ruler to measure corneal diameter in settings where an ophthalmic caliper is not available or UA is not feasible. Infants presenting to the congenital glaucoma clinic posted for EUA were recruited. Before EUA, corneal diameters were measured using U-tool. During EUA, corneal diameters were measured using Castrovici caliper. Corneal diameters obtained from both the techniques were compared. For measurement in a cooperative child, U-tool was placed just above the orbital rim. If not cooperative, when the child was asleep, the eyelids were gently retracted by the attendant and U-tool was placed. Photo was taken with the smartphone. Care must be taken to keep the U-tool and the smartphone parallel to each other so that parallax error doesn't occur. After taking photo, the image was edited in the image editing software. A rectangular frame was drawn along the limbus extending till the U-tool and the first reading was calculated. This image shows corneal diameter measured in various children in awake or sleeping state. As we do not place the U-tool directly on the corneal limbus to measure the corneal diameter, a correction factor must be applied for the magnification caused due to the distance. The distance from the corneal limbus to U-tool was measured using a ruler in all the eyes and was approximately 16 mm. The correction factor at 16 mm distance was deduced to be approximately 1.15 mm. The corneal diameter was calculated by multiplying the first reading with the correction factor. The mean age of the participants was 6.7 months. 66% of the eyes had primary congenital glaucoma, 22% of the eyes had anterior segment dysgenesis, 8% of the eyes had post-cataract surgery glaucoma, and 4% of the eyes were normal. Figure A shows that the corneal diameters measured using the Castrovici caliper and U-tool are almost similar. Figure B shows that if we don't apply the correction factor, the uncorrected U-tool reading was approximately 1.5 mm lesser compared to that of Castrovici caliper reading. The difference between the corneal diameters measured using the Castrovici caliper and U-tool was 0.11 mm with a narrow bland Altman plot 95% limit of agreements. Corneal diameter measured with both instruments had a good correlation with a Pearson correlation coefficient of 0.95. Measurement error could occur if the U-tool or a phone is not placed parallel to the eye while taking photographs. Sedatives or anesthesia might be required in a non-cooperative child. Stretched limbus in congenital glaucoma could also cause variation in measurement of corneal diameter by different observers. To conclude, this novel innovation provides a no-touch technique of measuring corneal diameter. Considering a difference of 0.5 mm within the acceptable range, 72% of the readings taken with the U-tool were in the acceptable range. It provides corneal diameter measurement in awake or sleeping state without the use of sedatives or anesthesia in majority of the cases. Hence, it can be used for screening pediatric glaucoma by first contact physicians, optometrists, or even by the ophthalmologist when the UA is delayed. Thank you.
Thank you. I would like to acknowledge my friend Dr. Rahul Kumar Bafna, who was the backbone of this innovation. Okay, thank you. Any questions? No. Thank you.
So hello everyone. Thanks to YOSI for this opportunity, and this talk is a bit of an outlier from the previous talks. You have seen cutting edge innovations, and this is more of a story of my teaching experience. Whether this is the innovation or not is up to your personal discretion. This story, okay, kind of outlines to these titles: the need, the solution, the ripple, and the message. So what was the need for this product called King's Crux, and how it came about, and what was the after effects, and finally the message. So the year was in 2016 when I joined Oftal. How many of you joined Oftal because you liked Oftal? Great, great. I joined Oftal because there was no other options. There was psychiatry next to it. I thought Oftal is much better than psychiatry. So I wanted a reason to like Oftal. It's like arranged marriage, no? You have to force yourself to love your wife. Not a love marriage, obviously. So I had to really try to find ways. And one thing was, I like to teach. That was my passion. Like Prashant sir was mentioning about the importance of passion. The passion to teach, I had to put it into my profession, that is ophthalmology. So thereby taught Oftal, thereby I started like Oftal. So the idea was to combine the social media and online education. Back in 16, we didn't have much of online resources as we have now. Now we have a plethora of resources. So using these tools, which almost all of us have, a laptop, I used an iPad, you can use a graphic tablet, an Apple Pencil, you can use any annotating tool, any digital writing tool to create lectures which were visually engaging, vividly narrated, and real-time annotated. That was my goal. That particular lecture should have the versatility of a whiteboard, also should have the interactivity of modern presentation tools. And thus born this YouTube channel which goes by the name King's Crux. I know it's a kind of a weird name. Many won't even pronounce it in the right way. But anyway, this is the name which I had right from my school days. So I had to christen this YouTube channel with this name. But what's the difference? We have so many YouTube channels, so many Oftal content. But what I feel kind of gives a different shade, a unique shade, is because I have a background in public speaking or oratory. So my aim was to incorporate the principles of public speaking into this ophthalmic teaching. So rather than focusing on the content, my focus on how do I deliver this to the audience, the technique. By curating that content to the audience or addressing who my real audience is with a deep rooted philosophy and principles on public speaking and medical education. How that came about? Through metaphors. Now what is this? What I'm trying to explain. Now this captivates attention of the audience. Hand-drawn depictions of complex concepts. Now these have been the USP of this product, which is in clear contrast to the animations. This is quite old school, but this is what we need to deliver the message to the audience in the best way possible. So this was the product called King's Crux. And what was the ripple? What were the after effects of this particular product? What started as illustrations for my videos became flashcards. And these flashcards later became short notes. And these notes then transformed into manuals and books. So from a single drawing, it has diversified into a textbook. Then the crux went global. This was my first voluntary, non-profitable collaboration with JP's DigiNerve, and over 1,000 postgraduates in our country have subscribed to this application. And the most fulfilling work of this King's Crux is this Ophthalmology Foundation Education Consortium, which is focused on capacity building, on building the next generation of ophthalmic teachers, where I'm leading these modules. One module which I'm working on is educating patients effectively. Now that is an underrated area. That's when I shifted my focus from educating postgraduates to how can we effectively teach patients. The same principles of teaching which I created, handwritten guides for my patients, into short, easy to understand textbooks. And these were displayed in my waiting cubicle. But how will you educate when you are not confident in the language your patients speak? We have many non-native trainees, fellows who come to Tamil Nadu. We have many institutes in Tamil Nadu. And they have to master this tough language called Tamil, and unfortunately not many speak Hindi in Tamil Nadu. So because of these geopolitical divisions, how can I help out those non-native trainees? And thus born Essential Ophthalmic Tamil, which has 3 components: video lectures. These video lectures are uploaded on YouTube. The second is a companion handbook, which is tabulated dictionary type of phrases and the relevant translations. And finally, a high-yielding audio podcast. Please repeat after what I'm saying in the exactly same way. I'm not sure they're able to hear it. But so what's the message? Any answers? What's the message? The message is this is not an innovation, but it is more of a product of passion. A burning passion to teach. And that will be the message, to find this purpose of life, or what you call as Ikigai. How many of you have heard of Ikigai? Great. This Ikigai is the intersection of what you love, what you are good at, what the world needs, and what you can be paid for. And that Ikigai and that purpose of life, my purpose is to teach. That's what I've defined my life purpose as. And that purpose has landed me now at Moorfields as a clinical teaching fellow, where I'll be teaching more scientifically to pursue my passion further. And it is what we love keeps us moving, keeps us kind of travel along, keeps us breathing, right? And when that breathing stops with the last gasp of air, we wish we are pursuing that passion, my passion to teach, when that breathing stops. Thank you so much. Let's all teach to reach.
Thank you, Pranesh. To say that it's not an innovation, because for people following Pranesh's work, he has done extensive videos on YouTube. I would recommend you all to see the videos of Pranesh Balasubramaniam. Every video speaks for itself, and he has also composed a regional handbook in Tamil for a regional language as to how you need to go forward diagnosing patients, or even as a handbook. So once again, we have come to the end of the session. So I would request our panel, Dr. Shilpi ma'am, to share a few comments on the 5 innovations that you have seen.
Yeah.
So I think it's rightly said that need is the mother of innovations. And in this session, we have seen the excellent innovations, not only from 2D to 3D, but the excellent which I like the most is by Dr. Prasanna, that is the 4D innovation, which we can't even think of. And you know, by these photographies or the innovations what we are talking about, we all know if you have a will, you can do it. We all are not so much wealthy that we can buy expensive instruments to teach our students, our fellows, or our patients. And we all know that if patients see what we are telling, it's more easy for us to convert them. So just the simple use of IOL, just which is easily available in everyone's OT, we can just, I don't think it will cost anything too much for all of us. We can just show what is there in their eye, what is going on from anterior segment to the posterior segment, and this helps in creating our patients' trust better on us.
Thank you, ma'am. As you rightly pointed out, all the 5 innovations that you just saw were all cost-effective ones.
Yes.
So when we started the 4-dimensional holograms with the headset, then this year was the year when we cracked it in the smartphone, because not every one of us can have the luxury to have the headset or go to the Help Me See lab. No financial disclosure, but can we have the simulator in a smartphone? Same thing applies to Dr. Prithvi Chandrakant, who novelized this idea of using an IOL. So to just bring up this innovation. Same thing to Karthik Mahalingam as well, when he used the simple cost-effective U tool to diagnose or to evaluate the patient under anesthesia. So everything that we saw, even the trash to treasure red cam. So I think after the session also you can connect with us, and we are always there. And Pranesh's innovations are all open access. In YouTube he has more than 2,800 subscribers, and he says he's not an innovator. I don't agree with him, but
23,000.
23,000. Yeah, 23 plus is still a great number, 23K. And all his videos are like 1 million views. You have to see his channel. I strongly recommend all the people attending to see his channel too. So with that, I think without any want of time, shall we? Yeah, we can close the session. Before that, we'd like to invite Prashant sir to please come and honor the speakers and the panel. Ma'am, first. Prashant sir, first we'd like to call upon our panel, Dr. Shilpi ma'am, please ma'am. Yeah. Thank you sir for patiently listening to all the 5 innovations and also sharing your inputs with us. It really motivated us a lot. And thank you ma'am for being a panel for the session. Next, do we have Nilesh here? No. Okay, we'll move to the Dr. Prithvi Chandrakant for his frugal imaging with the IOL scope, the Scooby-Doo. You have to see all his 10 innovations. It's also labeled very differently. He has one on slim, 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 Scooby-Doo, and recently he had some Magnifix. I don't know how he comes up with all these names, but he is all beautiful innovations of his. Next, I would like to call upon Karthik Mahalingam. So Karthik Mahalingam, he's from RP Center. He's a senior resident there. And sorry, sorry for that, Karthik. Yeah, true. So he created a tool, and not only that, he validated his tool, the U tool. So thank you, Karthik. Next, I'd like to call upon Shishir Varghese sir from. He was an alumni of Coimbatore Arvind, and he's now having his own center. So he talked on trash to treasure red cam. So I would also strongly recommend the attendees to see that how he has used it's like treasure, trash to treasure, and also the ASPI, the anterior segment photograph with IOL scope. Then I would like to call upon Pranesh Balasubramaniam, the innovation in teaching, the humble teacher who says he's not innovating, but he's a serial innovator. Yes, sir. Sir, his channel statistics are amazing. I think again, I have told it once again, but I would recommend every one of you to have it.
Yeah. So now the last one, sir, please stay back. Dr. Prasanna. I think, yes, the man with the... This is the result of the innovations.
Yeah, we would like to hand over the next session, Surfing the Anterior Segment, by Dr. Aarti Hida. Over to you, Aarti. We'll just have a quick group photo before you get it ready.
Yeah. Okay, Prasanna. I can't tell you no.
Thank
So
you.
may I please request everyone from the previous session to be on the dais for a group photo as requested by Prasanna. Quickly, please. क्या प्राइस हम देखते हैं जो भी तक रहेगा जब भी रहेगा. So good evening everyone. I am very happy to see that the hall is houseful and there are no places, no chair to sit. So I'm really glad and very excited for this session. So surfing the anterior segment is actually a brainchild of one of my very good friend, Dr. Indivar Mishra. And we started this series in May 2020 during the COVID times. And I'm glad to say that we have done 24 sessions online and we have been doing sessions in Yo Pavilion as well. So continuing the same trend, we are here for another interesting session of surfing the anterior segment, and it's not just the ocular surface. So we have been associated with quite a few enthusiastic people. To name a few, Dr. Aditi, Dr. Karan, Dr. Nikunj, Dr. Nilesh, Dr. Rutuja, Dr. Nandini for this session. So the format of the session is going to be, we'll have 4 interesting case presentations and the cases will be judged, and amongst the 4 cases, the best case will win. So I'll just introduce you all to the expert panel and the judges for the session. We have with us Dr. Puneet Jain, a very good friend of mine, who is consultant in charge of ophthalmic plastic surgery and ocular oncology at IQ Super Speciality Eye Hospital. So Dr. Puneet, may I please request you to come and sit on the dais? Then we have with us Dr. Anu. She's Assistant Professor Glaucoma and Squint Services at Guru Nanak Eye Center, Maulana Azad Medical College, New Delhi. So we request Dr. Anu to please judge this session. Then we have with us Dr. Mainak. He is consultant at IQ Super Speciality Hospital and Max Healthcare. He is running a little late and I hope he run to the session very fast. Then we have with us Dr. Nikunj, who is a cornea, cataract and refractive consultant at SRJ Netralaya and Super Speciality Eye Hospital in Indore. And Nikunj has been with us for all the 24 sessions. So we welcome Nikunj. Then we have Dr. Shivani. She's glaucoma and cataract consultant at SRG Netralaya and Super Speciality Eye Hospital in Indore. So Dr. Shivani, we welcome you to the session. And Aditi is going to take this forward.
Thank you, Aarti. So now we invite our speakers. First, we'll just give a short intro about them. So our first speaker is Dr. Kartikeya M, who's working as an assistant professor of ophthalmology at RP Center, AIMS. And he has multiple research papers and publication and citation. We welcome you, Dr. Kartikeya. Our second presenter will be Dr. Anujit Pal, who's presently working as a VR fellow at BBI Foundation at Kolkata, has received multiple awards and has many publications. Our third participant is Dr. Sonali Mehta, who is currently doing her cornea fellowship in Shroff Charity, New Delhi. And we have Dr. Shrey Raj Singh, who is a second-year resident at Eye Care Eye Hospital. So we welcome you all. And the moderators of the session will be Dr. Aarti Heda and me. So now we'll start. We'll start by inviting Dr. Kartikeya. So this is a competitive session and we will be announcing the result tomorrow.
So each presented 5 minutes of the time to present the interesting case and followed by the discussion by the judges.
Can you start the screen, please? Okay. Okay, I'm going to talk about an interesting case of hyperproliferative embryotoxin simulating a double cornea. A 12-year-old girl presented with complaints of whitish discoloration of both eyes since birth. There was no other complaints. She was a full-term normal vaginal delivery, and there was no history of redness, pain, discharge, or any eczematous fever in the perinatal period. There was no history of trauma to eyes, intraocular surgery, or using glasses, and there was no other systemic illness. There was no family history. And best corrected visual acuity was 6/18 parts in right eye, in left eye it was 6/24. Patient had telecanthus, broad and flat nasal bridge. There was a right divergent squint of 60 prism diopters. The patient had microcornea in both eyes, and there was peripheral corneal haziness in both eyes with infranasal clear eye line in right eye and central clear eye line in left eye. There were multiple spheroidal degeneration and hydrocorneal adhesions. On slit lamp, you can see a retrocorneal avascular glassy membrane which was obscuring the iris. Then we did gonioscopy. Angle structures were not visible. On ASOCT, what we can say is this membrane appeared like a double cornea, and it showed a double anterior chamber appearance. It was a small slit-like pupil, and there was iridocorneal adhesions. ASOCT of left eye showed a large central opening mimicking a double pupil in left eye. Fundus examination in right eye was not possible due to media haze. Left eye was it was anechoic, and left eye revealed the cup disc ratio of 0.4:1. Intraocular pressure was 30 mm of mercury in both eyes. Axial length was 22.3 mm in right eye and 21.9 mm in left eye. Specular microscopy showed reduced endothelial cell count and pleomorphism. There was no other systemic abnormalities like maxillary hyperplasia, microdontia, or congenital heart defects. Patient was managed medically. IP was controlled with 3 topical medication. Patient was given refractive glasses. In consultation with a cornea specialist, no intervention was done for the retrocorneal membrane because of low endothelial count and reasonably good vision. Coming on this kind of picture, for a congenital corneal opacity, we had a differential diagnosis of a Peters anomaly. It was ruled out because it usually has a central corneal opacity. Next is a congenital hereditary endothelial dystrophy was ruled out because it will have a diffuse corneal clouding. Other thing is epithelial downgrowth was ruled out because there was no history of surgery, and operated penetrating keratoplasty also was ruled out because there was no history of surgery. Another thing is persistent pupillary membrane. These are fine iris strands which cross across the pupil. Other differential diagnosis was partial sclerocornea. It will be continuous. There will be no nimbus seen. So we finally diagnosed it as a case of probably an axial field anomaly with hyperproliferative posterior embryotoxin. Because of pathognomic features like posterior embryotoxin, multiple iridocorneal adhesions, and erased intraocular pressure. Other features were telecanthus, broad and flat nasal bridge. The patient could not afford genetic testing, hence the same was not done to look out for genes like PTX2 or FOXC1. See, typically you can see this is a case of typical ARS with posterior embryotoxin and iridocorneal adhesion. But in our patient, see, this posterior embryotoxin was hyperproliferative. It simulated like a double cornea appearance. Embryologically, posterior embryotoxin is one of the mesenchymal dysgenesis of the anterior ocular segment caused by abnormal migration of neuropus cells. In our patient, we hypothesized that the posterior embryotoxin has hyperproliferated to form a retrocorneal membrane mimicking double cornea in right eye and double pupil in left eye. To our knowledge, this is the first case report describing a fairly symmetrical hyperprotective posterior emitted toxin, mimicking double cornea as well as double pupil in axon-filled anomaly. Thank you.
Thank you so much. Excellent case presentation. Now over to the panel for the question answer round. May I now request Anujit, meanwhile he can set up.
So a very interesting case, doctor. Histopathologically, basically posterior embryotoxon is made up of collagen, descemet membrane and endothelium. So probably in such cases it is the abnormal endothelial membrane which grows, and here it has grown like from one end to the other, giving us that look. Such cases we rarely come across in our clinical practice, very beautifully captured on ASOCT. For the sake of our young ophthalmologists here, just some basics we can withdraw from here. In such cases, in scarred corneas, opaque corneas, using a tonometer is, or using a tonopen is the most accurate way to check the intraocular pressure. Secondly, Dr. Karthikeyan, may I just know this girl was on 3 anti-glaucoma medications, so which all were they?
She was in brimonidine, timolol and brimonidine.
So just to mention here that brimonidine in children, it can cause CNS depression, lethargy. It is best to be avoided under 15 years of age. However, above 8 years, if we are giving this drug to a child, we have to be cautious. We have to inform the parents or the guardians that they have to take care that after instilling brimonidine, if the child is becoming lethargic or drowsy or sleeps off, then this has to be withheld. Secondly, when we prescribe such brimonidine to children, just in case if we have to, it's always good to advise them to put pressure here so that, less of the drug goes into the nasal mucosa.
According to literature, they said brimonidine is contraindicated in children because of dead brain is not adequately formed in less than 2 years. In 2 to 8 years, after 8 years we can give them. There is no contraindication.
We can give.
There is no contraindication. This was a 12-year.
Cautious. Yeah. And just in case if this patient comes up with refractory glaucoma in future, so how will we be going about it?
If it comes with refractory glaucoma and it is little complicated, we can try for trabeculectomy has very less success rate. We can do glaucoma drainage ways also. We can try a micropulse DLCP or a limited DLCP. So as soon as if we go invasive procedure, you know what happens in such eyes. This in these eyes are high risk for going into choroidal detachment, supracorneal hemorrhage and all. So we'll try to keep it in a less invasive procedure only.
And in such cases, as you mentioned, trabeculectomy, it fails very fast because this membrane can easily grow over your ostium and just fail the trap. Yeah.
So, continuing with Dr. Shivani's discussion, I wanted to know your pressure measurement was with which instrument? You mentioned 18 and...
I did with applanation only, ma'am. There was a central clear in that we did with applanation.
So, you had good Myers on the cornea?
Yeah, ma'am.
All right. Secondly, like she was discussing about the membranes growing over the angle, most of these angle structures are dysgenetic and they do not respond so well to medical therapy. You mentioned pressures of 30 coming down to 16, 14 with 3 AGMs. So would you expect such a response with say a prostaglandin analog or something working on the angle rather than the production?
Usually in this angle dysgenesis, medical management doesn't work properly, but in our case it worked, so we just continued.
I would have expected a good response from aqueous suppressant instead of
like what ma'am?
You've given timolol.
We gave brimonidine, timolol and brimonidine we gave. First initially brimonidine, timolol we gave. It was around 20. Again we added brimonidine.
I'm a little surprised with such a good control with medication because these kind of glaucomas are
so we tried to avoid carbonic anhydrase inhibitors. Already corneal endothelium was spectral count was not good. So we didn't have any other option. Pilocarpine we can give already. It is not advisable in such case.
Thank you.
Thank you so much. Thank you a lot.
Thank you.
Dr. Anuji.
Very good afternoon to this esteemed panel, and I thank Yosi once again for this opportunity to allow me to participate in the Surfing the Anterior segment competition. At the very outset, I would like to say that I'm very proud and not so proud of this surgical video because it is the first case of posterior capsular rupture that I've managed on my own, but it's not the best management that I would definitely want to highlight right in the beginning. Something is right, something has gone majorly wrong, and I pause and worry what to do next, what to do next. At this point of time, I call my mentor and my VR surgeon inside. He's looking at me and I'm looking at him, and he's seen and he's helped me out with a lot of cases. But in this time, he tells me something which boosts my confidence to no extent. He tells me that go ahead with the case. We'll see what happens. Either case, either the nucleus will fall into the vitreous or you will take it out. Both ways, I will come in, I will handle it. I'm behind you. Just go ahead. So with that confidence,
Thank you so much, Dr. Anujit. Over to the judges for discussion.
That was excellent, Dr. Nujit, and I am really happy, and I congratulate you for managing this case and as well as putting it up bravely for discussion here, because nobody wants to show their mistakes. I mean, I'm personally, I believe that mistakes are the best teachers you can have apart from your mentors, right? So, first question I would want to ask you is that. Would you want to manage it any way differently according to you, that you felt that it was not managed according to your expectation, and how would you approach this case differently and than what you have already approached?
Yes, of course. So thank you so much for your question. Well, now looking back at it retrospectively, I would have. Yes, yes.
Guys, all of you have not taken your faculty certificates or delegate certificates. So for that, you need to take it from outside. The session is going on. You can take it tomorrow also. That's not an issue. It will be printed then and there itself. You'll get your certificates. Okay. One more thing. There's a slight change in the plan of the Unite. Okay. So we are going more disco. We want to party harder. So the plan is over here. We're going to have stand-up comedy, followed by the games that we are having. Then there's the dinner here. And following which we are heading to a club to party. Okay, so the club is about 2 or 3 minutes walk away from here. It's Imperfecto Shore. I have booked it for all of us, and I guess we'll party there. Can I have a big round of okay for this? Yeah. Okay. Woo. Fine. Perfect. Thank you. Please continue. Sorry, Anujit, for interrupting you.
I think people might not be interested in the session now, Karan. But thank you so much for making all the arrangements for us. And we go back to PCR.
Yes. Anujit,
Thank you so much, sir. Yes, definitely on retrospect, I might have wanted to convert it because I don't want to put any traction on the vitreous.
Right.
And at the same time, going in with the IA probe at that point of time wasn't the smartest decision. A lot of things could have gotten wrong. It would have been better to go with the vitrector in IA cut mode and go with it much slowly. And I think these are the two main things which I would have done differently next time.
So starting from the first thing, that when you notice the PCR, right, and you took a pause, it was perfectly needed. At least it is important that you identified your PCR. That is the first step. When you're managing a complication, first you need to identify that is a complication. And realizing that a PCR has already happened, especially during FECO, it is also very difficult even for experienced surgeons. So after that, because you had a VR backup and that boosted your confidence and you dared to go again with the FECO and finish the case off, right? But important thing is to if you are going in with FECO again, and if you see a large PCR, which I think I'm not sure how big it was not clearly visible here. So you are doing still in the back FECO in that case, right? It is little risky, because whenever you are, even though your parameters are slowed down, you are using vacuum, you're using FECO power, so you will not understand or you will not realize when the vitreous is coming and it is getting caught into the FECO probe after the nuclear piece get absorbed, right? So important thing is, because you already had only half of the nucleus was remaining or even less than half, then you can just collapse it out, either using a visco or using a small dialer like instrument and bring it up. And you can even do then FECO in the anterior chamber above the iris plane also. Sometimes there is also recommended that if you have there is IOL scaffold technique also, but that will not work here because the cortex was significantly there, yes, and it is difficult to remove cortex once you have put your IOL into the surface. So at least you can bring the remaining nuclear piece into the anterior chamber and do a very small FECO, or you can, obviously you said that you would have converted into an SICS. If you have a proficient SICS surgeon, it is not at all a bad decision, right? And apart from that, when you are doing irrigation aspiration using your bimanual instruments from the FECO, and you were removing your irrigation source from the anterior chamber without injecting OVD, I mean, that is a very dangerous thing to do, because that will definitely cause chamber to collapse and the vitreous to come up. And you will not notice that after that, if you are while finishing further irrigation aspiration, you can catch vitreous and pull the vitreous base, and it can cause future retinal detachment and all those things. And so that is very important to not let the anterior chamber collapse. This is the most important tip here. And you could have used a tricoat just to stain the anterior chamber, or at least look for the vitreous even after you have done a thorough vitrectomy. it is important to stain it once. I mean, there is nothing wrong with it.
Nujit, any other way, like if you're proceeding with irrigation aspiration, you said you could have gone in for a IA cut mode, but if you're doing an IA, any way to prevent vitreous hydration directly? Can you adjust your irrigation and aspiration cannulas or anything of that sort?
So I could go for a dry IA instead.
You could have gone in for a dry aspiration using a Simcoe cannula.
Yes.
Or you can, use your irrigation probe directly towards the iris or the angle rather than directed centripetally.
Right.
So that could happen.
Yes, ma'am.
I also wanted to ask, which IOL did you put in this case?
I put a rigid PMMA lens.
That was a PMMA
an upper lens.
But you did not extend the incision.
I did. I think it was a little bit fast forwarded. I did extend insertion and then put it in.
All right. So that is important. Either you use a non-foldable or a 3-piece.
Yes.
All right. Very well managed case. And
Thank you so much, ma'am. Thank you so much.
So Nikunj, I have a question for you. So as anterior segment, we definitely don't like seeing vitreous. But yes, we do come across the situation like we have to deal with vitreous. So what's your take on use of triamcinolone to do the vitrectomy?
That's a very important, very good question, as well as very important point to be aware about for all the anterior segment surgeons, because every cataract surgeon will face PCR any point of the time, right? So to look for the presence of vitreous in the anterior chamber, triamcinolone helps amazingly. Even after you have put an intraocular lens and you have done a vitrectomy, you feel that you have completed the vitrectomy, but there could be a single strand coming even from the side of the IOL optic, and it can be caught in your side port. And we have seen so many cases where the vitreous is lying in the anterior chamber, especially towards the inner lip of the incision. So triamcinolone staining is actually a must, I would say, because I'm in a huge favor of it. Apart from that, there are other ways to judge about the vitreous presence or not. Like if you can constrict your pupil and look at the pupillary border. If there is a vitreous strand coming out, then will be a nick in that area. The pupillary border will not be a circular area. Or you can use a iris repositor and move it around in the anterior chamber. You will see the movement of vitreous, and it will also cause movement of iris as well as other tissue if you when you move the iris repositor in the anterior chamber, and that will also help you to determine the presence or absence of vitreous in the anterior chamber. So for learning surgeons, it is a must that you will always put tricot, especially in a case of PCR, even after putting an IOL, and check for vitreous presence before closing the case.
So I really wanted you to highlight that point. Thank you so much for summarizing it so well. Okay. So Dr. Anujit, did you counsel your patient after the surgery, or how did you manage the patient's post-op that you to change the IOL plan, what you were supposed to put? So how did you manage the patient post-operatively?
Thank you, ma'am, for your question. So the first thing is to be very clear with your patient. So the first thing I did was go and tell him that the surgery went well, but there was a problem. So we had to put a different sort of lens, and you might have a bit of inflammation at the end. But please don't worry about it. We are here to manage it for you. I started steroids 10 times a day, along with hypersol and timolol, and called him the next day to assess his IOP. And basically I kept him on follow-up for a week intensively, after which he stabilized. He had a post-op BCVA of 618, and we are still following up till this
So
date.
that's very important that you take the patient in confidence that yes, this has happened, but we were able to manage it. Okay. So thank you so much, Dr. Anujit.
Thank you, ma'am.
Next, I invite Dr. Sonali Mehta for her presentation.
Good evening, everyone. Today I'll be presenting a case of a 32-year-old male who presented to us. The slides are not.
So slides are not moving. Can somebody please help?
Now they are. Okay. So I'll be presenting a case of a 32-year-old male who presented to us for the first time in 2019 at Dr. Shroff's Charity Eye Hospital. When the patient presented to us, he had a best corrected visual acuity of counting fingers in the right eye and 20 by 120 in the left eye. I'll take you to his journey from the beginning, when he first presented at the age of 9 years in June 1999 at LVPEI, where he was diagnosed with chronic vernal keratoconjunctivitis with giant papillae and limbal stem cell deficiency. The patient was managed on topical and systemic steroids along with topical immunosuppressants by Dr. Sangwan at LVPEI. In December 2002, looking at this clinical picture where we can see dense scarring in both the eyes along with vascularization, the patient was planned for bilateral allogenic cultivated limbal epithelial transplant where the donors were the parents. The sample was retrieved from the parents and was cultured in the stem cell lab and later on transplanted to the patient. The patient was doing very well after the transplant. Alas, in 1 year, the eye regressed back to the similar clinical picture. In Feb 2004, we could see that both the eyes had failed limbal stem cell transplant. So we decided to repeat the allograft in one eye, which is the right eye. For better graft survival, we also started the patient on oral cyclosporin. The patient was doing well, and we could see that the cornea cleared up really well after 1 year, and hence we decided to move forward with a anterior lamellar keratoplasty along with a repeat cultivated limbal epithelial transplant. This time the donor was a brother. The patient was doing well on medications until he was lost to follow-up for the next 3 years, and he presented to us in 2009 where we can see this clinical picture where we can see a failed lamellar keratoplasty graft along with a failed limbal stem cell transplant. We decided to move forward with a Boston K-Pro in the left eye, as we know that the patient was a high-risk case for a corneal transplant. Patient underwent Boston keratoprosthesis in the left eye, and in the immediate post-operative period, the patient had a vision of counting fingers at 1 meter, which further improved to 20 by 25 after refractive correction. For secondary glaucoma, the patient underwent Ahmed glaucoma valve implantation in 2011. To summarize, a 9-year-old kid presented in June 99 with chronic VKC, giant papillary conjunctivitis and limbal stem cell deficiency, managed on topical and systemic steroids along with immunosuppressants, underwent multiple limbal stem cell transplant in right and the left eye, underwent lamellar keratoplasty in the right eye, which eventually failed, and a left eye Boston keratoprosthesis along with Ahmed glaucoma valve. Coming to the picture when he presented to us in 2019, the patient was doing well with the vision that he had and was managed on medications. In Feb 2022, the patient wanted something better. So in the right eye, the patient had a visual acuity of perception of light present and projection of rays accurate. The scarring was dense leukomatous scarring. The ASOCT showed us scarring of 432 microns depth. We decided that we'll do a stage procedure for this patient. So the patient underwent a simple limbal epithelial transplant in May 2022, and in the immediate post-operative period, we can see that the biopsies from the slit were well taken. The patient was now started on injection IV methylprednisolone 1 gram thrice 3 doses followed by oral Visolone. We also added another oral immunosuppressant, that is tablet azathioprine, for better graft survival. 5 months after the slit, the patient underwent optical penetrating keratoplasty with cataract extraction. The patient had a very good uncorrected visual acuity of 20 by 60 in the right eye 1 month post-op. And this is his final follow-up in recent January 2023, where the patient had a uncorrected visual acuity of 20 by 30 in the right eye and 20 by 200 in the left eye. What message I want to convey over here is that limbal stem cell deficiency is seen in only 1.2% patients of VKC. There are many other complications like secondary glaucoma, keratoconus, corneal scarring, and they constitute nearly 33% of all VKC patients. LSCD is the most vision-threatening complication and very challenging to manage. The surgical options that are now available are simple limbal epithelial transplant, cultivated limbal epithelial transplant. For symptomatic management, we can use amniotic membrane transplant, scleral contact lenses. For visual rehabilitation, keratoprosthesis or a lesser better option, penetrating keratoplasty can be done. So in the past, CLET was a surgery that everyone would look forward to. However, in CLET, we need a double surgery. We need a heavy investment on a stem cell lab where we can culture the limbal epithelial cells. SLET is now the way to go, where in a single surgery, we can directly transfer the limbal stem cells from the donor In case of a one-eyed patient, from an allogenic donor to the patient, and a patient who has other eye healthy from the other eye to the diseased eye. VKC is a disease that we commonly see from residents to the senior most consultants. We see every day in our OPD, but no one wants to see this scary face of the disease. And what will affect the outcome? The phase of the disease that the patient is in and how he is managed in that particular phase, a meticulous follow-up. And in VKC, if the patient does present with such a scary face, it is always better to intervene one eye and keep the other eye as a backup, so that these are high-risk patients, can fail any point of time. And the other eye, if it's a backup, we can provide good vision to the patient. I want to add one additional information. This patient today is a successful Ayurvedic physician and having a very productive life, which he had probably lost hopes in his childhood. Thank you.
Excellent case, Sonali, and very good documentation. You almost have followed for 20 years. So before we go on to discussion, Karan is here again to make an exciting announcement.
New announcement.
Got no chance.
Yes, regarding the Unite. Okay. So the Unite at Imperfecto Shore will be sponsored fully by AIOS. So it's free for all of us. Yeah.
So hold on the excitement for Unite and be with us. We have the good discussion coming up. So over to the judges for the question answers.
Nicely managed case, Dr. Sonali.
Thank you, ma'am.
I would want to know what was the fundus findings in this patient after you had done a KPRO and a PK with a good clarity. So what was the fundus of this patient?
So ma'am, in the right eye, the patient had a cup disc ratio of 0.6:1 and the FR was present. Rest of the fundus was within normal limits. In the left eye, the patient had a 0.9 cupping, which is an advanced glaucoma, for which he had also underwent ameth glaucoma implantation in 2011. That is 10 years back from now. The cupping was stable at 0.9 since past 10 years. FR was present and the rest of the fundus was within normal
I think
limits.
you're presenting the patient in totality and not just the cornea part of the patient. So that would have been interesting to mention.
Yes,
because
ma'am.
these VKC children are on steroids for a very long duration, even
Yes.
before they present to us. And most of them have secondary glaucomas at the time of presentation.
Yes,
What
ma'am.
about the lenticular status?
So ma'am, both the eyes were aphakic. The right eye that underwent penetrating keratoplasty, we extracted the lens when we were doing the keratoplasty, and the eye that had a Boston K-Pro, when they presented to us for the first time, the patient was already aphakic.
So again, if that was mentioned, it would have been even better.
Yes.
What made you choose PK as an option in the right eye compared to another K-Pro in the right eye?
Ma'am, with K-Pro, we have seen it's a vague correlation. I have not found any papers on that, but we have seen increase in axial length after K-Pro and also much higher risk of a secondary glaucoma. Although I do know that keratoplasty was a very high risk for this particular kind of a picture, but a stage procedure, we decided it after SLED that we would put this patient for a PK when his cornea cleared up and the vascularization reduced significantly after the SLED.
Can you elaborate the cause of glaucoma in the left eye? What would be the mechanisms contributing to glaucoma?
Yes, ma'am. So, two major mechanisms. Before the patient presented even to LVPI at 9 years of age, he was treated by local ophthalmologists and physicians also. So, he was already on steroids for a very long duration. So, that could be one of the causes for secondary glaucoma, steroid-induced glaucoma. Another would be the limbal stem cell deficiency and undergoing a keratoprosthesis. Keratoprosthesis in itself can lead to secondary glaucoma, ma'am.
So that's great. But most of these children are on steroids in both the eyes, so generally you would expect a symmetrical glaucoma compared to such a great asymmetry. But
Yes,
very well managed case. Thank you.
Thank you.
It was an excellent case, and I think Dr. Vidra Sangwan is managing this case in the LPPI, right? So he's the father of SLED, and he has shown how SLED can be, really, blessing surgery, that it can even make in a very high risk case, a clear PK graft survive. So, do you think that the similar approach could have been applied for the left eye as well? That because that eye also had a severe limbal stem cell deficiency. So, could it be like first we do the SLAT for the left eye, and then get a better ocular surface, followed by a penetrating keratoplasty, which could have avoided a capro surgery in left eye?
Yes, sir, I definitely think the surgery was done in 2009, which was nearly 12 to 15 years back. At that time, the SLET was in its very beginning stages and we did not have the long term results. About SLET, we all know that it has a very high failure rate and it also requires a lot of investment in the stem cell lab. So the patient had already undergone SLET once in the left eye. And yes, if SLET would have been available at that time, it would have been a better option for this patient.
Absolutely right. And we have many young, ophthalmologists will be even viewing this session on YouTube as well. So this one question even I remember because I think asked during my PG days that once you have done a Kepro in anybody's eye, and obviously it has to be done along with the valve surgery. So how will you follow up your patient in OPD in terms of glaucoma, and how will you judge intraocular pressure once the Kepro is done?
So, sir, the best would be either a tonopen or an eye care tonometer or a transpalpebral tonometer for the IOP measurement. Another thing that we need to do at every 6-month follow-up is the visual fields for the patient and a very good documentation of the optic disc, either in the form of a diagram or in the form of a fundus picture, and an ASOCT to be done every 6 months.
Dr. Himanshu Matalia at Narayan Nethralaya, he used to say that every Kepro with a valve patient is a ticking time bomb. You have to keep a follow-up. They can go into a different kind of complication post-operative sequelae anytime. So the follow-up is very important for all these patients. The chances of developing prosthetic membrane is also very high, and those also needs to be dealt with. So excellent case, and congratulations to you.
Thank you, sir.
So just to add on to what you mentioned, when we check IOP in such cases, so you cannot take the reading which is there at the center.
Yes,
So
ma'am.
if you are using a tonometer, from which part will you take the reading?
Ma'am, from temporal would be better because of
A
more
little
exposure.
like limbal. Okay?
Yes, ma'am.
And in such cases, handheld applanation like Perkins is easier because you can actually keep it in that direction. Our normal Goldman's applanation will not work.
Yes, ma'am.
And time and tested is digital palpation. I know it's very crude, but with experienced hands, if the pressure is around 30, 35, it can be judged.
Yes, ma'am.
So, and any take on AGV surgery and Kepro surgery together or one after the other?
Ma'am, I'm not.
Yeah, so just to add on to it, most of the cases which undergo Kepro surgery eventually need AGV implantation. So many a times both these procedures are done in the same setting. The surgical time is long, the recovery is a little slower, but in the longer run, the glaucoma control is better. So,
Yes, ma'am.
Thank you, ma'am. Thank you.
Thank you so much. Excellent presentation, excellent points by our esteemed panel. Now may I request Dr. Shrey to present his case.
Good evening, everyone. So at the outset, I'd like to thank Team YOSI for having given me this opportunity to present my case. So I'm presenting a case of a 76-year-old male who presented to the OPD on 30th January 2023 with chief complaints of redness, foreign body sensation, and blurring of vision in the right eye for 1 month. The patient is a known diabetic and hypertensive and is currently on medications. On slit lamp examination on retroillumination and magnified view, there was a plaque-like grayish-white corneal lesion extending between cloacas 5 and 9. There was also pseudopterygium in the right eye. The patient was advised CBC, PT-INR, RBS, anti-HIV1 and 2, HBS-AG, anti-HCV as a part of blood investigations and an ASOCT of the right eye. So based on the clinical features, slit lamp examination and ASOCT findings, the diagnosis of corneal ocular surface squamous neoplasia was made. The patient was subsequently started on topical interferon alpha 2B, 1 million international units, 4 times a day. So what are the distinctive features of an OSSN on ASOCT? It's the epithelial hyperreflectivity, the abrupt transition between normal and abnormal epithelium, and thickened epithelium. Now, how to prepare topical interferon alpha? We dilute interferon alpha 0.5 ml with 2.5 ml of artificial tears. So we now obtain a concentration of 1 million international units, and this is dispensed to the patient maintaining cold chain. The patient is instructed to store the drug in refrigerator at 2 to 8 degrees Celsius and instill the drops 4 times a day. So the patient was instructed to instill the drops 4 times a day, and he was followed up fortnightly. On the follow-up visits, we also got the ASOCT of the patient done just to monitor the response to topical interferon alpha. So after 50 days of initiation of treatment on a clinical examination and ASOCT, we can see that the lesion has almost completely resolved. So our findings were also corroborated on the ASOCT. So we can see that the epithelial hyperreflectivity and the epithelial thickness has considerably come down. Now, ocular surface squamous neoplasia encompasses a spectrum of corneal as well as conjunctival lesions. It includes dysplasia, corneal conjunctival intraepithelial neoplasia, squamous cell carcinoma. So although OSSN is typically a localized and slow-growing tumor, it can really invade sinuses, orbit, or the globe. Now, what are the risk factors? UV light, HIV, immunosuppression, human papilloma virus, mutations or deletions of tumor suppressor gene P53, xeroderma pigmentosum. Now, here are various varieties of OSSN. It can be nodular, leukoplakic, diffuse, gelatinous, or papilliform. Now, what are the treatment modalities at disposal for localized OSSN? It can be surgical or topical. So surgical excision is done with 4 mm wide margins, no touch technique, cryotherapy of the limbus and conjunctival borders in double freeze, slow thaw manner, and absolute alcohol placement on the limbus. Surgical excision is primarily done for lesions within 4 clock hours of the limbus. It has potential disadvantages, including limbal stem cell deficiency or conjunctival scarring, and leaving residual disease that can lead to subsequent tumor recurrence as high as 56%. So what are the topical treatments available with us? It is mitomycin C, 5-fluorouracil, and interferon alpha. So mitomycin C, also known as devil's drops, is used in a concentration of 0.02 to 0.04%, given 4 times a day for 1 week, followed by 2 to 3 weeks of off cycle. It usually takes 3 to 4 cycles until resolution. The common side effects are pain, keratopathy, punctal stenosis, and limbal stem cell deficiency. Due to the risk of punctal stenosis, punctal plugs should be inserted prior to initiating topical mitomycin C. Now, 5-fluorouracil is used in concentration of 1%, and it is instilled 4 times a day for 1 week, followed with 3 weeks of off cycle. The common side effects are mild pain, liriodema, epitheliopathy. It is also known as small devil. To reduce symptoms, topical corticosteroids are used in conjunction with preservative-free artificial tears. Now, interferon alpha is used in concentration of 1 million international units per ml, instilled 4 times a day. It has no off cycle. It is used continuously. It has very minimal side effects like malaise with injections. Hyperemia and follicular conjunctivitis have been reported infrequently along with formation of epithelial microcysts. So this is a slide summarizing the 3 topical modalities that we have. So there was complete resolution was almost similar in all the 3 topical modalities. The recurrence rates were also similar. The adverse effects were maximum with mitomycin C. The time to resolution was least with 5-fluorouracil, and the cost per cycle was maximum with interferon and least with 5-fluorouracil. What are the common mimickers? Limbal stem cell deficiency, pterygium panis are the common mimickers. Now, what is the role of ASOCT? The ASOCT is used to differentiate between OSSN and its mimickers to monitor response to treatment to topical chemotherapy. Distinctive features I've already mentioned. So what are the take-home points? A good clinical and slit lamp examination and a high index of suspicion is of paramount importance in detecting an OSSN. ASOCT is an extremely useful modality in differentiating OSSN from close mimickers. The characteristic features are again hyperreflectivity of the epithelium, thickened epithelium, and abrupt transition between normal and abnormal tissue. Interferon alpha 2B is very effective in treating OSSN and is widely becoming the treatment of choice for OSSN because of its better side effect profile. Choice of treatment in corneal OSSN is topical chemotherapy. Now, last but not the least, I'd like to thank my guide, Dr. Uma Sridhar and Dr. Shiyadhar, to have for guiding me through this and for encouraging me in all my endeavors. Thank you.
Thank you so much, Dr. Shrey. Over to the panel.
Hi, excellent presentation, Shrey.
Thank you, sir.
Lots to present in a short time. So, few things I'd like to ask you. So, since your first take-home message was that we should focus on a good clinical examination.
Yes.
So, what else would you do in a patient with a suspected corneal OSSN?
So starting off,
apart from the slit lamp.
So we can stain the patient with fluorescein dye or rose Bengal dye just to delineate and highlight the extent of the OSSN.
Okay.
And then we just go on retro. If we examine the patient on retro illumination, we get a better view, and on magnified view, we get a better assessment of the lesion. So since my case was purely a corneal OSSN, so these are difficult to pick, and a very good slit lamp examination is always, we must examine the patient very carefully on the slit lamp to pick up, lesions like these.
Did the patient have any history of surgery? There is a pseudoterygium there.
Yeah, there's also pseudoterygium, but no, there's no history. I think just chronic, dry eyes can also sometimes cause pseudoterygium. There was no history of any mechanical trauma by any contact lenses or any chemical burn injuries, so that had been ruled out.
It's a very big pseudoterygium, so most likely the patient did not give you that history.
Yes, maybe.
It could be a history of surgery in such cases. So you also did a very elaborate blood panel testing. What was the rationale behind that?
So this is just the routine protocol. So if a young patient presents to us with a corneal OSSN, we must get the HIV markers done. But just as a routine part of routine blood investigations, we got all those things done.
Right. So there is, in cases like you yourself said, the young patient, because the typical age for OSSN would be a middle-aged, older age group. So young patient presenting with OSSN or a bilateral patient,
yes,
you would be more inclined to do all these viral markers, especially HIV.
Yes.
Otherwise, there's no role of these markers in OSSN. So unnecessarily burdening the patient financially does not make any sense. Coming back to the point that you made, I think this is very important, that whenever we see a surface tumor, our first diagnosis is OSSN. Because it's an umbrella term, right?
Yes,
the person who coined it said that it's an umbrella term, so it includes everything, right?
Yes, sir.
So the onus is on the clinician to differentiate what is OSSN and what is not OSSN. I think what we critically missed, we could have done in this patient was a rose Bengal staining. A fluorescein staining has no value in OSSN at all. That is just to stain an epithelial defect. In your case, a fluorescein staining would be positive because there would be Dellin effect because of pseudoterygium, right? But if you were to do a rose Bengal staining, that has more than 95% sensitivity and specificity for OSSN. So that must be done. I think that is a very important take-home message, that we should not jump to investigative modality and fancy equipments like ASOCT, right? There's a lot of focus on ASOCT of late in last decade for everything. If you go and do the literature search, people are doing ASOCT for pterygium also, which is good because we get to know what we find on these imaging findings. But skipping the clinical part would not be a good rationale to do that, right? What about impression cytology? Did you consider impression cytology?
No, sir. We did not get an impression cytology done for this case.
So do you have a good histopathologist with you? Pathologist?
Not at our center, but we do get histopathology.
So impression cytology works only if you have a good pathologist with you. Otherwise, everything will be reported negative, and you might be misled in treating the patient as a plaque or as a non-neoplastic lesion, right? Another thing is that when such a patient presents to us in our OPD, we usually like to observe the patient. So we call the patient after 4 to 6 weeks before jumping onto if an ASOCT is not visible. So your ASOCT findings are very nicely documented and they do corroborate with an OSSN. But if it were not available, and if rose Bengal strips are also not available, the first attempt would be to follow up the patient at close intervals to see if this is progressing or not. Sometimes a corneal plaque in absence of a rose Bengal staining looks like an OSSN, just like an OSSN. And you might be over-treating the patient with interferon eye drops or all these things, right? The third point that I would like to mention you is that when you mentioned the surgery, the alcohol is applied on the epithelium, not on the limbus. It's for the cornea.
Yes.
You cannot excise the cornea or do a lamellar excision in OSSN. So you denature the superficial epithelium with alcohol using a Mirocell sponge or a cotton bud, right? So that is basically to scroll off the epithelium, because this tumor is limited usually and is anterior to the Bowman's. It does not go into the stoma unless it's an invasive OSSN, which clearly from the clinical picture it does not look like. So there is no role of retroillumination in OSSN.
Okay.
Right. Then you showed a table in which you mentioned everything in dollars.
Yes.
So you'll be surprised to know that in US half of the population cannot afford interferon therapy, because like you said, it is $500 per treatment,
Yes.
and 5FU is just some $39 or $40. But in India, thanks to Reliance and Reliferon and probably Ambani, that we have a very cheap interferon available. Right, it is just 800. The vial that you showed is just 600 to 700 rupees.
Yes.
And when you reconstitute it, it lasts for about 15 to 17 days if used judiciously, 1 drop 4 times a day. So the entire treatment cycle cost is just 8,000 or 7,000 rupees. Right. So that is one message that should go across, that we are fortunate to have this therapy with us at a lower cost, which is usually otherwise. Right. So that is how it should be judiciously used. I think otherwise you skipped a step probably in the management of the patient, but the documentation was excellent. You do see a very nice change in ASOCT going from a hyperreflective abrupt transitioning epithelium to a normal corneal epithelium. The thickened epithelium that you showed was actually not OSS, and that was your pseudopterygium.
Yes.
So there is no thickened epithelium in your case. It's just the hyperreflective epithelium and probably the abrupt transition. That is also not a very relevant point in your case.
Yes.
So the thickened epithelium that is shown in the diagram was actually your pseudopterygium. Right?
Yes.
Excellent presentation.
Thank you, sir. Thank you so much.
So, thank you so much. Thank you, judges, panelists, for this wonderful discussion. So, I would like to invite Dr. Divakant Mishra, sir, to please honor the presenters. First, I request Dr. Karthikeyan to please come over the stage to receive the certificates. May I request Dr. Anujit to please come? May I request Dr. Sonali to please come forward to receive the certificate? I request Dr. Shrey Raj Singh to please come forward. So thank you once again to all the presenters. We would like to honor the judges for this session as well. So may I request Dr. Shivani to please come forward. I request Dr. Divakant Mishra to please honor Dr. Nikunj. I request Dr. Puneet to please come forward. He is busy giving marks to the presenters. I request Dr. Anu to please come forward. So last but not the least, I would like Aditi to please accept the honor of moderating this session. And once again, thank you all of you for being with us. And the results will be announced tomorrow once we finish all the competitive sessions. So over to Dr. Nupur. So may I please request everyone to quickly come for a group photograph. Presenters and judges of this session. We just have 1 minute.
Nupur. 9:30 minutes. 9:30.
So, thank you, Aarti and Aditi, for the wonderful surfing the anterior segment session. Karan, do you have an announcement to make? Okay, so there's an announcement for Bio Night. So, as already discussed, so till I'm announcing, I'll request the panelists of the Beyond session, Dr. Aditya, Dr. Gunjan, Dr. Shivani, and Dr. Ankita to please come on the dais and just sit. Dr. Aditya, please. Panelist, Gunjan, Ankita, Shivani, Dr. Shivani. So, Bio Night announcement is, the plan is that we plan to start the Bio Night at 8. So, everybody be here by 8. After this Beyond session, we have a break. There's nothing in between. Whatever you need to change, please go and change. 8 o'clock onwards, we have a small entertainment program for you with games. There'll be a stand-up comedy act. There's a 3D art show. And so by 9:30 we plan to wrap up. 9:45ish we will all proceed. 9:45ish dinner will be served. We'll have a dinner here.
So as 8 o'clock we start. Plan to have the dinner started by 9:15 or so, 9:15. As soon as we finish, eat your dinner, gulp your dinner, whatever it is. 9:30 we have to leave. Huh?
And it's Imperfecto, which is a pub nearby, and it's being covered by AIOS. Okay, so we're looking forward to a DJ night.
Before we go on to the next session, before the next session, we have a very dynamic yo here. So let us all stand to wish her on her birthday. Happy birthday to you.
No, you need a license for it.
Happy
Please stop.
birthday to you. Happy birthday. किस का है भाई? और कोई भी है क्या? Happy birthday, dear Rituja. Happy birthday to you. Your birthday, girl.
The birthday girl will pay for it, right? So, good evening, everyone. We come to the concluding session of this wonderful first day of the AIOS YOSI Forum. We have a very unique session, the Beyond session. So, we've divided this into two parts. Can you just move the slide? Yeah. So, it's health. The first part is health and wellness. The second part is I, me, and YO. How harboring hobbies has helped me as a YO. So, with great pleasure, I introduce the panelists for the session. First panelist is Dr. Shivani Dikshit. She's currently practicing as a glaucoma and cataract consultant at SRG Netralaya, Super Specialty Eye Hospital, Indore. Next slide. Then the next panelist is Dr. Ankita Khanna. She's a cornea, cataract, and refractive surgery consultant in Delhi at Khanna Eye Center. And then we have Dr. Gunjan. She's practicing as a cornea, cataract, and refractive consultant in Delhi, NCR.
And we have Dr. Aditya Sethi, who's a consultant cataract refractive surgeon and pediatric ophthalmologist at Arunodaya Desert Eye Hospital, Gurgaon, Haryana. The moderators for this session is myself, Dr. Nupur, Dr. Rohit, who's a VR surgeon in Bombay, has his own practice at Centra Eye Center, Dr. Aditi Ghosh Rastidar, she's working as a cornea and ocular surface consultant at Synergy Eye Care, and also in Kolkata at Netralayam and Tetra Netralaya, Kolkata. So I would request Dr. Rohit to introduce our first speaker for the day.
So this is going to be a spatial session. And, when we are discussing so many things, practice, finance, ophthalmology, retina, cornea, we tend to forget what's the most important thing. So I want to invite Pooja Mehta to speak on the most expensive thing I have. Dr. Pooja is a pediatric vitreoretinal surgeon and an ocular oncologist. And besides her passion for work, she's also a fitness enthusiast. Dr. Pooja?
So thank you for the introduction. The introduction is covered, so I move on to the topic. Thank you, Yosi and Dr. Nupur, for giving me the opportunity to talk about a topic which is very, very close to my heart. The most expensive thing I have is health. And although health can mean very different things to different individuals, for a very long time, what it meant to me was fitness. And of all the things fitness could mean, what it meant to me was the glamorous aspects, chasing the chiseled body in the exuberance of youth. So this was myself when I was 18 years old, first year MBBS, bagging the title of Miss Fresher. Must have been my personality, as you can see that there's nothing else I can give credit to. And this was exactly a year later at my junior's Freshers Day. So what triggered this transformation was my self-esteem hitting a low. Now the question is, before and after what? And a lot of people asked me how I did it. So it was logical for me to believe that the body follows the laws of thermodynamics, that if I could just decrease the energy intake or increase the energy expenditure, I would lose weight. And I did, by gross calorie restriction and exercise. It was sheer teenage josh and willpower. And at the end of 10 months, I lost 35 kgs. But I ended up being skinny fat, which is the term given to a person who has high fat percentage despite low body weight. And this is because of low muscle mass. So to fix this, I switched from a predominantly cardio workout to training with weights as well. Now over time, this prolonged calorie restriction was just not working for me. I had high relapses, fluctuations in weight as well as mood. So this made me seek better insights into food and calorie, and I began to understand that all calories are not equal. I realized that hormones hold the key to body fat deposition and fat loss. My life changed when I understood the two-compartment theory by Dr. Jason Fung. So what it says is the form in which the calorie we intake is stored or available for utilization is basically governed by insulin, which is a pro-fat storage hormone. And fasting is an effective way to utilize these fat reserves. Now, there was a paradigm shift in my eating habits, and my preferences and ideas were so radical that it made me socially isolated at times. So my eating habits became rational to my peers only when there was an article in the New England Journal of Medicine in 2020 which showed the benefits of intermittent fasting, and there was evidence that 18 hours of fasting causes this metabolic switch which helps you to increase longevity, decrease diseases by improving an emerging health problem of insulin resistance. Now, many of us don't realize this, but sugar is a very, very potent drug. It can cause euphoria, what we know as sugar rush, dependence and heavy withdrawal, what we know as craving. Now, there are huge benefits of cutting down sugar in your diet, and this the food companies do not want you to know. In fact, the food companies are adding micro doses of sugar even to savory items to make it more desirable. So, in 2017, I adopted intermittent fasting as a way of life, and in 2018, I quit sugar. And then when all was going great, in 2020, I faced a major setback when I had an injury in my shoulder. It was a very, very tough phase, as I was additionally facing setback in my career front as well. and the body and the mind needed some healing. And what started as physiotherapy soon changed my daily workout preference from body weight training to flexibility and meditation. The shift through the phases has been because of the shift in my goal from weight maintenance to targeting anti-aging to overall well-being, and from believing nutrition to be the most important of the 3 pillars of good health to additionally prioritizing rest and sleep in my 30s. So now this is something I cannot emphasize enough, especially as a VR surgeon, is the importance of improving your longevity. Thankfully, these issues are being increasingly addressed by experts who suggest that we should not adjust to our workplace. In fact, we should adjust the workstation to suit our anthropometry. This is because every time we compromise, there is an incremental damage in our body that is going to hit us the most when we are at the peak of our career. Now, the standard understanding of and definition of fitness does not include a very important aspect of mental health. We need to differentiate the feeling of sadness occasionally versus continuously, seek help when needed, and be the help to somebody around who requires it. There are several dimensions of well-being that we are continuously exploring as we go through life. So the most expensive thing I have is a perfect balance of these secret ingredients. So health is your biggest asset, and we've learned a lot about investment today, but make investment that health rightfully deserves. Thank you.
Thank you, Dr. Pooja. Absolutely amazing talk. And we doctors keep on giving tips to others how to stay fit, but it's our own mental health many a times which we overlook. Thank you. Next, I would like to invite birthday girl, Dr. Rituja Thomas. She is a practicing orbit and oculoplasty surgeon. She is going to speak on, do I need to go to the gym to stay fit?
Hello, everyone. Okay, so when I was given this topic by Nupur, the first thing I thought was, how does she know that I don't go to the gym? And the second thing, I was like, am I even that fit? So I had to look into my life deeply and sort of think about what I actually do to stay fit. So the first thing is, I think this comes to me just naturally, but this is my breakfast every morning. So it's just black coffee, no sugar. I do have 1 piece of carb, egg for the protein, fruits and vegetables. So it's difficult to go wrong with this formula. This is something I've eaten on vacation. So normally we like to hit the buffet breakfasts at vacations, but when we stay in an Airbnb, we like to keep it simple like this. And when it comes to snacking in between during the day, it's important to sort of get some fiber in your diet. Like there's no other way you're going to maintain your weight. If you don't like to have fruits or keep chewing on fruits, or if hard or chewing is like a problem for you, you can always use a juicer, and this is how I juice all these fruits. So I'm pretty high on vitamins, as you can see. Even while going out to eat. So this is like, I actually didn't even realize that I do this, but I like to have things which have a lot of vegetables in it. So that's not trying to promote vegetarianism or veganism or anything. It's just that you have to have a good balance between your proteins and your fiber. But at the same time, I do like to enjoy my sadhya. So, but if you notice, this is like red rice, which is also pretty healthy, rich in fiber, and it has all the vegetables and of course ignore the papadam, but otherwise everything else is actually pretty healthy. The other thing I actually do without thinking, which I realized recently, is portion control. So I never used to do this earlier, but after crossing the age of 30, I could feel my metabolism slowing down. So Nikunj is here. He's a testament to the fact that we used to eat like one pizza each on night duties. So that kind of changed after leaving college and training. And portion control is something that I learned how to do. Whether you're on a flight or you're on vacation or whatever, portion control is something you can always practice. I agree that it's important not to waste food, but at the same time, if you're given a lot of food at one point, it's important that you don't overeat as well. So you don't really need to go to the gym, okay? Go to your nearby park, just get a walk in, either in the morning or in the evening. And this was, of course, you can see bright daylight. So this was during COVID that I could manage to go out during the day. But it's important to try to get a little bit of aerobic exercise in. Suppose you can't step out or you don't have a park nearby. Do some exercises at home. So all of this is free. Like you can do yoga at home, you can do Pilates at home. Doesn't require any kind of equipment. It's just you need a yoga mat or a carpet or whatever, maybe a few weights. You can also do something called yoga lattes, which is something new these days, and I started doing this recently. So it's basically a combination of yoga and Pilates. The other thing which keeps you fit is like Pooja was mentioning, that about mental health also. So it's important that you get some peace in your life, that you reflect and sort of meditate. That also helps you keep fit. Of course, if you don't know how to do yoga, it's best not to go ahead and do it. But if you do, then it's like the best exercise and mental health routine. So some people, like my husband, he doesn't like to do exercise at all. So he has several hobbies which help him lose weight and keep fit. So I try to join him on some of these adventures. And if you don't like to walk alone in the park, you can take your family members along, your dogs. And even on vacation, we somehow find dogs who will walk with us. So this is something that pet lovers, it would help them. Occasionally, it helps to enjoy your drink, your coffee with your milk and sugar and your dessert. There's nothing wrong with this, and you shouldn't punish yourself. In fact, you should reward yourself every time you need to celebrate. And it's important to go on vacation, get some solitude, throw away your phone, and even go out with your friends, hang around with your friends after conferences. Don't only sort of attend the conference and then just leave. You can get a lot of exercise just by trekking around with these people, is what I realized. And sometimes you need to go out alone as well. So the bottom line is just be at peace, have a balanced diet, and this will help you sort of chase your dreams and help you in your career as well. Thank you.
Thank you, Dr. Thomas, for a wonderful talk. I believe the key takeaways is, balanced diet would mean more of, raw vegetables. Keep a exercise plan. Maybe if it is just for 20 minutes, something like even Surya Namaskar, or doing a nitric oxide dump, or taking the staircase, walking to the nearby parks can help you. So small tips, but can go in a long way for your good health. Next, I'm going to invite Dr. Piyush Bansal. He's a dynamic vitreoretinal surgeon practicing in Pune. He's also the ex-secretary of Pune Ophthalmological Society, and this guy does wonders. He's going to speak on down but not out, making a comeback from injuries. He's one of the fittest guys I have seen, and he keeps on posting his gym photographs. Right, Piyush? You're an inspiration.
Is this working? Yes. So you give me too much credit, but I hope I could post pictures from the gym. I've hardly been to the gym in the last 3 to 4 years. Not because I didn't want to, because of mishaps. But a wonderful presentation, Rutuja and Pooja. I certainly learned a lot of new things. What I'll be showing is, just my experience, what I have gone through in the last couple of years, and then perhaps a little bit of more in my life. So first I wanted you to see this video. Okay, we not. So I'm sorry, we're not getting any sound. Was a professional boxer, and then because of something that you just saw, his life turned around.
If you let me do the fusion, I can guarantee you'll be able to walk again.
That's not enough for me. I need to be able to fight again.
6, 5.
Lee, you looked in the mirror lately? You see that thing on your head? Come on, you heard what the doctor said. You're risking your life here. What life? Upstairs? No. Yeah, let's do it. Oh! Show me how you do. Show me how you live. Show me how you fight. You show you how I fight? Yeah. Show me who the fuck you are.
So this movie was called Comeback. I wouldn't say that mine is a comeback, but it brought a lot of emotions to me because I had been through situations like this many times in my life. One especially bad one. This is one quote from Rocky that I used to really like a lot. You know, the world is going to be very difficult in you, and it's not about how hard you can hit, but it's how you can get punched and keep moving forward. So in total, maybe 15 broken bones, multiple ligament injuries is what I have had. And apart from the mental agony, the lost time, and of course, right from the beginning, pursuing a career in medicine. So it takes a lot from all of us, hasn't it? So my first injury was in the right humerus at the age of 8. And that didn't stop me. After that, I went on to do track and field district level and picked up squash. The same time, went into do state and nationals under 13. But then tragedy struck. After nationals, I entered school athletics and I participated in a new event. Triple jump just to increase the points of the school, and I had a right ankle fracture. So no squash for the next 6 months, something that I started to cherish a lot. But then no worries, I picked up competitive swimming and qualified for district, for state, for nationals over the next 3 years. So under 16 is what I did. Then there were boards, and then like many of us, MBBS, so pretty much everything goes away for a toss. So what you see on the left is I don't post these old pictures. It was a tough job to actually find these old pictures. But one on the left is my pre-board picture, board meaning the 12th standard that we have in Maharashtra. And the guy on the extreme left, that's me again. It's just in second year. I was pretty beefed up in those days. So I was quite regular with my exercise, and this is first year again. So all throughout it was like this, you know, this is my residency, during my residency. And I wouldn't gym most of the times in those days, but I used to hike a lot. So we have around Pune, we have a lot of places where, you know, we can go hiking and trekking, a good 100-kilometer workout. So like I said, I used to work out a lot. But then getting into a rigorous fellowship program, I know somehow it worked the other way around with me. You see that I've already put on weight, and you know, no exercise, renal calculi coming in. And then we have a picture that's similar that Pooja had shown. You see this? That's me. So again, this was something that was not acceptable and made me look like Gabbar by the end of 2 years. But then I got back to swimming 1.5 years down the line, 100 to 200 laps a day, and then I was still looking more decent. But then just when things started looking uphill, you know, I could perhaps get into more rigorous training. I had the biggest accident. So this was in 2014. When I had a spiral cortex to cortex. I don't have pictures of those, but I have one picture which I dug out, cortex to cortex, left humerus fracture. So it was right across my left humerus. It required an 18-hole plate to be put in there. My right radius had gone, a carpal fracture, phalanx fracture. My left phalanx had gone, 2 ribs had gone. My brother picked me up from the road, and then he got me admitted at night. And the next morning, my younger brother was that time orthopedic resident. He's a very good revisional joint replacement surgeon now, but he and one of my senior colleagues, they were the ones to operate me in the morning. The next 3 months were pretty bad. I don't even remember when this picture was taken, but somehow it came out in the archives. So right from this cortex to this cortex, if I have the time. So again, long period of recovery, rehab, physio, immense emotional injury for the next 3 years. But then, you know, you have to get back to work. I started my private practice soon after. You see me, there's a big difference in this. And traveling was something that brought a little bit of joy to me. Academics is something that I immersed myself in. So I love traveling. I used to go on solo trips with my friends. But then 2017, I decided, okay, it's a good amount of time for my injuries to have healed. And no more fun escapes. It's time to get a balance. And that's the time when I decided that no matter how busy, no matter the pain, because my arm still hurts. To this day, if I do a pull-up, my left arm hurts like crazy. So I started simple. I started cardio. In fact, I used Fitbit. Chaitra Jaidev told me that you start using this Fitbit. So I started using Fitbit to 10,000 steps a day. I resumed swimming. And within the next couple of months, I started feeling fairly good. I could maintain my travel along with this, continue my talks. By August 2018, I was in a much better place. In fact, I wasn't even skipping workout when I was going to conferences. In fact, I was dragging seniors and colleagues. Chalo, gym jayenge, pool jayenge, doesn't matter what time. Middle of the night, no problem, let's go. In September to December 2018, I just went off the grid, completely dived into HIIT, strength training, agility, stability, sports, you name it, I was doing it. My crown jewel came in calisthenics, because at one point of time, I wasn't sure whether I'll do one pull-up, and then I could do 24, including 12 chin-ups. So it was a very big buster for me. So if I was awake, I wasn't still. I was just constantly moving around. These two things just brought the most amount of joy to me, whether it was being in the theater operating or whether it was working out, getting those endorphins out. So again, calisthenics is something that I completely swore by in those days. In fact, dancing is something that I wasn't too keen earlier, but then getting into dancing was something that also brought a lot of flexibility to my body, something that I started to enjoy a lot. I'm sure Nupur would agree. She's a phenomenal dancer, and the positivity she exudes is amazing. So by December 2018, I was perhaps the fittest that I had been, you can see. So in the last 10 years, I had never been so fit. And it showed, the happiness also showed on my face. So again, this time I felt and also looked like a Yosi. Unlike the pictures that were there earlier. But then during COVID, again, there were terrible mistakes that I made. I started running. There was nothing really else that I could do. And during that time, my plantar fasciitis, which I picked up at LVPI, it just re-triggered. I developed an IT band tendinitis because I was running 10Ks every day, which is something that most runners know, and I didn't know that you shouldn't be doing that. You're going to excessively strain on the IT band. So I was on a forced break for 6 months. So again, the weight started piling on, but then swimming coming back. By last year's AIOS, again, I was feeling fitter with just swimming. But then again, when I was just about to start weight training, another surprise, disc bulge. So you say, Rohit, that I'm very fit, but I don't feel fit right now. So many times I walk with a hunch, and I'm trying to work on that. So in fact, this is the week that just after BOA last week, this is from last week BOA, and this is after 6 months that I've stepped into the pool, and 5 times I've done just 20 laps. So you don't know what next. Maybe I'll be hit by another injury, or perhaps be able to get back to my older self.
Doing well.
You always have to, you have to. So you must, I'm very grateful for everything that I have. I could have died in that accident. So injuries will happen. They are like complications in surgeries, and that doesn't mean that you stop, or even mean that you push yourself when you're injured. So you should listen to your body and understand what it's saying, because rest is equally important. And get up when you can, run as soon as you can. If you can't, crawl. And it's all right to fail in between, but it's also important to pick yourself up, even if nobody else is there. So thank you. And I hope. Yeah.
Thank you, Piyush, for a wonderful, inspirational talk. I'm sure a lot of us would get inspiration from him. Now I would like to invite Dr. Sunena Hatila for the next talk, The Power of the Right Thigh. And I must say something about Dr. Sunena. We spoke to her 2 to 3 weeks back, suddenly out of the blue, and she agreed for a talk which she has not given before. And wow, thank you.
Thank you. So till Sunena is setting up her presentation, so Dr. Piyush, I must compliment you. It's not easy to talk about your own injuries. So I think that's really fantastic. You spoke about it. Very inspiring.
Hello and good evening, everyone. I am Dr. Sunaina Hatila. I've done my MS Ophthalmology from SMS Jaipur in the year 2022 and currently working as senior resident in the Sardar Patel Medical College. I'm going to discuss about the power of right diet. I have no financial interest, and first of all, we'll like to discuss about what is healthy diet. One that maintains or improves overall health or that provides essential macro and micronutrients could be considered as healthy diet. We'll emphasize upon whole food plant-based diet that includes green smoothie, grounded flax seeds, legumes and pulses and sprouts. The green smoothies could be considered as best energy drink, an excellent way to start your day. The grounded flax seeds have the comparable with the statin drug and have high fibers, anti-cancer property and omega-3 fatty acids. Legumes and pulses have high protein, 3 to 4 cups a day should be taken and contains resistant starch that are protective against colon cancer. It releases short-chain fatty acid and stimulates satiety center. The sprouts help in reducing the quantity of food and also favors the digestion. Gradually increasing in the amount can helpful in the facing the problem of flatulence. Fruits in salad are considered as pillar of digestion. 3 to 4 fruits should be taken at least in a day. For the diabetic, apple, pear, plum, strawberry, cherry, dragon fruit can be considered, and for the non-diabetic, any fruit would be helpful. Salads should be taken at least half to 1 kg of salad per day, including green cruciferous vegetables like cabbage, cauliflower, lettuce, broccoli, kale, carrot, onion, cucumber, tomatoes, sesame seeds, grounded flax seeds, etc. According to a famous nutritionist, Dr. Josh Axe, health is not about the weight you lose, but the life you gain. Water is also an important constituent, and at least 3 liters of water should be taken per day. Ideally, we should preload our stomach with water before every meal. We should try it. There are good food versus bad food. High fiber rich foods are considered good, while meat and egg are considered bad. Red meat are well known to cause colorectal carcinoma. Also, they have L-carnitine, choline, lecithin. They get converted into substances like TMAO, which is atherosclerotic as well as carcinogenic. Our body consists of good bacteria and bad bacteria. Good bacteria are enhanced by fiber-rich food like legumes, green leafy vegetables, and bad bacteria develop when we eat edible milk, egg, red meat, poultry, refined flour, refined sugar, and fatty food. Here are some calcium sources that are plant-based. For example, soy milk, tofu, edamame, chickpeas, okra, pumpkin, cabbage. These should be taken with a recommended daily allowance of 9 to 11 grams per day. Here are some plant sources that are proteinaceous in nature, like potato, peas, almond butter, almonds, black-eyed peas, black beans, etc., with a recommended daily allowance of 0.8 gram per kg body weight. The plant sources like legumes we have discussed. Vitamin B12 should be taken with a daily need of 2.4 to 7 microgram. These are solely sourced by the bacteria. Vitamin D helps in facilitating of the calcium absorption. Sunlight exposure of at least 20 minutes is needed for the vitamin D. The supplements can be taken in the absence of adequate sun exposure, like for the concentration of 2000 international units daily. We should try to stay hydrated. Defloor your diet so that you can have more and more fibers. Preload your stomach with water and negative calories like salad. Time restrict your eating according to the circadian rhythm. And on the left side, we can see a pie chart which shows at least half of our diet should be raw salad, 25% should contain dal, 15% should contain sabji, and roti as well as brown rice can take 10% of it. These are some studies showing benefits of whole food plant-based diet for the coronary artery disease. Even some studies show reversal of coronary artery diseases. Here we can see the pictures with significant results showing good flow of showing coronary angiography with good flow and decreasing in the size of plaque. As we all know, health is not valued till the sickness come, but we should try to value it before. Thank you.
Thank you, Dr. Sunena, for a wonderful talk. We all know a particular approach to diet is always very different with each one. And she presented her view about whole food plant-based diet. And there is a lot of data which has been published that some of the diseases, let's say diabetes mellitus or coronary artery disease, can actually be reversed. I don't have published data, but when I have given meal plans, nutrition is my passion, to my diabetic patients, I have seen them cutting down on insulin dose. A few patients actually could bring down their diabetic macular edema, reduce the number of injections by following a strict diet. And the basic concept of whole food plant-based diet, a thumb rule, even if we cannot go 100% plant-based, if we can increase the quantity of raw food to 50%, and most of our speakers, Dr. Thomas, everybody emphasized that the more raw we eat, the more enzymes we consume, which helps us in reversal of the chronic illnesses, or it helps in prevention. Thank you, Dr. Sunena. And for the first part of the session, we have a last speaker, Dr. Bhavya Gokani. He's a phaco-refractive anterior segment surgeon with AHE group of eye hospitals. And he's going to speak about the most important part, mind over matter. And if this is clear, the rest everything falls in place. Over to you, Dr. Bhavya.
Good evening. It's a very exciting topic, mind over matter, and this is Dr. Bhavya here. We can skip through the introduction. Financial disclosure, of course, none. They said talk about mind over matter. If there is any materialistic closure or disclosure, the very essence shall be lost. The sources of this lecture, one of those nights. Objectives, I believe that there can only be good ophthalmology if there is a great beyond ophthalmology. This is one of the most cruel parts of the current scenario. Our own mental health burning, and we are here talking about mind over matter. Mind over matter burning, and we are here inserting memes and trying to use humor as a coping mechanism. Why do we sulk? No, we don't. As doctors, we don't. Who says we sulk? We are over successful, very happy individuals, very fit mentally and physically, and we don't need any help. One of the interesting things that I came across while I was preparing for this is something new, which is known as the imposter syndrome. It means it describes a high achieving individual who, despite their objective successes, fails to internalize their accomplishments and have persistent self-doubt and fear of being exposed as a fraud or an imposter. Like they attribute their successes to external factors such as luck or receiving help, and anything that's negative in their life, they come across as professional inadequacy for themselves. A new project or task gets started, eventually sets up anxiety, procrastination, or over preparation. Eventually, when the project is complete, there comes a sense of accomplishment which is brief. Then the real feeling starts when the feeling comes as somebody else would have done it in a better way. And this in turn sets up the cycle of self-doubt, anxiety, and feeling of fraud. This is what you call as the imposter syndrome. This is very curious, which I received, that are you one of those imposter syndrome victims? There's one who is the perfectionist, who has extremely high expectations, thinks that 99% of the goal is achieved, I still feel like a failure. The expert who wants to know everything, but does not want to ask because he feels that he looks stupid. The natural genius who believes that if they have to struggle to learn something, they're not good enough. The soloist, I will never ask for help because I equate it to weakness. And the superhero who pushes themselves to work harder than everybody else to prove that they are not a fraud. I feel the need to excel at everything in life. There's a part of an imposter in all of us, especially at this part of our practice. 4 ways to overcome: start attributing your success to you. Don't compare yourself to others. Accept that you're a work in progress and learn to fail better. If you fail, fail better. The crazy chakra: post something on social media. We have a lot of discussions on how social media should be used. This is the downside. You post something on social media, it brings a momentary validation. You realize that that was inadequate. You need to work more. There's an anxiety to re-perform, and then there is a craving to rebroadcast, and you come into this momaya of social networking and posting it again and again. Another thing that I realized, which is engulfing and it's crazily affecting all of us, is FOMO, a constant urge to stay updated with friends. A lot of things have been talked about, all the mental illnesses, all forms of problems. This, I feel, is the latest and the woke part of our generation. Never misses a television episode, always on the phone, try to photograph everything, stalk 24/7, spend money when you can't afford it, afraid of being home, immediately sets up a cascade. So what can be done? You work out either here or you work out either there, both of which have been spoken in the previous sessions that have come. Can I read out something that's actually happy? It's an extract, and if there's anybody who I'm sure you would be able to could guess who I'm talking this about, using the stage name Kerry Adams, he recorded telephone numbers. He had a singing career. He used to be on shows that were hosted by Oprah Winfrey and David Letterman. He was a great saxophone player. He used to regularly perform in Atlantic City and Las Vegas, opening for, alongside the Spinners, Glenn Campbell. He's produced a lot of musicals, including the Broadway, including Can Can, Triumph of Love, etc., etc. Any guesses which musician or which amazing artist am I talking about? Any guesses? Which amazing artist am I talking about? Now can you identify this musician? Yes, he's Charles T. Kellman. He was a documented artist. What he did was, there was a time when FACO was being explored. The community came up and did not support him. He started going to the stage, and this came to him as a sabbatical, and this came to him as a reincarnation. And that's the story. Maybe you would want to Google it. It's amazing to, it's exactly what he did. 10 psychological defenses. All of these are psychological defenses. In optimum, they are amazing. When they shoot up, they are detrimental, and they're set up in the same casket that we all were talking about. Find the lecture of the entire session about the power of hobbies. Mine is a very standard one. The one in the left is my favorite one. I don't know. I feel that sleep is the best hobby that anybody can ever have. It recharges your neurotransmitters to an unimaginable extent. My Ikigai, Ofthal, of course. Rangmanch, to those who know me, I'm associated with the stage to a level that the stage has, just last 2 slides, to a level that I don't know if I've given the stage anything or not. The stage has given me a lot, to a level that I don't call it the stage anymore. I call it the Rangmanch. Sports, family and friends. And this is something that I came across. Life is just like corneal edema on post-op day 2. Maybe you exerted too hard, too long, but you know what's beautiful? Most of it resolves simply with time. And this is one of my favorite slides. पता नहीं दूसरी सारी कॉन्फ्रेंसेस में जाता हूँ तो स्ट्रेस होता है, फोमो होता है, कॉम्पिटिटिवनेस होती है, योसी में मजा आता है. So thank you so much Yosi for having us, and it comes as a relief. And thank you AIOS YOSI Forum for having me. That's Dr. Bhavya Kokani signing off. Thank you.
Thank you, Bhavya. I'm looking forward for your act. So that was a fantastic talk, and my key takeaway was nothing matters in the end. There are sometimes when I'm stressed about, and after 2 days, that thing doesn't matter. And now I realize actually most of the things doesn't matter in the end. absolutely. So we have a few panelist questions for you, Dr. Shivani. You know, what I learned from the session is focusing on my health is priority. What is your number one fitness mantra?
Yes, so this fitness mantra I have learnt it the hard way. I was working at a very high volume center and started having back stiffness. I was like, it's okay. It worsened to sharp shooting pain, diagnosed with disc bulge, nothing you discussed before. I spare few minutes every day to do my core and back strengthening exercises. And all the young people here, please start doing, so that when you are in your mid or late 30s, you don't have that bad backache. So that's my mantra.
I can completely relate to that, being a retina specialist. So, Dr. Ankita Khanna, as a young ophthalmologist, we are juggling between so many acts. We are trying to set up our practice, then attend conferences, and especially for a lady, you have sometimes kids at home. So being a mother or even a father, we can give some credit to the father also. And so what is your mantra of balancing life-work balance? How do you approach that thing?
Time management, I think, is easy said but difficult to practice. I think it requires one's coordination between the daily activities to maximize one's efforts. It depends, I think, to find time depends on your motivation, basically on own motivation. So I find time for my own fitness mantra basically by getting up a bit early and before my baby wakes up. So because decreasing my good half an hour sleep, I try to find my time for exercise, and definitely even I faced through the backache thing which was mentioned, and even I realized after that only that one needs to have a fitness mantra and find time for yourself, and that was my motivation.
Thank you. Can we have a show of hands, all of those who have actually faced a lower back pain? I believe 60% of us are honest. So, Dr. Gunjan, what Bhavya spoke was so important, but how to actually implement it in a life is a challenge. So, how to stay mentally calm? What would be your mantra you will give to the yos to stay mentally calm when we are running here and there, and especially subspecialists or super specialists when we are freelancing?
True. I think I can't just say, but it's just like what I started doing even during the lockdown times, etc. I picked up few of my hobbies. I started learning new instruments. I started playing ukulele. I think music, keeps you a little bit calm sometimes. When you are even operating, sometimes we would have seen that once we are playing some music in the background, some complicated surgery is going on, something like that, and we just don't feel the load of that on your head. Like we are just always feeling that something is going on, lyrics are going on in your head. Sometimes it doesn't work out, like sometimes you want to, but I feel music is one of the biggest calmer for everyone which can be there. Secondly, I think meditation also helps a bit. When you start meditating, then you understand how wanderer your mind is. When once you start meditating in the beginning, then you start feeling that you actually are a wanderer and your mind is also a wanderer. So once you start meditating, it does take a long time to develop a meditating habit. And during my fellowship days also, I was with my consultant, so I used to have one app on my phone, and he used to ask me, what is this? So I said nothing, this, I just want to listen to it. So she also picked up that app, and now that app everybody sometimes uses. So I think meditation somehow helps. Is obviously not the kind of meditation we feel that we used to see in a lot of movies, Eat, Pray, Love, etc. But nowadays, I think we have good apps also that give you a modern insight of meditation. Somehow, I feel that it works for me, and I think everybody would have their own kind of stress busters. Thank you.
So all the OT assistants love to come to my OT because madam ka OT hai to music to chalega hi. And this is something I cannot somehow operate with if the music is not on. I start feeling sleepy.
I agree with both the points. Music is obviously great. Most of us will agree with that. And about the meditation, I've tried it with my CSR patients. It has done wonders for them. Aditya, no, you are quite a fit person. So, so one superfood you would recommend, and how much importance you will give to sleep. One of our presenters did speak about sleep, and at least I speak to my CSR patients a lot about sleep, but I am myself not clocking 8 hours. But what's your take on that? One superfood you will recommend, and the other is what does sleep mean to you?
So first, before answering that question, I'd like to thank Nupur and the moderators and the speakers for sharing such personal anecdotes and their life story. And I've never seen so many ophthalmologists suck in their tummy during a talk before. It's amazing. And I'm sure everybody's promised liquid diet tonight, so that's good. Breakfast, I think, as a father, I would say is the most important superfood for the day. Rituja showed us some nice photos of breakfast. But as a surgeon, I would say coffee. And as a Punjabi, I would say butter chicken. So breakfast with coffee and some protein. That would be my food that I would say is superfood. And sleep, I think, is very personal. I know people who go without sleep and they're achievers. And I know people who sleep all day and they're achievers. So it's very personal. I'm married to somebody who loves sleep, and I'm the opposite. So it works either which way. So whatever works for you in the end.
Thank you.
Thank you, panelists. So now we would move on to the next session, I, Me and YO. How harboring hobbies has helped me as a YO. So we have the first speaker, very young, dynamic YO, also a YOSI sociocultural team member, Dr. Richa Gupta. She's a glaucoma anterior segment surgeon trained at Shankar Netralaya, Chennai, founder director of Sunitram Eye Care, New Delhi. And she's going to be talking on, she's a very multifaceted, multi-talented personality. So she's going to be talking on Jill of all trades, mistress of some. So over to you, Dr. Richa.
Hi, a very good evening to you. I think this session should be made mandatory in all the conferences, right? So I'm Richa and I am a Jill of many trades. I was advised to talk about, the whole process of managing my interest. I have recorded a small video because I have on and off vocal cord edema, so I was not sure I would be able to talk today. So can we have the video? This sound also.
Namaskar, good afternoon. I am Dr. Richa Gupta, Director, Anterior Segment and Glaucoma Consultant at Sunitram Eye Care, Rohini, Delhi. It's a proud privilege to be a part of this special session beyond ophthalmology, and I sincerely thank the organizers for this platform, not only because it has brought people of various interests together, but more so because it celebrates who we are as a person apart from being ophthalmologists. I was always inclined towards art, but being the daughter of Dr. B.N. Gupta, a celebrated eye surgeon himself, I had pretty big shoes to fill up. So I worked hard throughout school, medical college, received the gold medal in post-graduation, pursued my glaucoma fellowship from Shankar Netralaya, Chennai, and have participated as organizer and faculty in many national and international forums. In the meantime, I got Dr. Abhishek, a vitreoretinal surgeon, as my life partner. During our first meet, the only thing I told him was that I wanted to pursue dance later on, sometime in my life, whenever I get time. That's how important it was for me. Had two lovely kids, and it was after my second born that I finally decided to do something about my passion for arts. I have been on stage many a times and enjoyed thoroughly performing various dance forms. But then I decided to take it up professionally. And now I am Diploma Kathak pursuing my bachelor's. Now, painting was something I always did as a hobby as a child. Vibrant colors always attracted me. And slowly I got serious about it and started exploring various mediums and creating larger pieces. It was my dream to cover the walls of my workplace and home with my artwork, and have been fortunate to have received awards for the same. Now I'm associated with an art studio in Delhi to take my passion to a higher level. Now, baking is said to be making love edible. Cooking has always been like a therapy for me, but baking and cakery intrigued me, and a couple of years back, I did a 1 day professional course on cake making, tried my hands on different types of cakes and decorations. I can never forget my daughter's first birthday when I made a 2 tiered cake of 9 kilos all by myself. It took me almost 6 hours to get the whole thing ready, but the smile on my kids' faces was so worth it. Another thing which I'm passionately involved in is fitness. I had gained a lot of weight after my eldest son, but 3 years back, after my second born, the need to become a better self took hold, and I plunged into self care and fitness, which included yoga, cardio, and weight training, all at home. And this is me 3 years and 25 kilos later. Mind you, my whole journey beyond ophthalmology started after I was 35 and after my second child was born. So I always tell my friends and colleagues that never stop learning, because life never stops teaching. It's just a mind block. And remember, courage to begin needs more power than the will to succeed. So go for it, conquer the world. It's never too late. Thank you so much.
Thank you. So, the hobbies, what do they mean to me? See, managing so many things, even today I'm learning something or the other every day. It has definitely made me more disciplined. It has taught me how to manage my time well. And it's amazing to get compliments from the patients, because I have all my art on the wall of my hospital. So that is really great. And the best part is getting connected to people like you. So thank you so much.
Thank you, Dr. Richa. Very, very inspiring, and you really are a Jill of all trades, that I must say, mistress of all. So we have our next speaker, Dr. Neha Mohan. So Dr. Neha Mohan Jain is a passionate surgeon, passionate teacher. Her special interest lies in uveitis. She is currently practicing, she's done a Vitreoretina fellowship from Eddie Prasad Eye Institute. She's currently practicing at Jain Eye Hospital and Laser Center at Drishtikon Eye Care, Shalimar Bagh, New Delhi. A very dear friend since my PG days. She was my senior. So she's going to be talking on the pursuit of happiness.
Yeah, hi. So I'm probably speaking for the first time on YOSI Forum, but the session that I'm attending is so enriching. So, sorry, it just got converted from Mac to the thing, so little bit. My topic is pursuit of happiness. So all of us are talking about fitness and food and perfect hobbies, and for what? Like Bhavya spoke, it's about happiness, right? So people who know me, they know me as a good academician. Few are my juniors, so they know me as a good surgeon. But my academic timeline was super smooth, and people would look up to me कि इससे ज़्यादा अच्छा क्या हो सकता है? अभी भी लोग देखते हैं, everything is flowing so well. But does that guarantee happiness? There are no guarantees, there are no warranties. So when you Google up the pursuit of happiness, you find so many books, which obviously means getting happiness is not the easy thing. But there's an interesting thing, that is the happiness of pursuit. Meaning thereby that when we pursue anything, little things, and we accomplish those tasks, so dopamine has been spoken about, gives you a sense of accomplishment, satisfaction, and happiness. So let's rewind few years back. I'm a very small town girl, unlike Piyush, I think he's left. So he was very privileged to learn all those interesting words I was listening, and squash and all that. I actually started listening after 25. So I was lazy, definitely, but there was total lack of opportunities. And I like Richa, I also wanted to learn Kathak, but there was no teacher in my place. The only thing I remember about myself, I was an ardent video gamer with those Game Boys in my hand my mamaji used to get from US, and I was not talented in anything practically, like Nupur. And so anytime, like in my life, I've kept meeting people who are so talented, and you think like, मैं क्यों नहीं हूँ यार? So then, my life like Richa also started after 35 because I was done with my fellowships. I had 2 kids, and now what? So unlike a lot of people, Ankita just mentioned, she gets up before the baby gets up. But for me, like Bhavya, sleep is too important. I cannot put in that much effort to wake early. So I actually anchored onto my children, and what they were learning, I was also learning, because they had the best of the teachers. It is like the millennial kids, and everything is online. So they would doodle, I would doodle. So everything you see is in 3, because it's they, me, and making the whole thing. So we learned some pencil shading, and we would do some crazy watercolors. And Kshitij has not come, right? He's there?
Yeah, he'll be showcasing his 3D art.
Yeah, so his 3D on LBO really inspired me, and we got down one day on a Sunday, and I told them that, wo bhaiya bahut acha banata hai, so let's do it. So we made these pyramids. And so me being a Pahadan, I was not afraid doing paragliding, but I am a non-swimmer. I just don't know how to swim. And, I often go doing scuba diving at different places, and I am not scared, So I think these little things really give me the kick. And whenever I am back in my theater, I feel कि मैंने ये कर लिया तो ये तो मुझे आता है, ये तो मैं कर ही लूँगी. So after we all have these phones, we all feel that, we are great photographers and we click well, but my photography kida is like long back. But now I've started cashing on it. So there was this NIDIC competition of some monochrome picture, and this picture is actually of my airport at Himachal. And I just clicked it in my phone and then put it in the competition, and this actually got me a free GoPro. So it was worth the deal. And my 2 children that are sitting there, they would always tell me, all the aunties make such nice cakes, 9 kg, I can't imagine. But why you don't cake? And I had that cooking akida, but I never did anything for it. So lockdown was the boon. I made these beautiful cakes, and they were very happy. Haan, my mama bhi ab banati hai. So dancing, yeah, I'm a very amateur dancer, not trained in any particular form, and I call it the bhangi dance that I do. But that does get me with these big people like Nupur on a common platform, and we are on YouTube. Even Gunjan is there in this one. So the latest achievement is, cycling. My papa would just put me on a mountain hill and say, go cycle, and I would fall. And I said, I don't want to take that much amount of pain just to learn cycling. And I was teaching my children a month back कि चलो cycle चलाएंगे, and they said, खुद को तो आपको आती नहीं है, मुझे कैसे सिखाओ? And I went to my Micah and just took their cycle, and it just started flowing, and they were like, wow. In 7 days, all 3 of us learned cycling. So these little joys are, you don't have to be perfect in anything, I feel. I am not a mistress of anything. Probably my work, that is what I'm passionate about, but rest, it's thoda har cheez ka, and it's a lot of fun, So we have to actively seek happiness. ऐसे नहीं बोलते कि work hard, party harder, because you have to work hard again. So, just keep that cycle going. So my now goals are to learn swimming at 40, that Piyush has been doing, I don't know since how many years. And, after watching Uncha, I was just sitting with Rohit, I want to go to Everest Base Camp. So let's see where it takes me. Thank you.
So I have known Dr. Neha for last more than 10 years, I guess. And she was a very strict senior. But, that time also her mantra was very clear with life. That when you work sincerely, and when it's time to, enjoy, you just detach from everything and then focus on the most important things in life. And wow, it was really great to connect with you.
That was a very happy presentation from a very happy mom. And so I'm a little emotional because I've known Dr. Neha. She's been a Ragini Aunt since PG days. So thank you, Dr. Neha, for sharing it right from your, direct dil se sharing this presentation with us. So moving on to the next presenter, we have Dr. Pooja Mehta. Dr. Pooja Mehta is, Dr. Pooja, can we? I'll just introduce her. So Dr. Pooja Mehta is a cataract and refractive consultant at CKI Hospital and Vision Eye Center. And she's going to be sharing her Mrs. India journey. So over to you, Dr.
Hi, thank you all so much for the invitation. I'm here to talk on my recent most adventure, my Mrs. India journey. Sadly, everyone sitting here in this room, all of us are stuck in a vicious cycle. The day we started our med school, the day we started our PG training, and everything started when we, after 12th standard, we used to, okay, we have to do this, next accomplishment is PG, next accomplishment is fellowship. So one after the other, all that we did was study. And then after fellowship, okay, we've done with fellowship, we need to get into a private practice or join somewhere. So it was just a vicious cycle. But so when does life beyond medicine start? I thankfully came across this book by Dr. Sharon Rom saying life beyond medicine in my internship days, and it just stuck with me and it stayed with me. And coincidentally, in the same time, I had gone to Johns Hopkins for my fellowship, and it just opened a full different world for me, because people do enjoy life beyond medicine, not after retirement, because you never know what year, what age, what might happen tomorrow. So why wait until retirement to enjoy and follow your passions? So this stuck with me, and I made sure I did an effort every day to enjoy my life apart from doing ophthalmology daily. If you don't do wild things while you're young, you'll never have nothing to smile about when you're old. This actually holds very, very true, and we must incorporate this in our life. Pageantry and being on stage was something that I always fantasized about. I always wondered what it would be to be on stage, what the drama is behind the scenes, how does it feel to get ready and be proper, trim and proper, be on stage. Is it just fancy things, or is it a lot of hard work? So I thought, once in a life you'll get an opportunity, I will definitely grab it. Thankfully that day did come to me. I am blessed with good genetics. I had a good height, so that was not an issue. My facial structures, I fit into the category, and it came across an opportunity, so I said yes, 100% I will grab it. And thankfully I was in the Mrs. category, because Miss category have to be less than 30, and I had just got married, so I fit all boxes. So I said I have to go ahead and do this. It did open a lot of box of opportunities. I didn't know what I didn't know what I didn't know. There are so many things that we take for granted. There are so many things you learn, attitude, how to groom yourself, how to walk, how to talk. There are so many different things that we just don't and oblivious about. It started with, of course, in initial round of interviews and screenings, and once you get through the auditions, it was just after COVID, so it was originally it started with Zoom calls, rigorous. Every day we had sessions, every evening. So I used to finish work, and then the evening I used to attend Zoom calls. They used to teach us about how to answer questions and ramp training and ramp walking and all of that, which led into 1 week of on-ground training. It also helped me unlock a lot of new skills like video editing, how to prepare for an interview, how to talk to patients. I could incorporate all these things in my day-to-day life as well. And of course, the growth of self-confidence was so good that you just felt like a new, different person every day. I then realized the importance of grooming, importance of taking care of yourself, not only for being presentable in front of others, but when you start looking good for your own self, you feel much better as the day go on. I then realized and came across this picture, which is so impactful, is this man who is sitting with his head inside the sand. He's oblivious to anything that is around him, just as how we are oblivious to anything other than ophthalmology and other than our routine mundane life. So as this origami of oblivion goes, it's time for all of us to explore the world, to follow our passion, to take time out in our routine mundane life for our activities, hobbies, be it however stupid and simple, but do make sure, because you never know, there's no tomorrow, there's no guarantee of tomorrow. Thankfully, I am so blessed to have a very, very supportive family, my in-laws as well as my parents, who stood by me and never ever said a no for anything that I wanted to achieve. Thank you so much.
Thank you so much, Pooja. Beautiful and inspiring talk for everyone. Thanks a lot. Now over to our panel. So Aditya, I have known you since our fellowship days, and I know how perfectionist you are. So how do you balance finishing a task on time and with perfection?
I think perfection is like you saw a lot of brilliant different examples here. So perfection doesn't come in one go. It You have to be okay with failure for that, and I think it comes naturally to everybody once you're okay with failure and keep trying till you get it there. But I like to say a couple of more things. That number one, with age you realize that it's okay to say no. So I think that's something we should all digest, that when you don't want to do a task, don't get involved, just say no. And that itself will make you a perfectionist. So that.
So true. Thank you so much, Aditya. I know you do not say no, you give it your best. Over to Kunjan. So now, how do you keep yourself groomed? And I know you are so beautiful. And how important it is to, as a yo, to grooming for a yo. How important is it?
So I would ask you first. How do you keep yourself groomed? Yeah.
No, Kunjan, please.
No, really. Like what aspects do you think? I think, yeah, of course.
So yeah, but then you have to find me in
Yeah,
that,
I'll-
right? So I think our patients today, I think Dr. Richa said it very beautifully. The compliments from the patient.
Yeah.
The patient feels very confident when they come to a very well-groomed, confident and smiley, positive doctor, right? So I practice a lot of cornea and ocular surface with very, very depressed and sad, unfortunate patients. So I think they are looking for that, glimmer of hope and positivity for their future. So I think that is what. And when I feel good myself, I think I can give that vibe to my patients.
Correct. So that's what it is. So I think that is what keeps us going. The mantra of life is just keep yourself happy, try to believe in yourself, and always try to look as what you want. I think I've learned from a lot of people. I've seen in a lot of conferences also. I used to see during my PG days. So I always wanted to do cornea. So a lot of people used to say, why do you want to do cornea? Why don't you go for it? I used to always say, cornea and refractive people are always the glamorous people of the Lord, because that's what keeps you on that platform. Sometimes you see people and you learn from them. You take an example that what do you want to be. So once I saw someone, I not named the person. I saw someone presenting very confidently. I said, "Wow, she's so good looking. She's maintaining herself, and she's doing such a good work in her, field." So what I feel is the people who say that you have to look nerd to look and work as a nerd.
So true.
So sometimes I don't know. I have been always a sports person in my school times. I used to pursue all the hobbies. I was a singer. So I don't know whether it was naturally coming from my childhood days or whether I've modified them later on. But I never wanted to be a nerd. That was for sure.
So lovely. Thank you, Gunjan. Ankita, I know Ankita, she's my college junior, wonderful dancer. So Ankita, how important is dance? I mean, your hobby for you, now your present hobby. So many years have gone by.
My dancing is your passion, ma'am, as I had seen you throughout my various times. Mine, I think, my hobby is basically yoga and meditation. I think it's a very busy life schedule. At like work, you are a doctor. At home, you are a mother, a wife, a daughter, and a daughter-in-law. And like juggling between these responsibilities is a tough task, and you should find time for yourself, for your hobby. I think it's very important, because if you keep on staying busy, satisfying other people, and don't give time to yourself, your personal liking, like your hobby, then it would affect your mental health. So basically, yoga and meditation, they help me stay calm and regenerate my body, to which helps me a lot. Like if it's in the heavy OPDs, basically, or basically fussy patients in the OPD, or basically in the OTs when you are in the stressful situation, it just helps you to calm down. And I think chanting Om mantra helps me, like when you focus on the Om and inhaling and exhaling just helps you concentrate. So basically, as a yo, it has helped me to stay focused on my work and keep the distractions at bay.
Thank you so much.
Thank you.
Thank you for a wonderful session. Just a little bit of credit. The health and wellness session was very beautifully designed by Dr. Rohit. So thank you, Dr. Rohit, for being a part of the YOSI socio-cultural team and designing this beautiful session. And thank you, Aditi, for beautifully co-moderating this entire session. I thoroughly enjoyed the session. Hope you all did too. With this, we conclude the session. We'll quickly hand over the mementos. I'll request Dr. Divakant to please give the mementos to the speakers of the first session. So Dr. Pooja Mehta, if you could just come and collect your memento, please. We can have some claps, please. Next, Dr. Rituja, birthday girl. She around? Rituja? Okay, she's not. She's outside. Can somebody just call her? Till then, Sunena, if you can just come. Dr. Sunena, Dr. Bhavya. Dr. Richa. Rituja has come, so Rituja and Bhavya, if you can just come to collect your mementos. Rituja, please collect your memento. And next, I'd like to invite Dr. Avnish to hand over the mementos for the next set of speakers. So we also have the birthday girl who will be sponsoring our YO night, is it?
Oh yeah, it's on me, guys.
Yeah. So Avnish, yeah. So Dr. Richa, if you can just come and collect your memento. Next speaker, Dr. Neha Mohan. And Dr. Pooja, Dr. Neha Mohan. Dr. Pooja for a very, very beautiful talk on her Mrs. India journey, very inspiring talk. Next, I would like to invite Dr. Neha Mohan to give the mementos to the panelists. Dr. Neha? Yeah. So, first panelist, Dr. Gunjan.
Please clap loudly for panelists.
Yes, please. Dr. Aditya. Dr. Ankita. And yeah. And last but not the least, me, moderator, Nupur.
I request Dr. Neha Mohan to felicitate Dr. Piyush Bansal.
and we can just, the panelist speakers can have a quick group photo before we sign off and get ready for the bio night. And we hope to have a great time tonight. We have a lot of games planned for you all. So I hope you all are wearing your badges. So we will start with dividing ourselves into teams. Okay, so there is a colored sticker on your badge. So I would want all the pink colors to come on the first table, please. So that team is Pink Panther. Quickly. The second team will be Red Rangers, followed by the Blue Bandits. The third, Orange Outliers. Okay.
And let me show you, we have lots of chocolates for you all. So the team which will organize first will get the prize. So Nupur, can you quickly announce the teams so that the team who will come first will get the prize?
We'll get a prize, and we have a lot of team games, and the winning team has a prize, as the entire team will get some prize. So looking forward. So quickly I'll announce the teams again. Pink Panthers, Blue Bandits, Orange Outliers, Red Rangers, Green Goblins.
Please find your teammates.
Quickly. The team which has a maximum winning this thing, no? I mean, जो सबसे पहले अपना team बना के बैठेगा, they will get chocolates.
So team pink.
Let's see who's there.
Blue. Team orange.
Pink, blue, green, red, orange, yellow.
Organize yourself.
Quickly.
As soon as you can. Red. Somebody is looking for team red.
Team Red Rangers.
And as soon as you are ready, please let us know. So your team orange.
Team Orange. Okay.
Looks like team orange is settled. They have settled.
And that also we can give it to all. We can give it to all of them. Team Blue also.
Yes, team blue. Please take your seats.
We'll give your chocolates. Pink. No one for pink. Green sit. I'm the organizer.
So now, people like Karan who are not finding their teammates, they can form their own team. Okay, so team
Yeah,
orange.
we can have
Here
that.
comes your prize.
Green and pink can go together. Green and pink can go together. What is that team? Red. Okay.
Green. And
Let
let me
you
remind
can
you
come
all.
here. It'll be easy to. Yeah, come here.
So this is for team orange. I don't know. Fine.
So team pink, orange, and green can go together here. Come.
Sir, I'll tell you.
Come here, na. It'll be easy.
Sir,
Come here.
towards
It'll
the
be
end,
easy.
I'll tell you why only chocolates.
Chocolate. Aarti.
So team orange has already got their gift. We are going to team blue, right?
Yes.
And please keep collecting the chocolates during the session. Towards the end, the person who has maximum chocolate or the wrappers will get a prize. Okay? So if you feel hungry, you're free to eat your chocolate.
So I think we have 3 teams right now. Which is this team? So red can join them. Yeah, red can join them.
Karan, shift here, na? Shift here. Yeah. Sorry. अब अवनीश ने डरा दिया है मुझे नहीं सॉरी So you are all set now. So I said this is team orange, that's team blue, and this is team red.
Team Red Rangers.
Team red. So we
So
have
Red Rangers, Blue Bandits, and Orange Outliers. ठीक है? So Aarti, over to you.
दिव्यकांत सर, मेरी एक आंख आप ही पे है आज, ठीक है? सारे चॉकलेट जा रहे हैं, वो निकल के आएंगे वापस. Okay, so you all are excited for this evening? Yes. Okay, so here we go with our first filler game. Till the time we arrange Antakshari round. So that.
Okay, so quickly join your teams.
So we assume that
What
you
is
all
this?
are
Blue
set.
Bandits.
So I'll be asking you for something, and the person that has that thing should come forward. The person who comes forward first will get the prize. Okay? So you all are with me for that? Yes? Maybe? No? Okay. So somebody sitting. So somebody sitting here has coin of 20, 10, 5, 2 and 1. All 5 coins. And I'm standing here, all 5 coins. No. Arrange and come, please. Please, I repeat, coin of 20, coin of 10, 5, 2 and 1.
हो गया
Wait. So I'll tell you, this was the first.
इसने मेरे हाथ से ले लिए
Okay, so there is time between all the 3 teams here.
ये प्रेसिडेंट सेक्रेटरी प्रेशराइज
We have Vaishno Devi ka coin also. If it adds.
That will come later. Okay, so this was the first question. This was the trial game, but I still will give prizes to all. But I still give 3 chocolates to all the 3 teams. So please keep collecting your chocolates. So Dr. Bavan sir, Dr. Divakar and Dr. Karan. I'm not going to disappoint anybody, but yes, next time I'll disqualify. But अरे बाप रे.
Sir, trial round.
Looks like Aditi is going to finish all of them. Okay, so now we move on to the next game. I'm happy that we all are very charged. Over to you, Nupur.
So we have the next round, Antakshari. It's sort of an Antakshari. It's been very, with a lot of hard work. Dr. Richa and Dr. Richa has prepared. Over to you, Richa.
Hi everyone. So this is like a small 1-minute game, but the teams will be playing this separately. Okay. Something like an Antakshari but with a twist. So what we have is we have a chit, we have a bowl with chits with different words written on it, and you will get 1 minute to sing as many songs as you can with that word in the mukhra. Is that clear? So for example, bowl is there.
The team who doesn't listen will have -10 straight away.
So you get +10 for each song that you sing. No negative marking. So, sorry? As many as you can, but then you have to... 2 lines, but these words should be there in that. Okay? So for example, if I give you Bhavara, can you think of any song? Raise your hands. Yeah.
तेरे लिए
आवारा भवरे जो हौले हौले गाए, फूलों की सन के हवाएं सनसनाए.
So you got the thing, right?
गुनगुना रहे हैं भंवरे खिल रही है कली कली.
Let's start with this team then.
Okay, so here are the chits. We will start with team red. Looks like team orange is going to get disqualified. So cheer up, guys. Okay, just a second. Who's going to? Okay.
No, you have to announce.
Dil.
So their word is dil. The time starts now.
ये दिल दीवाना दीवाना है, ये दिल तो पागल है, दिल दीवाना है,
दिल
तो पागल है,
मानता नहीं.
दिल देखो देखो दिल देखो देखो दिल देखो देखो जी. पागल है,
दिल दिया है,
ये दिल्ली है,
भी देंगे ए वतन तेरे. दिल दिया है, जान भी देंगे ए वतन तेरे. I'll stand it up. Please. दिल दिया है,
तेरे
दीवाना बिन सजना के माने ना.
6
दिल धड़कने दो.
Time up. 6 songs.
हम दिल दे चुके सर.
If you have to listen to this, they should start serving drinks. If you have to tolerate this.
So they
Okay, the
got
second
6 songs. We move to team
seniors.
Chalo, please check the time.
प्यार तो होना ही था, प्यार तो
प्यार प्यार प्यार
प्यार तो हो जाने दो. प्यार में खो जाने दो।
प्यार किया तो डरना क्या,
जब प्यार किया तो डरना क्या।
कोई चोरी
नहीं नहीं हाँ प्यार
प्यार प्यार करते करते तुम पे मरते मरते दिल ले दिया।
मैंने प्यार तुम्ही से किया है दुर्र, मैंने दिल भी तुम्ही दुर्र। ना करते प्यार तुम्ही से कर बैठे, करना था इनकार कर इकरार तुम्ही
ना
से
प्यार
करना था इनकार मगर इकरार तुम्ही से कर।
नाना करते प्यार तुम्ही से कर।
नाना करते प्यार तुम्ही से कर गई।
That is different song. नाना करते प्यार तुम्ही से।
हम है राही प्यार के, हमसे कुछ न बोलिए। हम है राही प्यार के।
Team Orange gets 7 points. So, okay, up to you.
आंखें तेरी कितनी हंसी
के इनका आशिक मैं हो गया हूँ, आंखों में तेरा ही चेहरा, धड़कन में तेरी ही याद।
आंखों में तेरी अजब सी अदाएं।
आंखों में इशारा हो गया।
आंख मारे ये लड़का, आंख मारे, आंख मारे ये लड़का,
अखियां मिलाए कभी
अखियां चुराए, क्या तूने किया जादू। आंखों में तेरी अजब, आंखों में
लड़की का माल देखो, अखियों से गोली मारे।
आंखों की गुस्ताखी
खुले हो या हो बंद, दीदार उनका होता है, कैसे कहूँ मैं हो यारा प्यार के। आंखों में इशारा हो गया, आंखों
Next team. Oh yeah. Do you want to have one more round of this? Do you want one more round? One more round of this, Antakshari. One more round. We'll have one more round, okay? One more round of Antakshari. Who is doing the honors this time?
दीवाना।
Time start. Time start. Time start. Time start.
ये दिल
दीवाने ने
दिल दीवाना बिन सजना के
बन सजना के जाने ना दीवाना।
बादल नहीं ये रेड है, ये टू लिख दे।
दीवाना दीवाने तो दीवाने हैं, दीवाने
चीनी बता रहा है।
दीवाना दीवाना हुआ दीवाना दिल दिल दीवाना दीवाना
दिल दीवाना बिन सजना के माने ना।
दीवाना 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 मैं प्रेम
दीवाने हुए हम तो दीवाने हुए यार।
6, 5, 4.
चांद चांद है ना।
चांदनी हो तुम, मुझे आया तो आया मुझे आ गली में आ चांदनी
चांद में शर्मा
चौदवी का चांद हो या
चंदा रे चंदा रे कभी तो जमी पर आ बैठे। चंदा रे कभी तो जमीन पे भी।
चांद ने कुछ कहा
रात ने कुछ सुना, चंदा रे चंदा।
चांद मेरा दिल हो गया ना? हाँ?
ओ मेरी चांदनी रंग भरे बादल से। और एक बोलो, और एक बोलो, और एक बोलो, और एक बोलो।
चंदा रे
चंदू के चाचा ने चंदू की चाची को
चंदे के
नाइन संतोष सर के आने से एक बार पावर अप हो गया टीम।
ये लोग बहुत सारे हैं, ये लोग बहुत सारे हैं। Not allowed.
रात कली एक ख्वाब में आई और गले
रात शबनमी भीगी चांदनी दूसरा कोई
है।
आज
रात अकेली है बुझ गए जिए
पाना ही क्या होना ही
बात बाकी
चांद ने कुछ कहा, रात ने कुछ
रात बाकी बात बाकी
ए रात जरा थम थम के गुजर।
रातों रानी फूले जैसा
ये रात भीगी लगता है चांद का बहुत शौक है।
सांवली सी रात है
भीगी भीगी रातों में मीठी मीठी बातों में इन्हीं बरसातों में कैसा
भीगी भीगी रातों में मुझे तड़पाओ ना।
भीगी भीगी रातों में हो गया।
जीरो दे दूंगी आपको। अरे लेवल सी ना, टोटल टीम करेंगे ना आप, तो ठीक हो रहा है।
So before we move on to the next game, so the scores are Team Red Ranger is at 130.
Team Orange Outliers. How much did you score? No, it was 160. Good job, bud. And our winners for the evening. Bandits are at 200 score. Great.
Before we move on to the next game, so we have our international dignitaries with us. So we'll request to sing some song of their language, and please. मैं बता दूंगी स्कोर शीट उसी के हाथ में स्कोर शीट उसी के हाथ में।
Two lines.
Next. As you wish. I cannot sing. Anything. Huh?
Please come there. Come.
当我们同在一起，在一起，在一起。当我们同在一起，其快乐无比。
I will sing something different.
very happy not discussing ophthalmology, right? Yes. Okay, so time to win a chocolate. Okay, please come forward.
Okay. The thing is that I cannot sing, but one thing is that when the COVID came, so we had a very good, inspiring poem. That's just I'm reciting it in Bangla. এ যাত্রায় বেঁচে গেলে চলে যাব মায়ের কোলে, কতদিন আমি দেখতে পাইনি মায়ের মুখখানি, এই চাহেনি প্রশান্তি জুড়াবে আমার বদনখানি. The meaning was that if I can survive in COVID, I will go to my mother and definitely I'll stay with her.
Thank you so much. Thanks a lot. Over to you,
Let's
Aarti.
move on. So anybody here carrying a passport with him or her should come forward. Passport. Passport. I did not say hard copy or soft copy. I just said passport.
The first one to reach, Aarti. The first one to reach.
I just said passport. No. She doesn't have it. She's now checking. Yes, she gets it.
So this is... No. You have to show it.
Okay, so he was also looking for
Yes. We'll move on to the next game. Yeah. So moving on to the next game. Pictionary. Very simple. One person from the team has to come. There are chits. You have to pick up a chit. It is some personality. Okay, famous personality. You have to draw and make your team guess. Draw anything related. What? Okay. So this time we'll... Okay, wait.
We'll start with team blue.
We'll start with team... No, so we'll start with team blue. Second team. Okay, and we give you 1 minute to discuss who amongst us you can strategize and discuss, and then one team has to come. Okay. Team blue, be ready. You have 1 minute. One of you has to come up. Okay. Yeah.
Team blue, your time will up soon. Please come forward.
So Naina, are you ready with the time when we tell you? So can you introduce yourself?
I'm Dr. Gunjan and I'm a blue team member.
So what is your... इसका क्या है?
You people are becoming too demanding. Team blue will give you minus points. Minus 40, right?
Okay, so team blue, your time starts now.
आपका टर्न आना बचा है, ठीक है?
No alphabets.
KFC.
Aeroplane.
Computer, what is that?
Burger, namaste. Burger. Namaste.
Time up, time up, time up. +5, +5, +5. Done. Julia Roberts. Julia Roberts. आधा पॉइंट दिया है ना, आधा पॉइंट दिया है. डिसीजन इज फाइनल. डिसीजन इज फाइनल. चलो टीम ऑरेंज आउटलायर्स हु विल कम.
Okay.
Time starts. +10. Orange outliers +10. आ जाओ. Team Red Rangers, who's going to come? Time starts now. +10 to Team Red Rangers. We'll have one more round, one more round, one more round, one more round, one more round. Team Blue Bandit, Team Blue Bandit, Blue Bandits. Come, who's coming? Quickly, quickly. Quickly, quickly, quickly. Okay, Blue Bandit, time starts now.
Body.
+10.
Awesome.
Team Orange Outliers, who's coming? No, same people cannot come again. Different people have to come. Okay, done. Next. +5. सर ने बोला, मेरे सामने बोला. सर ने मेरे सामने बोला. सर ने मेरे सामने बोला. +5. +5 ही दिया है ना. Decision is final. Please. Thank you. Thank you. Time starts now. No actions, huh? No actions. No actions. No actions. Draw, draw, draw. +10. +10. So till Richa is collating the scores, Aarti, you can.
So, ophthalmologist here, please relax, take a deep breath. That game is over now. And we are looking for more mics. Nupur, if somebody has, please bring. I won't give them that person a chocolate, but still. Don't worry, I'm not going to give a chocolate for that, but still, you can bring. So here comes the next filler game. Till the time we get ready for our next big game. So, anybody here carrying foreign currency can come forward. No, you have to give me.
Kshitij, are you there?
Okay, fine. So all three of you get the chocolate. So Nilesh, Dr. Akshay, and Dipanshu. मुझे पता चल गया है किसके वॉलेट में कितनी करेंसी है अभी. Okay. So are we ready for the next game?
So we have the score.
So I think, yeah, we can have the, yeah.
We have the score for the Pictionary round. Team Blue Bandits, Orange Outliers have scored 15. Okay, and you have scored 20. So now the cumulative score is Blue Bandits 215. You are in 175 and you're 150.
So we'll take a little break from the games, and we have a couple of people have prepared something. So we have Dr. Kshitij Raizada. He'll be presenting a small video of his 3D art that he does. So over to you, Dr. Kshitij.
Good evening, everybody.
So sit back and enjoy.
I have been harboring this interest of drawing 3D illusions on paper for quite some time. So I have compiled them into a video. All of these are handmade drawings on paper. So can we please have the video? I hope you enjoy them.
Are you ready for it?
So I hope you enjoyed it. Thank you so much.
I think that was a wonderful, wonderful artwork. Minus 50.
Amazing, amazing, amazing. So here comes the next question. Anybody here who has a hole in his socks can come forward. Please, maybe you can remove your shoes and check कहीं hole है तो नहीं? Yeah! So I gave you all a clue. You can see whether you have a hole. Nupur, are you ready?
So we move on to another very interesting performance. We have Dr. Bhavya Gokani. I'd like to first, he is going to do a stand-up comedy act for us. He's been a TEDx speaker. And Dr. Bhavya, you can just introduce yourself first and then go ahead.
मैं डॉक्टर भव्या हूँ. मैं कभी कभी थोड़ी बकर कर लेता हूँ. सो या माय नेम इज भव्या और मैं आई एम बेसिकली गुजराती. और एक गुजराती अगर दिल्ली में आकर परफॉर्म कर रहा है तो आई एम श्योर वो अपलोड होगा ही. जय श्री राम. गुजरात हैज अल्कोहल बैन. आई ऑलवेज हर्ड इट, नेवर एक्सपीरियंस्ड इट दो. सो आई टेक यू थ्रू आउट माई लाइफ. ये कहानी है सेकेंड स्टैंडर्ड की. मैं बहुत सा ट्रॉमेटिक बच्चा हुआ करता था एंड इट्स अनलीस्ड. मैं बहुत ट्रॉमेटिक बच्चा हुआ करता था. हिंदी का पीरियड चल रहा था और एकदम जोर से टट्टी आई. एकदम जोर से, मतलब जोर से. मैंने उंगली ऊंची करके मैम को बोला, मैडम मैडम कैन आई प्लीज गो टू टॉयलेट. मैडम ने बोला, बेटा यू कैन बट यू मे नॉट. मैं बोला, तू साली हिंदी टीचर है, तू कहे ग्रामर करेक्ट कर रही. और जोर से प्रेशर आई. मैंने उंगली ऊंची करके बोला, मैडम कैन आई प्लीज 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 गो टू टॉयलेट. सी लाइक यू कैन बट यू मे नॉट. फाइनली इतनी ज्यादा प्रेशर हुआ. मैंने बोला, मैडम कैन आई प्लीज गो टू टॉयलेट. यू कैन बट यू मे नॉट. मैं क्लास में हक दिया. हा मजा आ गया एकदम. फिर मैंने मैडम को बोला, मैडम नाउ कैन आई प्लीज गो टू टॉयलेट. शी इज लाइक नो, नाउ यू कम टू प्रिंसिपल. तो मेरे को मैडम प्रिंसिपल के पास ले गई. वो कॉन्वेंट स्कूल था, उनके पास लॉन्ड्री में एक्स्ट्रा पेयर ऑफ क्लोथ्स थे. तो मेरे को लड़की के कपड़े पहना दिए और स्कर्ट पहनाकर घर भेज दिया. हा क्या खुला खुला लग रहा था. मैं एकदम टहलते टहलते घर पहुंचा. मैंने मम्मी पापा को देखा. उन्होंने बोला, ये क्या पहन के आ गया. मैंने बोला, यू कैन नॉट कमेंट ऑन द साइज ऑफ माई क्लोथ्स. तब से थोड़ी थोड़ी दिक्कत आने लगी. A huge round of applause or a cheer if you guys have heard that famous song from Karishma Kapoor, sexy 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 मुझे लोग बोले. 7th स्टैंडर्ड की सीन है. ड्राइंग रूम में टीवी देख रहे हैं सब लोग. मेरे पापा, मैं और मेरी मम्मी. And the song flashes, sexy 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 मुझे लोग बोले. A curious kid in me, I asked my mom, मम्मी सेक्सी मतलब? एंड शी गिव्स मी द मोस्ट साइंटिफिक आंसर एवर पॉसिबल. बेटा जो छोटे छोटे कपड़े पहनते हैं ना, उसे सेक्सी बोलते हैं. बाजू में पापा लुंगी बनियन में बैठे थे. सेक्सी? मम्मी शर्मा गई, अभी नहीं. थोड़ा और बड़ा हुआ, मैं मेडिकल स्कूल में गया. मेरे क्लास में एक खतरनाक बच्चा था, जिमी करके. जिमी ने दुनिया के सारे कांड कर लिए. जिमी ने दुनिया के सारे कांड कर लिए. ईएनटी का प्रैक्टिकल चल रहा था. जिमी को फैकल्टी ने पूछा, जिमी जिमी कैन यू प्लीज एलिसिट द ट्यूनिंग फॉर्क टेस्ट. जिमी ने ट्यूनिंग फॉर्क लिया और पेशेंट के सर पे मार दिया. I think that eventually as I grew, I started getting exposed to a better world. The entire matrimony started getting explored for me. My parents, they said कि बेटा अब तू शादी कर ले. So I came up with the most innovative solution that I am fat and I want to lose weight. So पापा ने मेरे को फिटबिट खरीद के दे दिया. एक महीने में 10 किलोमीटर दौड़ा हर रोज 10 किलोमीटर दौड़ा. 1 kg भी कम नहीं हुआ. Then I started wearing Fitbit on my left hand. इस जोक में सिर्फ लड़कों की लाफ आती है. That exactly explains the biological basis of orgasm. I grew a little older. How many of you guys have ever dated a dentist in your life? Has anybody dated? You have dated a dentist. How is your experience, bro? Oh, she's your wife. Oh, so no, किसी ने तो और कोई है जिसने डेंटिस्ट को डेट किया और उसका ब्रेकअप हो चुका है? ये किसी ने जोक नहीं सुना? अक्षय सर, ये आपका जोक नहीं है बिल्कुल, ठीक है? बिल्कुल नहीं है. I dated a dentist almost for 1 year. And I broke up with her because I started feeling that whenever I used to visit her, I used to feel like a prostitute. Let me explain. Unleashed है, ignore. एक तो वो पहले अपनी चेंबर में बुलाते हैं, एक शेडी सी कुर्सी पर सुलाते हैं, फिर बोलते हैं मुंह खोलो. You open your mouth wide. They insert the sharpest tool in your mouth and you start moaning. Oh, they start looking for cavities. They ask you to gargle that shit out. And finally they get paid for it. Sorry, bro. Things started getting serious. I got married and it has been... Initially, before I got married, I used to think that my life is funny. After I got married, I realized that my life is funny. I went to a honeymoon. I went on the honeymoon to Phuket with my wife. How many of you guys have been to Phuket? Most of you guys have been. Not with your wives, of course. तो हम लोगों ने ये स्कूबा करके एक मस्त वाली एक्टिविटी की. तो उन लोगों ने स्कूबा की हमें बहुत अच्छी वाली ट्रेनिंग दी. They were like कि ऐसे करोगे, that means आप ऐसे करोगे मतलब down, and you do this मतलब there is some risk. So I was down under the sea, and Sakshi started waving ऐसा करके. मेरी फट गई. मैंने सोचा अभी हनीमून हुआ है, बीवी मर गई तो लोचा हो जाएगा. मैं तुरंत एसेंट करके बाहर निकल गया. मैंने बोला क्या हुआ था तुम्हें? ऐसे नहीं बोला मैंने पूछा बीबी क्या हुआ था तुम्हें? कुछ शार्क दिखी क्या? शायद बाबू पानी में मेरे नेल पेंट कितने अच्छे लग रहे थे. So occasionally I do smoke occasionally and my wife is not aware of that. तो एक बार हम लोग मूवी देखने गए और नो वीडियोस प्लीज. तो एक बार हम लोग मूवी देखने गए. तो पता नहीं इंटरमिशन में क्या हुआ कि मेरी वाइफ को सडनली क्रेविंग आई एंड शी इज लाइक भव्या एक सिगरेट लेकर आना. तो मैं विस्पर लेके पहुंच गया क्योंकि हीरोगिरी सिगरेट में नहीं पैड देने में है. तो अब जब भी लौंडे इकट्ठा होते हैं और कोई मुझसे सिगरेट मांगता है मैं पैड पकड़ा देता हूँ कि ये ले भाई. तो एक बार ऐसे ही सब दोस्त लोग बैठे हुए थे और किसी ने मुझसे सिगरेट मांगी. बोला भव्या मुझे सिगरेट दे दे. तो मैंने पकड़ के उसको विस्पर दे दिया. तो उसने बोला भव्या कैन आई प्लीज हैव अ सिगरेट? आई सेड यू कैन बट यू मे नॉट. थैंक यू सो मच. दैट्स माय टाइम.
So thank you so much. I'm sure everybody is awake and active here. So let me ask another question to you all. Are you ready for it? Yes, no, maybe. So, everybody is wearing wristwatch here. So, people those who are wearing wristwatches, the brand which you are wearing, try to match it with some